Are we ready to start? Wonderful. Good morning. I'd like to call this hearing to order. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Thursday, March 2nd, 2023, and the time is 9:30. We are holding a hybrid meeting via the Zoom internet platform. I'm also live in room 400 of the council building. This meeting is being broadcast live on cable television channel 12 and on my YouTube page. Today, we will hear public witnesses and government testimony for the DC Department of Health. DC Health promotes health, wellness, and equity across the district and protects the safety of residents, visitors, and those doing business in our nation's capital. With almost 750 FTEs, DC Health is organized into 7 administration and offices, including Agency Management Program, Community Health Administration, Health Emergency Preparedness and Response Administration, the Center for Policy Planning and Evaluation, HIV/AIDS, Hepatitis, STDs, and TB Administration, Health Regulation and Licensing Administration, and the Office of Health Equity. The committee sent written pre-hearing questions to DC Health, and we will reference those materials today. If anyone watching would like to see those materials, they can be found online on the council website at dccouncil.gov. I can't see the screen. Are any of my colleagues here? What's that? No, I know I can't see. Okay. Before we get started, I'd like to review the testimony guidelines for public witnesses. Given the large number of public witnesses we have today, all witnesses will have 3 minutes to testify. If your testimony is longer than that, you feel free to submit any written testimony that you would like. We have a clock that will begin counting you down when you start speaking. I'll give you a nudge when your time has expired. To make sure we get to everyone, your name will only be called once when it appears on the list. If you're not able to available when your name is called, we are going to welcome you to submit written testimony. We will also be doing 8-person panels today rather than our normal 5. Okay, so with that, I will call up the first panel of witnesses. Christina Burke, Carrie Stuffless, Jacqueline Bowens, William Dietz, Mark Miller, Leah Castells, Melissa Millar, and Ashley Matajik. Apologies, Ashley. I know I butchered your last name. Awesome, thank you. Okay, don't see Christina, but we will keep it moving. So Carrie? Good morning.
Good morning. You ready for me to get started?
Yes, go ahead.
Okay, good morning, Chairman Henderson and members of the committee. I'm Carrie Stoltzfus, the Executive Director of Food and Friends. I'd like to begin by thanking you for your continued support of our mission to improve the lives and health of DC residents living with serious illnesses such as cancer, kidney failure, HIV/AIDS, and others that limit their ability to provide their own nourishment. Your support, as well as the time you spent volunteering with us, shows your neighbors your commitment to their well-being. We're also grateful for our partnership with Dr. Lewis and the staff of DC Health. You've helped us provide more than 799,000 medically tailored meals free of charge to more than 1,800 district residents in the past year. Food and Friends is the only community-based organization in our region providing home-delivered medically tailored meals, or MTM, and medical nutrition therapy. Last year, we saw a 29% increase in referrals to Food and Friends. We've heard from our healthcare partners that their patients are returning to care with pandemic-delayed diagnoses of severe illnesses. That means that more people are finding themselves in need of Food and Friends, and higher food costs due to inflation only add to their need. Looking to the FY24 budget, we are respectfully requesting a $310,000 increase to our Community Health Administration grant to help us meet these needs. And these funds will help us keep pace with increased need and enable us to provide an additional 55,000 meals in FY24. We rely on philanthropy and healthcare partnerships in addition to public funds from federal, state, and local sources. We're committed to maintaining a diverse revenue stream, and our support from CHA is a key part of our ability to carry out our work. Investing in Food and Friends is a good value. For each dollar we receive from the district, we raise 6.5 from other sources, and our support from DC Health makes that possible. Over 44% of our meals in DC go to neighbors in wards 7 and 8, addressing geographic social determinants of health, such as food security, and we also reduce the cost of health care. The American Diabetes Association reports that the illness costs $700 million each year for the over 48,000 adults in DC with diagnosed diabetes. Those living with complex conditions like diabetes who receive MTM experience 50% fewer inpatient admissions and 70% fewer emergency department visits than similar patients not enrolled in such a program. And new research this year estimates that if all eligible patients received access to meals with nutrition standards such as ours, in just the first year of service, over 1.5 million hospitalizations could be avoided for a net cost savings of $13.6 billion. All that to say, our service makes a difference. Food and Friends also enthusiastically endorses the other requests presented by the Fair Food for All DC Coalition, which is attached to my written testimony. Our emergency food providers have played a crucial role for our community, and the city's investment in these programs has improved the health of DC residents. We will continue to meet the challenges of feeding those who are medically vulnerable. We appreciate the council's support of our mission, and we look forward to a continued partnership. Thank you.
Thank you, Carrie. Ms. Bowens?
Good morning, Chairman Henderson, and thank you for the opportunity to testify. I'm Jacqueline Bowens, the President and CEO of the DC Hospital Association. I will be joined later on in the panel. You'll hear from other members of DCHA, Hassan Zia from Sibley, and Dr. Kurt Newman from Children's National. Again, I appreciate this opportunity. DC Health and the district's hospitals have been partners and have had a long history of collaboration as they both endeavor to improve the health of our community. This has not changed during the pandemic as we've continued to implement best practices that protect the residents of the district and the communities, as well as in our health facility. Under Dr. Lewis's tenure as interim director, this is carried on. Our hospitals have had a unique relationships with DC Health because the department is both as a collaborator and regulator, and we don't shy away from either role. Each year, the Department of Health conducts unannounced surveys of our facilities, as well as additional visits to investigate any complaints. This work ensures that health facilities are meeting the needs of their patients in a safe manner, as well as providing quality care. In the area of collaboration, we're working closely with the department on improving maternal and infant mortality, which Dr. Zia will cover in his testimony. District hospitals are also working collaboratively with the Community Health Administration to model best practices for food and nutrition. Through the Healthy Hospital Initiative, hospitals are reducing the availability of sugared beverages within their facility, as well as reducing the sodium and saturated fats in meals. This is translating through many areas and supported by Care First, which saw a number of participants in a great initiative called Healthy Steps, where we saw over 5 million steps in 4 weeks. We're also looking forward to our annual cooking competition in the coming months that will require the opportunity for our chefs to produce meals entirely out of plant-based ingredients. Finally, we want to thank the department, in particular Senior Deputy Director Patrick Ashley, for his continued collaboration in the emergency preparedness space. During our last program budget period, the department invested over $200,000 in a supply chain initiative, which allowed our hospitals, skilled nursing facilities, and FQHCs and home health agencies to purchase over $120,000 in PPE supplies. We also kicked off our mutual aid radio system, which will move from HMARS to the Hospital Association's analog systems to the digital radio system. Hopefully this will be completed by the end of the year. And there are a number of initiatives that we've worked collaboratively on. Again, thank you for allowing me to testify, and I look forward to any questions, and there'll be more detailed testimony from my board members later on in the panel. Thank you.
Thank you. William Dietz.
Good morning, Chairperson Henderson, members and staff. I'm Bill Dietz, a pediatrician and chair of the Redstone Center at the George Washington University School of Public Health. Prior to GW, I was the director of the Division of Nutrition, Physical Activity, and Obesity at the CDC for 16 years. Today, I'd like to discuss healthy school meals and increasing physical activity as key components of DC Health's chronic disease prevention strategy. The 2010 Healthy Schools Act set some of the most ambitious nutrition standards for school meals in the country. However, the HSA still has not achieved all of its aims. DCPS still works with a huge vendor, Sodexo, to provide most of its meals. We still hear serious concerns from the community regarding inequitable variations in meal quality across schools. Students do not have real access to water, and excellent programs established by the legislation, such as school gardens, environmental literacy, and nutrition education, do not have sustainable funding sources. We think the time is right to update the HSA. We recommend that your committee convene a new working group to reassess the HSA and identify ways to improve meal quality, health, and wellness, including whether the district should shift to self-operated food services, how to ensure that vendors are providing nutritious, high-quality meals, increasing water access for students, expanding hands-on food education for all students, and providing sustainable and reliable funding for food and garden programs. This working group should collaborate with the Healthy Youth in Schools Commission. Although the HSA also addressed the need for physical activity, more attention has been paid to foods than to fitness. The same is true of the Nutrition and Physical Fitness Bureau. However, physical activity is a wonder drug with multiple positive effects on mental health, depression, and the prevention and mitigation of chronic diseases, including obesity, type 2 diabetes, and cardiovascular disease. Nonetheless, 38% of adults in Ward 8 report no physical activity, compared to 6% in Ward 3. Inequities in physical activity are driven by the lack of safe and accessible infrastructure, such as safe neighborhoods, safe sidewalks, bike lanes, and accessible trails. Walking infrastructure is a proven strategy to address health disparities for socially and economically disadvantaged populations that face higher rates of chronic disease and lower physical activity levels. Street safety efforts should ensure that all DC residents can safely navigate the city using all transportation modes, and particularly modes that promote physical activity, such as walking, biking, and public transit. Access to parks and green space increases physical activity. However, the district is limited in its ability to create an equitable and integrated park system that promotes health for all DC residents, because 90% of our parkland belongs to the National Park Service. We've just completed a year-long research project to better understand how to address the barriers that the National Park Service imposes on the district, and look forward to sharing our findings with the committee. Thank you for the opportunity to testify today, and I welcome any questions that you might have.
Thank you. Mark Miller.
Good morning, Chair Henderson. Good to see you again, members of the Committee on Health. My name is Mark Miller. I'm the DC Long-Term Care Ombudsman with Legal Counsel for the Elderly. You have our full testimony, so I'm, in the interest of time, just going to talk about two particular topics that I want to make the committee aware of. One is the booster rate for nursing home residents and staff, and the other is the release of the long-term care services and support study. First, with regards to boosters, there's certainly no question that the initial vaccination of residents and all staff have added a layer of protection and significantly moderated the risks of COVID transmission. We applaud DC Health's and the provider community's efforts on behalf of residents and staff to access boosters. Unfortunately, over the past several months, these efforts have waned. And as we know, COVID is not finished, even though the public health emergency is scheduled to end shortly. We really can't let our guard down here. Hundreds of people every day continue to die of COVID, and nursing home residents are still amongst our most vulnerable populations. As of February 5th, in the district, only 65.5% of district nursing home residents are up to date on their boosters, and only 43% of staff are up to date. Therefore, we recommend that HRLA work with nursing homes to ensure there's a plan for continuing to provide all residents and staff with opportunities to access boosters for the safety of everyone. Second, the study of long-term care services and supports needs to be released. In 2019, with the support of this committee, the council passed and funded the Study of Long-Term Care Facilities and Long-Term Care Services Act. Given the shortage of nursing home beds and the lack of affordable assisted living, this study is a critical first step to identify and address the future long-term care needs of district residents. The study has been completed for more than a year, but hasn't been released. I've talked briefly with Dr. Lewis about this, so I'm hopeful. But the information and recommendations that it includes are going to be critical for many of the discussions we're having moving forward about future needs and services, and also the workforce that will be needed to provide those services. We respectfully ask the committee to request DC Health to release the study without further delay. And finally, just I want to recognize Dr. Lewis for her work on behalf of district residents of long-term care facilities. She certainly has been a compassionate and intelligent and accessible leader. It's hard for me to say this. I think she's the right person at the right time in the right position. Really would love her to have her back at HRLA, but I think she's doing a great job where she's at. And with that, I'll end my testimony and happy to answer any questions.
Thank you, Mr. Miller. Leah?
Good morning, Chairperson Henderson. My name is Leah Kaslas. I'm a policy attorney at Children's Law Center and a resident of the district. I'm testifying today on behalf of the Children's Law Center. Our more than 100 staff work with DC children and families, community partners, and pro bono attorneys toward a future where every child can grow with a strong foundation of family, health, and education, and live in a world free from poverty, trauma, racism, and other forms of oppression. I know this has been a busy performance oversight season. Thank you for your attention to the many issue areas impacting DC children and their families. I'm happy to testify today alongside the many partners in this work, many of whom will be speaking to two specific programs under DC Health, Healthy Steps and Home Visiting. Healthy Steps and Home Visiting are critical to the array of services that provide support for families and play a role in child abuse and neglect prevention. We know from our work that children have the best trajectories when their parents and caregivers are fully supported and equipped to meet their needs. However, across both Healthy Steps and Home Visiting, there have been continuous strain on the workforce that provides these important services. The district has made significant investments in Healthy Steps program. In January 2023, DC Health released an RFA for a 6th locally funded Healthy Steps site. This expansion is needed and welcome. However, the struggling behavioral health workforce has delayed hiring for existing Healthy Steps sites. DC Health and this committee have a significant role to play in addressing the continued workforce shortage of behavioral health providers. Throughout this season, we have provided several recommendations to improving the behavioral health workforce. Most recently, my colleague Amber Reiki testified regarding recommendations for the Board of Social Work. Additionally, we have testified that Healthy Steps be included in the ongoing DHCF Medicaid rate study. My written testimony provides further recommendations. As for Home Visiting, the grants for this immensely valuable program have not been adjusted for inflation since 2019. Additionally, the grant amounts continue to fluctuate. Specifically, we asked this committee to clarify the specific cuts with DC Health in the FY23 budget. There is some confusion in the reported cut in performance oversight responses and the actual cut that was experienced by home visiting programs. Many home visitors report having highly rewarding relationships with the families they work with and enjoy the work they do, but do not see longevity in a career in home visiting. Boosting program funding and making consistent, as well as standardizing home visitor wages, will strengthen the home visiting profession. We hope the council, this committee, DC Health will work together to find and fund innovative solutions that will allow these programs to continue with fidelity and excellence. We appreciate this council's continued commitment to the district's youngest children and hope we can continue to work to build a strong system that supports children and their families from pregnancy and onward. Thank you for the opportunity to testify. I look forward to any questions.
Thank you. Melissa Millar.
Good morning, Chairperson Henderson and members and staff of the Committee on Health. I'm Melissa Millar, consultant to the Coalition for Nonprofit Equity, a coalition of approximately 1,000 DC nonprofits advocating for full funding and implementation of the Nonprofit Fair Compensation Act. Last month, I testified on this law, effective since March 2021, that seeks to ensure consistent application of overhead or indirect cost rates on grants and contracts made by DC government agencies to nonprofits. This law allows 5 ways to calculate and use an indirect cost rate in negotiations with district government, is an important step in right-sizing and adequately compensating nonprofit partners for their actual costs of doing business in and with DC and elevating nonprofits' financial well-being. Implementation of this law remains problematic, with DC Health being no exception. We're spot checking FY23 solicitations for inclusion of reference to the law and for standard language about potential nonprofit awardees calculating their indirect cost rate and negotiating or renegotiating payments with the district. We have found 3 FY23 solicitations, 1 a grant for early childhood home visiting, 1 a grant for HIV prevention activities, and 1 a grant for Healthy Steps, none of which included all the ways a nonprofit could effectuate a rate or name the act, and perhaps most egregiously, sought to cap indirect rates at 10% versus what the law mandates, which is 10% being the floor on covered costs, not the ceiling. The direct language from each solicitation notes, quote, grant awardees will be allowed to budget for indirect costs of no more than 10% of total direct costs, unquote. We will note that the home visiting solicitation at least mentioned the possibility of an awardee having a federally negotiated indirect cost rate or a NICRA in the mandatory disclosures section, but did not offer an opportunity for a nonprofit applicant to provide, let alone use their rate, only to provide the date on which the rate was established and with what federal agency. To address our concerns, the coalition has been meeting and working with the executive. The mayor's budget director met with us last month. She acknowledged a mistake by the government at the outset of the law for failing to properly assess its overall cost, which contributed to a significant delay in the law's implementation. The executive informed the coalition it will be building out a database of contract costs, awardees, and indirect cost rates to help track and compare rates and clarify funding gaps and needs. This database will likely take into the summer to build and will not directly contribute to assessing budget formulations for FY24. However, as some agencies have more budget flexibility than others, we would request DC Health to reprogram funds as needed to cover indirect costs for nonprofits. We are disheartened to see DC Health seeking to limit indirect costs in its solicitations and further failing to name the act and the ways it provides for nonprofits to calculate and use their indirect cost rate with the district. Finally, I would like to highlight a need for additional funding and oversight, and we do ask the council to hold agency heads accountable to comply with data requests for the upcoming cost study that the executive will be doing, and recommend that where agencies have flexibility to reprogram funds to cover indirect cost gaps and to ensure agency general counsel's awareness of the law to ensure that agencies do comply. Thank you for the opportunity to testify.
Thank you. Ashley?
Good morning. Thank you, Councilmember Henderson and members of the Committee on Health for allowing me to speak with you today about COVID relief and education services. My name is Ashley Mateka, and I'm the Director of Community Wellness at Latin American Youth Center, or LAYC. LAYC has been an important part of the district and region for over 50 years. We serve over 4,000 youth and families annually and operate programs in the district and Prince George's and Montgomery counties. LAYC's COVID relief and education services serve residents from youth to adults in Washington, D.C. metro area by disseminating COVID-19 information and personal protective equipment, hosting COVID-19 vaccine clinics, and collaborating with partner organizations in wards 4, 5, 7, and 8. COVID-19 information is shared via flyers at outreach events and on social media. Topics include where to get COVID-19 rapid and PCR tests done by ward, symptoms for COVID-19, and how to properly count your quarantine days. LOIC also hosted 2 vaccine clinics per month in partnership with Giant and the Department of Health. Approximately 236 residents were served in our vaccine clinics from April 22 to present. At LOIC's Summer Youth Employment Program, our COVID-19 efforts supported 42 at-home COVID-19 tests. 5 youth were sent home who showed COVID-19 symptoms, and contact tracing was performed as needed. These efforts prevented a COVID-19 outbreak at LOIC. We received this anonymous feedback from one of our youth. LOIC's team was very informative and allocated me resources regarding my potential COVID-19 exposure quickly and safely. I was given instructions and a team member checked back with me. All of my questions and concerns were answered promptly. It is important to note that LOIC COVID relief also included the distribution of over 12,000 bags of shelf-stable food to youth and families experiencing food insecurity. As we transition out of the public health emergency, LOIC continues to be a trusted source for health information and resources. Councilmember Henderson and members of the Committee on Health, I ask you to continue supporting the health and wellness of our young people in the district. Thank you for your time. I'm happy to answer any questions you may have.
Thank you. And thank you to this panel of witnesses who all brought up very interesting points. I'm just going to make a couple of comments and then we'll move on to the next panel. Mr. Miller, it's good to see you again. Thank you so much for being so engaged in this performance oversight season. The long-term care services report. Now, this is yet another report that I'm hearing of where it's done, it's in draft form, it's under review, but it still hasn't yet been released to the public. And yet the information can be very valuable in terms of what happens from an accountability oversight, but also how we do our goals going forward. When you talk to DC Health, did they indicate where it was in the process?
I think currently Dr. Lewis has it on her desk. And obviously she moved from HRLA to her current interim director position. It was hung up in review for a long time though, but it has been done for more than a year. So we're just anxious to get it. And when I last talked with her, I reiterated how important it is, because I think there's information in there, maybe some recommendations that we certainly could use in the discussions moving forward on the services that we're going to be needing in the district. So, and I think it's kind of a side note, but, we have 1,000 residents of the district that are living in nursing homes outside of the district because there's not enough, not sufficient services. So we really need this report because we think it's going to tell us some things about, okay, how do we move forward? What are the needs going to be in the near and long-term future? So the sooner we can get it, I think the better, because I think it'll inform not just conversations I have, but conversations that a lot of other organizations, here in the district are currently having.
No, I totally understand. And I think we had a little bit of this conversation with healthcare finance. I'm not sure if on that part when we're talking about insurance coverage for long-term care facilities and nursing homes, and whether or not we have enough facilities who are accepting Medicaid to be able to bring those folks into the fold. So I will follow up on that. I also have a long list. I'm going to be sending the city administrator as well of reports across jurisdictions to figure out where those lie. So thank you for that.
Thank you. I really appreciate it.
Dr. Dietz, thank you so much for being here and for your advocacy. When I was a staffer at the council, we worked on at least one iteration of the Healthy Schools Act. And so I definitely hear you from, I think your request was for a working group to determine what further or additional updates need to be made. I will tell you, and this is not an education hearing, but DCPS has started scratch cooking at several schools. And interestingly enough, the student feedback is better than with some of the other contractors that they have on board. We'll be calling on you as we think about that further.
Great. Be happy to help with anything, any way I can.
Great, thank you. Carrie, thank you so much for being here. I know there are going to be some other witnesses, I think even on the next panel, who are talking about food access and the grants that DC Health provides in that area. So we'll certainly bring those up in my questions with them, and also to anyone who's listening. Not just Food and Friends, but some of our other organizations who do food access work can use volunteers year round, not just during holidays on that front. And thank you again to all the other witnesses on home visiting, on the nonprofit equity. Thank you, Melissa, for continuing the drumbeat on that. Thank you. I don't have any other further questions. Many of you I have seen already during this performance oversight hearing. So we'll have some follow-up questions for DC Health, but thank you so much for being here.
Thank you.
Okay, so we're going to move on to the next panel. So for those who are just joining, we're doing panels of 8. You have to affirmatively accept our request for you to be elevated as a panelist. So please look out on your screen for that. So Lauren Lapointe, Reagan Dunham, Hugo Mulligan, Kimberly Price, Juanita Blassingame, Dr. Hassan Zia, Dr. Kurt Newman, and Rachel Johnston. Okay. Lauren, you're first on the list, and I see you here, so you can come off mute, present your testimony.
Awesome. Thank you, Councilmember Henderson and City Council members, for allowing me to speak with you all today. And also apologies, I think there's some construction going on outside. My name is Lauren Lapointe. I use she, her pronouns, and I'm a resident of Ward 1, a graduate of the Milken Institute School of Public Health at George Washington, and the Sexual and Reproductive Health Program Manager at Latin American Youth Center, or LAYC. So today I'm representing LAYC, and I will be speaking about our sexual and reproductive health services, primarily funded by the Department of Health. As you know, in DC, we have some of the highest rates of STIs and HIV in the country. And according to HOSTA's 2021 report, 1 in 2 newly reported cases of chlamydia in DC were aged 13 to 24. 1 in 2 newly reported cases of gonorrhea were aged 20 to 29, and 1 in 4 of newly diagnosed HIV cases were aged 30 to 39. Our work focuses on the prevention of these cases, and it starts with our young people. At LAYC, our Counseling, Testing, Referral, and Linkages Program, or CTRL, offers a safe, non-judgmental space for our DC youth to attain necessary resources to prevent pregnancy, sexually transmitted diseases, and human immunodeficiency virus, or HIV. We empower young people to take steps to prioritize their health and their future through free and confidential HIV, STI, and pregnancy testing and individual counseling sessions. We also train youth and young adults to offer these services to their peers rather than just adults, which can sometimes be intimidating for young people. Through the new Public Health America program at LAYC, we have trained and certified 8 young people to provide HIV and STI testing services and counseling sessions to our clients during in-house testing hours and at outreach events and health fairs. We also assist with professional development and workplace readiness by offering youth internships. Currently, we have 11 high school youth from schools and programs such as Don Bosco, Banneker, and Urban Alliance. This helps inform our services and keeps them youth-centered. In addition to our testing services, we provide an LAYC curriculum, sexual wellness and advocacy by teens, to foster much needed dialogue among youth around gender and sexuality, healthy relationships, consent, pregnancy, and contraception. These classes recently started using an anonymous question box where students share questions and feedback. Young people have anonymously shared that they experienced sexual assault in middle school. Some of these were also in middle schools. And our facilitators and school partners offered support and stressed the importance of reaching out to trusted adults and organizations like ours. So without these safe spaces for our youth, we worry they may never share and may never receive help. We need these safe spaces in our communities. So Councilmember Henderson and members of the Committee on Health, I ask you to continue supporting our young people and their sexual and reproductive health. Thank you.
Thank you. Reagan?
One moment, sorry. Okay, thank you for the opportunity to address the DC Council today. My name is Reagan Dunham, and I'm the Health Equity Manager at the Washington AIDS Partnership and a community organizer with the Decrim Poverty DC Coalition. I'm here today to urge the City Council to address the overdose epidemic and promote racial equity by establishing 24/7 harm reduction centers across the district and decriminalizing possession of substance use. The overdose epidemic has increasingly devastated communities in DC over the past 5 years and has disproportionately impacted communities of color. According to the DC Office of the Medical Examiner, DC has lost 1,932 residents to opioid overdoses since January 2017. Black Washingtonians accounted for 84% of these deaths, highlighting significant racial disparities in the health outcomes of people who use drugs in DC. These disparities are due in large part to racial inequities in the criminal legal system. 92.6% of all Washingtonians convicted of drug possession in 2019 were Black. I witnessed this crisis firsthand as a staff member at Joseph's House, a hospice and respite home for unhoused people living with HIV and/or cancer in Adams Morgan. Joseph's House lost a beloved community member to overdose shortly after she was released from incarceration at the Central Treatment Facility. Her story is one of many. DC can address health inequities, support racial justice, and promote economic mobility among LGBTQ+ residents of color by establishing harm reduction centers and safe consumption sites around the city. Such sites have already proven successful in New York City, where centers operated by On Point NYC prevented over 600 overdoses in their first year of operation. The Decrim Poverty DC Coalition was able to visit On Point NYC this past Monday. Their overdose prevention center contains a safe consumption site where people can use in the presence of trained health workers who can respond to emergencies such as overdoses. It also contains a clinical center with physicians and nurses, a drop-in center that provides food access and case management, and a holistic healing center where people can receive massages and acupuncture to help with detox symptoms. On Point NYC offers a model for what substance use treatment services should be, designed by and for those who have been most directly impacted by the war on drugs. On Point NYC staff noted that their work would be greatly improved by the decriminalization of possession of drugs, as that would encourage patients to seek out their services more often without fear of being criminalized. The criminalization of healthcare services obstructs access to care. Evidence-based harm reduction policies, on the other hand, have been proven to encourage and improve community health. For example, 2022 marked the 15th anniversary of DC's decriminalization of syringe exchange programs. Since then, new HIV transmissions are 85% lower than 2007, and it continues to steadily decline, especially among injection drug users. It is clear that the DC government's investment in evidence-based harm reduction strategies works, and it is imperative that the fiscal year 2024 budget includes funding for a harm reduction center and support for drug possession decriminalization. We hope to turn the tide of opioid overdoses in the district, and we are hopeful that we can count on your support. Thank you.
Thank you. Hugo?
Hello, can you guys hear me?
Yes, we can hear you.
Thank you so much. Good morning, members of the City Council and Committee on Health. Thank you, Councilmember Christina Henderson, for this opportunity to testify in support of DC Health and the program Produce Plus. My name is Hugo Mogolon. I am the Executive Director of Fresh Farm, a nonprofit organization that works to create a more resilient, equitable, and sustainable future. As you know, disparities in the food access in Washington, D.C. reflect long-standing inequities in resource distribution and in historic disinvestments in community of color, which negatively impact district residents' health and quality of life, especially those living in wards 5, 7, and 8. Produce Plus is an innovative and strategic investment in the government of the District of Columbia's portfolio that improves residents' health, food access, and well-being, especially attending to the needs of Black and Latino households, those with children and seniors, which are the higher risk of food insecurity and diet-related illnesses than the general district population. Since 2015, I've seen firsthand as a partner the profound impact that Produce Plus has on the lives of the most vulnerable district residents, our local farmers, and our communities. Last year, Fresh Fund and I had the unique opportunity to work for DC residents and as a manager of the program as the DC and a DC Health partner. Informed by extensive community listening sessions last year, Fresh Farm in 2022 transitioned Produce Plus from paper checks to a debit card system that allows participants to shop in any denomination at any participant vendor of their choice, addressing barriers to access for residents by prioritizing dignity and autonomy in the customer experience. In 2022, our partnership with DC Health empowered over 6,000 Washington, DC residents to spend over $900,000 on fresh local produce of their choosing at over 50 participant farmers markets, mobile markets, and farm stand locations throughout the district. From all of the participants, more than 40% were seniors over 60-year-old, 30% were households with children, and 60% were from wards 5, 7, or 8. Additionally, 84% of the people use at least 80% of the money they receive. The program has a very large impact. For the first time since Produce Plus inception in 2012, Fresh Farm was able to extend the program season into the fall, supporting both local families and seniors, as well as the city's farmers markets and farmers, especially those located east of the Anacostia River. We run the program from June to November, and that's 6 months in total. However, demand for the program is really high. Despite our best effort, we were not able to reach everybody that has expressed interest in the program, leaving a great number of people without this benefit. As you look ahead and shape the city's budget for 2024, we urge you to prioritize all DC Health investments, keeping the district as a national leader in food access. Additional funding for DC Health grants will support improving healthy food retail environments in low access areas by creating enhanced systems, alignment between public and private social services and clinics, addressing more social determinants of health. Before we end here today, I really would like to recognize DC Health's staff, their leadership, and the tireless effort to make our partnership successful, always being able to answer our questions and gracefully helping us to navigate our challenges. It has been a pleasure to carry out this collaboration. Thank you very much, and I'm grateful for this opportunity to speak to you.
Thank you. Ms. Price?
Good morning. I'm here from the members of DC Council, member of the Health and Community Chairperson. My name is Kimberly Price. I'm here for Fresh Farm to increase funding to the Produce Plus. I've been here 2011, guiding hotlines in person. I'm here for the I've been here from Ward 7 and 8, Minnesota Avenue and Ward 8. And we have the highest ratings of diabetes and healthy conditions. A lot of seniors ask about the program. I try to help people, and they use my email to sign about the new Produce Plus. There is a need to I'm asking you to council to Produce Plus for the budget so we can serve over 8,000 to DC residents. Thank you.
Thank you, Ms. Price. Ms. Blessingame?
There. I can see Juanita.
She just needs to unmute. There we go. Go ahead. I can hear you. Can she hear me? Ms. Blassingame.
Just ask if they can hear you.
Yeah, I think you can. They can.
Hi, can you hear me?
Yes, ma'am. Go ahead with your testimony.
Hello?
We can hear you.
Okay, all right, thank you.
No problem. Go ahead.
Okay. Good morning, members of the DC Council, members of the Committee on Health, and our committee chairperson, at-large council member, Christina Henderson. My name is Juanita Blassingame, and I'm here today on behalf of Fresh Farm to advocate for increased funding for the Produce Plus program. Produce Plus positively impacts the lives of DC residents experiencing food insecurity, especially those living in wards 5, 7, and 8, and by increasing access to fresh, local fruits and vegetables grown by local area farmers. I have been with the program since 2014, starting as a volunteer and then market champion, providing outreach, enrollment support, and customer service. I have also been a Produce Plus program participant for many years. We signed up over 6,000 DC residents to Produce Plus last season. We need more funds because people were still coming on the last day of the program to ask if they could sign up. What they get from us in the markets is really healthy, fresh fruit, and they like it more than other programs. People were eating vegetables before, but now that they're getting the fresh ones from the farmers markets with Produce Plus, they're eating more and feeling better. Last year, we were also able to extend the season into October and November for the first time ever. A woman told me she usually starts freezing her sweet potatoes in September to use them for Thanksgiving. But because the season was extended through November, she didn't have to do that. And they ate fresh in the fall and on Thanksgiving because of Produce Plus. At the Hayes Wellness Center, another woman came up to me that I didn't personally know, but she recognized me and asked me about Produce Plus. She said it was so good and so helpful for her, and she asked if what she needed to do to make sure she gets it again next summer. I told her to keep her card for next year since she can use the same one. I am asking the council to prioritize Produce Plus in the budget so that we can serve 8,000 DC residents, a 30% increase. Thank you for your time and consideration.
Thank you. Dr. Zia?
Good morning, Chair Henderson. My name is Hassan Zia, and I have the privilege of serving as the chairman of the District of Columbia Hospital Association Board of Directors, as well as serving as the president of Sibley Memorial Hospital, which is part of Johns Hopkins Medicine. I very much appreciate the opportunity to present testimony before you today. The collaboration between DC Health and the district's hospitals is an example of how to balance the department's role as a regulator with that of a partner in improving community health. We share the goal of keeping the patient and the community at the center of everything we do. One of the critical issues where DC Health and the district's hospitals are partnering is in the effort to reduce maternal and infant mortality. As part of this effort, DCHA was awarded funding to establish the DC Perinatal Quality Collaborative. The collaborative serves as the district's champion for reducing maternal mortality, improving maternal and infant health, and narrowing racial and place-based disparities in maternal health. We know this work is critical because almost 2.5% of women delivering a baby in DC have experienced severe maternal morbidity, and 90% of maternal deaths in DC happen to non-Hispanic Black women. We are proud that all 5 birthing hospitals in the district have committed to this initiative and that the collaborative was accepted into the Alliance for Innovation on Maternal Health, or AIM. As part of their ongoing work, hospitals are using data-driven quality approaches to monitor quality improvement projects and facilitate data sharing to collaborate across hospitals. Currently, hospitals are collectively working on the severe hypertension bundle as part of this quality improvement program. We know the hospitals can't do this work alone and realize patients, families, and advocates are key to driving success. This is why the collaborative engages directly with patients and families as advocates and partners and includes them in larger maternal health stakeholder meetings and focus groups on specific maternal health topics to ensure this process keeps patients at the center of healthcare. At Sibley, we are also proud to be one of 3 district hospitals, including Children's National Hospital and MedStar Washington Hospital Center, to partner with the Clark Foundation to improve maternal and infant outcomes. Through the Maternal Health Access Program at Sibley, we have improved access to our Johns Hopkins Maternal and Fetal Medicine program for women across the district through strategic partnerships with community-based organizations. MFM faculty at Sibley are now providing peer-to-peer consultations for physicians caring for expectant mothers identified to have high-risk pregnancies and are providing direct services to patients through telehealth and in-person visits. We support wraparound services through the dedicated social work, nurse navigation, and case coordination resources of the MHA program for patients to be able to address barriers to access. We are also in the process of launching an OB hospitals program at Sibley to improve access for mothers across the district who may wish to deliver at Sibley. Over the last year, we have served 188 patients with MFM specialty care and delivered 41 patients at Sibley through the Maternal Health Access Program. Again, thank you, Chair Henderson, for the opportunity to testify, and I would be happy to answer any questions you may have.
Thank you. Dr. Newman.
Good morning, Chair Henderson and members of the Committee on Health. My name is Kurt Newman, and I am a DCHA board member and president and CEO of Children's National Hospital. As you know, Children's National has served the nation's children for more than 150 years, and I am pleased to be here today with Ms. Bowens and Dr. Zia to present testimony. DC Health and the district's healthcare providers are partners in providing and improving community health in the city. Children's National partners with the department on community health improvement initiatives such as Impact DC, which is our pediatric asthma program, and family nutrition services through WIC. Most notably, DC Health and Children's National partner to provide comprehensive primary care services in 2 of the 7 school-based health centers at Dunbar and Ballou. We also provide school nurses to DC public and charter schools. It's an immense responsibility, but we are committed to ensuring the best health and well-being of our youngest residents. You will hear testimony later from the program leaders about these accomplishments. What I wanted to focus on today is that as we move towards pandemic recovery, we continue focusing on improving community health while also addressing the incredible delayed needs of our patients and citizens. Like our adult counterparts, we continue to see an increased acuity of patients in both body and mind, as well as a very high census. Meeting this demand requires effective systems that enable us to recruit the best and brightest, and particularly nurses. One of my top priorities is recruiting and maintaining high-quality staff, as well as developing a workforce that knows how to care for children. I know DCHA testified earlier this week, and we support the testimony at the Health Professional Board, and we agree that the council should continue investing in the Office of Health Professional Licensing. But most importantly, we believe joining the Nurse Licensure Compact is essential to improving the nurse licensing process. At Children's National, we are proud of our status as the only, and I'll say that again, only locally owned and governed hospital in the Washington, D.C. region. However, with that status, we struggle to compete and recruit nurses from the 39 compact states, which includes both Maryland and Virginia. Nurses in compact states are eligible to apply for a multi-state license that is accepted in all the compact states. Highly qualified nurses with a multi-state license are more likely to accept employment opportunities in other states. The compact eliminates the burdensome state-by-state process. When it comes to recruiting nursing talent, one of the most important members of our team, we need every competitive advantage. I say this not to discount the hard work the agency is doing to improve in the licensure process, and we are thankful for the investments made so far and look forward to continued advancements. And we look forward to working with the council to adopt the Nurse Licensing Compact. Thank you for allowing me to testify today, and I'm happy to answer any questions.
Thank you, Dr. Newman. Rachel?
Good morning, Chairperson Henderson and members of the committee. My name is Rachel Johnston, and I'm a Ward 5 resident and the Senior Director of Operations and School Support at the DC Charter School Alliance, the local nonprofit dedicated to ensuring all students in DC receive the great public education they deserve. As always, charter schools are committed to providing safe and nurturing learning environments. So we're grateful for the stronger coordination we've seen between OSSI and DC Health to ensure our schools have crucial health supports like COVID tests. Today, I focus on two areas where charter schools are still facing challenges and ways we believe DC Health can support. First is overcoming barriers in the school nursing program. But before I dive in, I'd like to thank Children's School Services and Dr. Boudreau. She is collaborative and gracious with her time, listening to our feedback and brainstorming solutions. We've previously testified that for the school nursing program to be effective, we need DC Health to provide greater clarity around what we can ask nurses to do. We understand DC Health is in the process of 1, updating the nurses manual, and 2, finalizing a 1 to 2 pager that summarizes the responsibilities in the manual. We appreciate this and hope schools will receive these documents by June so they can plan for next school year. Additionally, we need full-time nurses in every school to meet students' health needs, which is a precursor to actively participating in learning and therefore an equity issue. The majority of our schools don't have the 40 hours per week of coverage required by the law, and some have no coverage at all. To fill the gaps, many of our schools hire or contract with nurses using funds from their budgets. We appreciate that DC Health and Children's are working to remedy this issue given the nationwide nursing shortage. And second, we asked DC Health to improve the immunization compliance systems in light of the lessons learned about what it takes to fully operationalize No Shots, No School. As we testified previously, schools navigated issues across several data systems, including DOSIS and Salesforce. None of these systems had complete or fully accurate information, which OSSI and DC Health recognize, because they are not designed to align with the immunization compliance guidance that the city has issued. Since school leaders couldn't rely on DC Health systems, the city advised them to maintain their own lists. This is an inefficient use of the time that they could be spending directly supporting students. This also means publicly reported vaccine rates don't truly reflect schools' efforts. Now that we know the system's weaknesses, we urge DC Health and partner agencies to take 2 important steps. First is making system adjustments ahead of the summer so that they report accurate compliance rates aligned with the city's guidance. Second, given enrollment fluctuations at the beginning of the school year, we recommend the city advise schools to send non-compliance notification letters to families after count day. In closing, charter schools care deeply about ensuring their students' health needs are met and about routine pediatric immunizations. We appreciate the effort the city is making to address challenges schools face in both areas, and we welcome the opportunity to collaborate. Thank you for your time and attention, and I welcome your questions.
Thank you. And thank you to all of the public witnesses on this panel. I do have a couple of follow-up questions, and I'll be brief. Ms. LaPointe, you spoke about HIV and STI rates and testing, and this was something that kind of jumped off page to me while we were sort of preparing for this hearing. I'm curious, are you all seeing a rebound in terms of the number of individuals who are being tested? I know that with the pandemic, we saw some dips in our numbers, and I'm curious if you all are starting to see the numbers come back up again.
Thank you for this question, Councilmember Henderson. This actually, like you said, during COVID, we were not getting as many testing numbers. I think maybe like 15 to 30 a month, but this past month, we actually hit 100 people getting tested. And this month, we're on track to be close to that again. I think the last time we checked was about 60. Again, I can only speak for LAYC, but also talking to other partners, the numbers have been coming back up. People are feeling more comfortable coming in and getting these services. So in terms of testing, we've been having more people coming out, getting tested, which is really great to see. However, with more testing, that also means we're getting more positive results as well and making sure to connect people to care. So yeah.
I'll ask Reagan, I'm not sure if you've heard, I'll ask you similarly because you work with the Washington AIDS Partnership, what you all are seeing on the ground.
What we're seeing in terms of specifically HIV or substance use and STIs overall?
Overall, like are folks coming in to be tested? And because, right, we can't refer you to treatment if we don't know whether or not have it, or and so yeah.
Yeah, so similarly to what Lauren mentioned, I think a lot of health service organizations in the city are really trying to adapt to a new normal now that we're transitioning into a different age of COVID. COVID definitely disrupted services a lot because people had so many other issues going on, whether it was employment or paying bills or putting food on the table. And so many people started putting health issues that weren't acute and emergencies kind of at the back burner in the back of their mind. So right now, lots of organizations are kind of rebuilding the infrastructure to know, like, where are people? How can we reach them? If they're not coming into clinic, where in the community can we go out to do mobile testing? That's been a big thing. And something else since the pandemic began is overdoses have been increasing every year in the district.
Right.
And so a lot of harm reduction providers in DC, like folks at HIPS and Family Medical Counseling Services, among others, have really been trying to build more sustainable infrastructure for supporting communities where overdoses have been happening. I know they all look at DBH can do like maps of clusters where overdoses are, where there are hotspots. And I think HIPS is really trying to find ways to get into those hotspots and build structures where people can come and receive substance use treatment without judgment or without fear of incarceration. And so that's really with our proposal, what we're trying to get at with building the harm reduction centers and decriminalizing possession of substance use of substances. Yeah.
Thank you. Thank you for being here. Thank you so much to the Fresh Farm team. I've heard really great feedback about the Produce Plus program, and you know, I think food access and nutrition and wellness goes into those social determinants of health. So I focus on it, you know, here within the committee, and so we'll definitely be asking questions of DC Health about that. Dr. Zia, Dr. Newman, I found your testimony. I've met with you all in terms of the hospital association, but I thought it was interesting in comparison to Ms. Johnston's testimony, where she's like, I need full-time nurses in every school. And Dr. Newman, you're saying, I can't find nurses even for my hospitals. So clearly we are having a workforce challenge that is hitting in sort of every area. Dr. Newman, in terms of the nurse licensure compact, I did like a quick search, right? You know, California is not in it, Connecticut is not in it, and DC essentially, for the most part, or doesn't even have legislation sort of pending. I'm sure that you all, and Dr. Zia, you can join in on this. I'm sure that the Hospital Association has raised this as a priority issue and concern with DC Health. What has the response been in terms of why the district has not yet pursued entering the compact?
Well, thank you, Council Chair. And I wouldn't want to speculate on what the issues might be from their perspective. I think, you know, folks want to make sure that the district has the highest standards, and perhaps there's some concerns about would this decrease the potential for those standards. When we've studied it, we believe that there are terrific safeguards in place about whether standards for nurses would be lowered. The issue comes up is that if you're a nurse and you're looking at moving to another state or being recruited to another state, if you have to go through at your own expense a whole process of reapplying and getting a separate license just for the District of Columbia, but you have 39 other opportunities for other states, including Maryland and Virginia, it's pretty easy to understand why a nurse wouldn't want to come to the District of Columbia. And that's what we're facing. And I respect the testimony around from KIP about this. And, you know, we're passionate about trying to find enough nurses, not just for the school systems, but for our own hospital. We're working short staff. People are working late into the night, the weekends, doing double shifts, triple shifts, you name it. It doesn't feel good. And so anything that we can do to partner with DC Health while maintaining the the standards, but if there's 39 states that have already been operating under this, I don't see why the District of Columbia can't become part of this alliance.
Thank you. Thank you to all the witnesses. If you could just make sure that we have a written copy of your testimony. I know some of you had longer statements, and we just want to make sure that we have that information for the record and that the committee can review. Dr. Newman, I will ask about the nurse licensure compact, and Ms. Johnston will also follow up in terms of the school nurse program as well. So thank you all for being here. We're going to move on to the next panel. Okay, I'm going to call up the next 8. Charles Romani, Reginald Black, Deja Williams, Candace Hemphill, Cervantes Thomas, William Long, Janet Phoenix, and Caitlin Roger. Again, you have to affirmatively accept our invitation to be elevated as a panelist. For those who are here now or who was on the last panel, you'll be put back as an attendee and can continue watching the hearing. Okay. I see Charles here, so why don't we go ahead and get started with him.
Chair Henderson and members of the Council Committee on Health. My name is Charles Romani, and I'm the Associate Director of Health Services at KIPP DC. Thank you for holding this hearing today. We appreciate DOH and their nursing contractor, Children's National Medical Center, for the significant improvements they've made in expanding nurse coverage over the past year. Every KIPP DC campus now has a nurse, which has not always been the case. 5 of our 8 campuses now have full-time nurses. However, we continue to advocate for staffing at all DC schools. Children's National has also expanded access to needed hearing and vision screening equipment and support staff, resulting in more kids getting the required screenings. We specifically want to shout out Dr. Boudreau, Executive Director of Children's School Services, who has been a responsive partner, meeting regularly with me and my colleagues to review policies and address concerns. Regarding the 3 recommendations, DOH should continue improving access to student health services. The first point is transparently communicating nurse policies in writing. To date, we have not received any of the following documents despite our repeated requests to DOH, including student visits documentation policies, parent communication policies, and COVID-related student quarantine policies. We appreciate the times that Children's National has shared this information orally, but having copies of these policies is valuable to ensure consistent information across schools, LEAs, and nurse supervisors. Communication could be further improved through regular updates from Children's National, invitations to their trainings, sharing lists of medically fragile students, and integrating data systems. The number 2 point is retaining the PCT position and refocusing the role on immunization tracking and support. As a reminder, the council enabled schools to access PCTs during COVID to support isolation suite staffing. Over time, many PCTs have provided critical support to our routine childhood immunization tracking and parent communication. If the council wants LEAs to comply with the no shots, no schools requirement, LEAs will need reinforcement, and PCTs are the best positioned to provide this help. The final point is ensuring capacity for universal hearing and vision screenings and expanding access to equipment across all wards. Due to COVID-19 protocols and a lack of staff capacity, not all required students currently are receiving these screenings. Expanding staff capacity should include providing a clear timeline on when each LEA will revert to these universal health screenings. These screenings are a vital to the IEP process and ensuring students with special needs receive the support they deserve. Thank you again for holding this hearing today. We appreciate DOH and children's recent improvements and look forward to even more progress in the coming months. I look forward to any questions.
Thank you. Reginald Black. Mr. Black, we see you in the attendee room. You have to accept our invitation to be elevated as a panelist. There we go. Mr. Black, can you hear me?
Yes.
Okay, great. It's your turn.
Yeah. All right. Good morning, Councilmember Henderson, members of the committee. My name is Reginald Black. I am a native Washingtonian, and I'm currently the Housing Advocacy Director for Serve Your City, Ward 6 Mutual Aid. And I'm here today to give testimony to matters that are important to the Department of Health. Medical respite are essential to maintain a level of health throughout the homelessness services system. These beds are greatly needed and to assist better discharge planning. I have witnessed many of my peers be discharged from hospitals right into shelter. A respite bed may give a person that needs extra time to fully heal a more medically serviced bed that the low barrier shelters cannot produce. After these clients have been brave enough to bring, these clients have to brave the elements to bring a doctor's note for bed rest currently. They will lose their belongings if they are left in shelter, which would include adjacent medicine the consumer may need long term. Our homeless population on the single side has aged, and these people need hospice care, not a low barrier shelter. We must strive to protect their health. According to Home with DC 2.0, the Department of Health is to assist conduct an analysis to examine service connectivity among clients that are referred to mental health services and or substance use services, as well as to work to ensure, as well as explore the feasibility of a sobering center and harm reduction models to disrupt the cycle of films, and ambulance transports, and street overdose from hospital to emergency rooms, and to co-locate addiction specialists for constant engagement opportunities. This will improve social service connections in the community. We can do better for our medically vulnerable clients. They may not need a hospital, but shelters are not appropriate either. We would like Department of Health, DC Health, to help us create a rest stop for those needing additional care after leaving a hospital instead of going to shelter. I would be glad to assist with this work, and it's important that we remember how we serve the least in our community. Homelessness is supposed to become rare, brief, and non-recurring in the future, and I would like our hospitals to help us conduct a better plan. Thank you for the opportunity to testify, and I'm happy to answer any questions you may have.
Thank you. Deja Williams.
Hello, good morning, Councilmember Henderson and committee members. My name is Deja Williams. I'm a Ward 4 DC native and advocate with Spaces in Action. My testimony today will focus on the Supporting Healthy Steps program and home visiting for a strong, effective, and connected early childhood system in the district. My values are family, community, and healthcare. These values matter to me because as an organizer and advocate for families with babies from birth to 3, the health of my community is a top priority to ensure DC families have a healthy start. The problem I notice while working with families in DC is financial insecurity and the need for access to healthcare and prevention and early intervention services. These problems are real for all low-income families in the district, evidenced by the increasing rates of food insecurity, inflation, and the cost burden of early childhood education and some health services. Family support services available to DC residents at little to no cost, like Healthy Steps and home visiting, can be critical lifelines and opportunities for families to thrive. The district has continued to invest in Healthy Steps over the past 5 years. This investment has helped to improve the quality of life for families with babies and toddlers. Families can better connect to resources, services, and support to help soothe the stresses of problems that may arise. Through my work with families in DC, mainly in wards 7 and 8, they have told me great things about Healthy Steps. I have been able to check in with families throughout the months of them being in the program, and we talk about the growth they have seen in their children and themselves as a parent or caregiver. Continued funding for this program will ensure that more families can access various physical and behavioral health supports and services through Healthy Steps. Similarly, home visiting is a proven effective early childhood service. As a home visiting community advisory board member, I have connected with home visitors who express the importance of their work. Home visiting leads to a positive family outcomes and reduces child abuse and neglect. This service allows a holistic and preventive approach to support families, their health, and economic well-being. The problem I noticed while being engaged with various home visitors is the need for investment in the workforce. Many home visitors have expressed the need for higher pay. Low wages are causing home visitors to leave their roles for better pay. High turnover disrupts the system and causes inconsistencies with the families they serve. Home visitors are crucial to our community's growth and deserve increased investment. The council's next action step should be to continue funding for Healthy Steps programs and investment in home visitor workforce. I believe these two services will result in positive outcomes for families in DC. Thank you, Councilmember Henderson and committee members for hearing my testimony.
Thank you. Candace?
Can I mention Candace Hempfield and also Cervantes Thomas? They could not be here today. There are proxies on the line to speak for them. Are they allowed to come on and speak? On behalf of them.
If someone can put the names in the chat.
Yes, I can add I will put the names in the chat right now.
And also, if you are waiting to come in, if you can change your name, rename yourself so we can know who you are. That's the best way for us to be able to identify. But I'm gonna go on and we'll come back. William Long, I don't see Mr. Long. Okay, Janet Phoenix.
Good morning, Chairperson Henderson and members of the committee. I'm Dr. Janet Phoenix. I'm here today to talk about health impacts and data needs related to social impacts of health. As you may well be aware, many of the things that cause illness are outside of kind of the realm of traditional infectious disease and have to do with conditions in the home environment or conditions in the school or conditions in the community. Childhood asthma and childhood lead poisoning are both health conditions that are rooted in social determinants, especially the social determinant of housing. Asthma is exacerbated by housing conditions and also by exposure to airborne pollutants, like those that come out of the tailpipes of vehicles, particularly vehicles traversing the 295 traffic corridor. And lead poisoning often occurs in housing where maintenance is delayed or deferred. Because so many children in the district were adversely affected by these conditions, a group of organizations joined together last March and launched a campaign to reduce lead exposure and asthma. This campaign has met with many in the council, many staff, and a few members, and we will continue to work with you to try to improve conditions to reduce the number of DC children whose homes and communities place them at increased risk of disease. And this risk is not spread evenly across the District of Columbia. Wards 5, 7, and 8 have some of the highest rates of ER visits and hospitalizations. And I've included some data supporting that in my written testimony. I encourage the council to consider ways to facilitate partnerships between DOH and other agencies so that health data highlighting populations at special risk of disease because of the exposures taking place where people live can be used. This cooperation between agencies and the administration could lead to more effective program administration and implementation of laws and regulations that are designed to protect the health of DC residents and to improve the environment of those vulnerable populations. One example of that might be data that Children's National has included in a public-facing database that's searchable, that includes kind of large properties where children with asthma live and housing code violations that they collected from the former DCRA, now the Department of Buildings. The Department of Buildings is going to have someone in a public health managerial capacity. I believe that person is being onboarded now. And that individual could work closely with DC Health if there were agreements in place to access population data to help improve and target housing inspection and code enforcement. Lastly, I'd like to mention the Brentwood community. I've had the opportunity to work with them on a health impact assessment. The work of the Office of Health Equity, especially the 2018 Health Equity Report, was a valuable resource in that work and putting that HIA together. That's precisely the kind of data that is needed to inform decisions being made by DC agencies for regulating conditions that have an adverse impact on health. This has budget implications because some data is collected by outside entities and would have to be purchased and made available to DC agencies. But the main obstacle is the creation of these data sharing agreements and partnerships between agencies like DC Health, DOEE, the Department of Planning, and the Department of Buildings. I neglected to include the attachment when I submitted my testimony last night, but I will make sure to make it available. And I look forward to working with staff to shed light on these recommendations. Thank you very much for the opportunity to testify.
Thank you, Dr. Phoenix. Caitlin Roger.
Hi, good morning. Congratulations, Chair Henderson, for your appointment to committee, and
Caitlin
Walker, Deputy Executive Director, and I greatly.
Caitlin, you're going in and out. You might need to turn off your camera, just so we can just hear you.
Thank you. There you go. Could I start again? Is that all right?
Yes, that's fine.
All right. So thank you very much. Congratulations, Chair Henderson, for your appointment to lead this committee, and good morning, committee members. I'm Caitlin Roger, Deputy Executive Director at Greater Washington, and I greatly appreciate the opportunity to offer our first testimony to the Health Committee. I'm here today to call for greater interagency collaboration between districts' traffic safety and Vision Zero goals. My testimony nicely echoes a lot of points made by the accomplished Dr. Phoenix before me. Traffic violence is fundamentally a public health crisis, more than it is a transportation crisis. In the first 2 months of 2023, DC recorded 6 fatalities, altering major injuries, and 800, many of them children, about a 15% increase on all margins from last year, which already saw record highs. If this were any other cause of death or grave injury, cutting random people highly correlated with full, but the district operates as
Caitlin, your audio is going in and out again. So Caitlin, why you
spot and we go to a different panelist, and I'll read.
Yep, that will be just fine. Okay, so we're gonna go to Candace.
Perfect.
So Candace, why don't you go ahead and start?
Perfect, thank you. Good morning, Councilmember Henderson and committee members. I am Hope Joyner. I'm the proxy for Candace Hempfield, and I'll be reading her testimony today. So my name is Candace Hemphill. I am a parent, caregiver, usher at my church, and leader with Spaces in Action. My testimony today will focus on support of DC's Early Steps program for a strong, effective, and connected early childhood system in the district. I am a Healthy Steps parent advocacy council member for the Children's National, the ARC and Acostia, and the National Board. My values include family, community, and health. These values matter to me because as a parent, I ensure my daughter has the care she needs in education and health to thrive in the community. Mental health is essential to me because I need the proper care to take care and raise my daughter. The problem I faced was I had my daughter prematurely in May of 2021, and I was not able to go through my original birthing plan and had a C-section instead that I did not want. As she was born, I was told I had to find a doctor. I visited Children's National, the ARC, in her first pediatric visit. I was approached by the Family Services Coordinator about the Healthy Steps program. I did a questionnaire about postpartum depression. I joined the Healthy Steps Parent Advisory Council and found a sense of support from other parents. During this whole process, I became a single parent. My grandmother and my father also passed away in 2021. I was a new mom on maternity leave dealing with grief. The isolation from maternity leave made it very hard to function. Before joining this program, I was depressed, drained, fearful, and hurt. The solution I found was Healthy Steps. Healthy Steps gave me something to look forward to. I had a space where my needs and concerns were met, and my feedback was appreciated. I felt as a mother, once a month during the Parent Advisory Council meetings, we received information regarding our children's health. For example, when the COVID-19 vaccine was available for children under 5, the Healthy Steps PAC meeting gave us all the details on getting vaccinated. We get gift cards for attending some meetings, which has helped provide necessities such as food. Healthy Steps provided me with not only a safe space, but resources as well. I received diapers, wipes, and pamphlets on parenting. The topics included postpartum depression, breastfeeding, sleeping habits, etc. Healthy Steps has given me many tools to be a healthy parent and raise a healthy child. The next action should be to continue funding the Healthy Steps program. Continue funding for Healthy Steps will ensure more sites can be open and more families can be served. All parents in DC should have access to these services. If all parents in DC had access to this program, we would guarantee a happy and healthy future for our babies in DC. Thank you, Councilman Henderson and committee members for hearing my testimony.
Thank you, Hope, for presenting that testimony on behalf of Candace. Fari?
Good morning, Councilmember Henderson and members of the Committee on Health. I'm Fari Gamina Tumpe, a senior community builder with Spaces in Action, and I'll be standing in proxy and in solidarity with Cervantes Thomas. I'm a parent leader with Spaces in Action. I'm a Ward 8 resident and DC native, Healthy Steps parent, and Healthy Steps Advisory Council member. My testimony today will focus on the importance of DC Healthy Steps. We need this in order to have a strong, effective, and connected early childhood system in the district. I value our children's health. Our young children in DC have the right to grow up healthy. This value matters to me because I strive to ensure that my children receive the best care possible regarding their physical and mental health. One of the problems I experienced as a parent was toilet readiness for my twins. One of my twins was potty trained and the other wasn't. We all know that certain factors can get in the way of potty training, but Healthy Steps provided me with the information to help my other child. When my grandmother passed away, Healthy Steps gave me a pamphlet explaining sickness and death to young children. That helped me as a parent, explain the loss of my grandmother to my children. I also believed it helped me to cope better as well. The solution to raising healthy children in DC is access to programs such as Healthy Steps. And Healthy Steps has a plethora of information that can help caregivers. The brochures have various topics about breastfeeding and postpartum care. They give us access to nurses to help with questions regarding our children's health. The program is inclusive of all languages and has a very much like a family feel. I can openly ask questions about topics that I don't know. And the information they provide, such as sex education, can help me as a parent and caters to my older children. They give information on red flags involving drug use, peer pressure, and so much more. I believe through Healthy Steps, the district can ensure that more families with infants and toddlers have a place to get the resources and strategies that all families need to raise healthy children. The council's next immediate action should be to maintain or increase funding for Healthy Steps. Thank you, Councilmember Henderson and committee members, for hearing the testimony of Cervante Thomas. Thank you.
Thank you. Okay, don't go anywhere. Caitlin?
Hello there. I thank you so much to the committee's flexibility, and I apologize for my connectivity issues. If I could, I do want to start from the top because I don't know how much you heard. Apologies if I waste any more time for folks. I'm here today to call for greater interagency collaboration between the Department of Health and the Department of Transportation in the service of achieving the district's traffic safety and Vision Zero goals, which is kind of similar to what Dr. Phoenix was testifying. Traffic violence is fundamentally a public health crisis, more than it's a transportation crisis. In the first 2 months of 2023, DC recorded 6 fatalities, 56 life-altering major injuries, and 819 minor injuries, including children, which is about a 15% increase on all margins from last year, which already saw record highs. If this were any other cause of death or grave injury, cutting people down at random but highly correlated with racial identity and economic status, we would be bringing the full force of our public health system to bear. But the district operates as though the main responsibility for achieving our goals of 0 deaths or major injuries due to traffic violence lies primarily with DDOT. That's an administrative misalignment that can be costing us lives. What would a public health lens bring to the Vision Zero challenge? Public health centers on using data to tackle the major causes of premature death, disease, and injuries. Public health specialists work with relevant experts to cut away the chaff and distractions around other factors and get to the nub of a problem that's killing people. Furthermore, public health specialists are trained to analyze and respond to cultural preferences that have to be considered if you're going to create an effective intervention. And I use the term cultural broadly to mean our driving and mobility culture. As the 2018 Health Equity Report showed, the Department of Health clearly has ideas about how transportation could better serve health ends. Let's give them some resources and accountability to see what they can get done. We have found DOH staff helpful in engaging on traffic safety issues, but there's a big difference between interest and reasonably resourced accountability for this issue. DDOT has an impressive array of specialties, and I give them credit for their work on bus and bike infrastructure, but public health is not one of them. A multidisciplinary approach like this requires stellar leadership and vision. To that end, we'd ask that as DC moves forward in recruiting a permanent director, we seek and prioritize a leader with particular expertise in the structural and social determinants of health. Interagency collaboration sits in the spectrum from non-competition to communication to cooperation to coordination to real collaboration, where departments share goals, sometimes staff, timetables, budget lines. My written testimony contains some specific suggestions about this. Air quality and the diseases it's associated with, particularly in Black and Brown communities, could equally benefit from collaboration between DOH and DDOT. I'd also add that Gigi Wash is currently developing a report on how racial disparities in transportation infrastructure and services creates long-term health inequities, which I hope can help move this conversation forward. I'm happy for the chance to testify today on a personal level because I came to transportation from the sphere of public health, where I worked on how cities across the globe can make it possible for people to lead healthier lives they value. My specialty was using interagency cooperation to improve health equity through an initiative called Health and All Policies at the World Health Organization. So I know that this can be done, even in much lower resource cities than ours. In conclusion, I think we're leaving a lot of inequities lingering on the transportation table because the Department of Health hasn't been given a proper seat there. And I would love to see that change in the coming years. Thank you very much.
Thank you, Caitlin. And thank you to this panel of witnesses for your testimony. Deja, Hope, and Fari, I appreciate your testimony about the Healthy Steps program. In particular, Hope and Fari, I appreciate that you were able to share the testimonies of Candace and Cervantes, providing their own personal experience with the Healthy Step program. I think that's a very powerful testimony into the value of the program. And so thank you so much for being here. Charles Romani, I'm sorry if I'm saying your name incorrectly. Thank you for being here as well. In terms of your ask around vision and hearing screening, actually included that in some legislation that we introduced a couple of weeks ago. Just sort of noting that while we do require for students to be up to date in terms of immunizations, et cetera, vision, hearing, and dental also play a role in terms of whether or not a student can concentrate from an academic perspective, right? I remember when I got glasses, it was 9th grade, because I couldn't see the board in my biology class. And it was just like, oh, okay, let me get glasses because it's impacting my ability to pay attention in class. So thank you so much for bringing that up. Dr. Phoenix, I'm so glad that we were able to have you here today in terms of your testimony. I think, unfortunately, prior hearings didn't work out in order for you to be there. But I think the work that you all are doing with the campaign to reduce lead exposure and childhood asthma is so critical and important. And I've had some conversations with Children's National around the data that they have been collecting in terms of how environment leads into some of the things that we're seeing around health of children. And so if you don't mind, I'd love to follow up with you offline to get some more information about your work. In that regard, Caitlin, thank you so much for your testimony and sort of the intersection and always the advocacy that you all are doing at GG Wash around traffic violence, but the intersections between that and health. And I think you raised an excellent point around the social determinants of health needing to be a key part of the leadership of the agency going forward. So thank you all to the witnesses for your testimony today. We're going to move on to the next panel, but we'll raise some of these issues with DC Health. Okay, I'm going to call up the next panel. Sabrina Rhodes, Hannah Francis, Nisa Hussein, Aaliyah Ibeklung, Lucia Suarez, Evgenia Moziv, Eric Clocamero, and Dean Brenner. Apologies again if I butchered names. I will try to correct myself once you provide your testimony. This is just a reminder to folks. So you have to affirmatively accept our panelist request in order for you to be elevated as a panelist. Also, please check your name that you have on your Zoom screen. And if it's something other than what you signed up for, please rename yourself so we can know who you are. I'm going to give it a minute because I see Sabrina Rhodes in the attendee room. All right, but in the interest of time, I do see Hannah here. So Hannah, why don't you go ahead and we'll come back to Commissioner Rhodes.
Good morning, Chair Henderson and members of the Committee on Health. Thank you for the opportunity to address the committee as it reviews the performance of the department. My name is Hannah Francis. I am the Food Security and Health Programs Coordinator for DC Action. At DC Action, we use research data and a racial equity lens to break down barriers that stand in the way of all kids to reach their full potential. Chair Henderson, we want to thank the Department of Health for the quick rollout of EWIC this past year. The transition to EWIC has enabled families to have greater ease in use and flexibility, as well as a great reduction in stigma. This shift has been monumental for the families who rely on it. We encourage further efforts to modernize the WIC program and encourage DC to opt into waivers to modernize WIC through building or enhancing remote services, which have been proven beneficial to families who may face barriers to accessing in-person services. Improving WIC coverage is proven to reduce racial disparities in maternal and child health that still persist in the district. Therefore, it should be a priority to reduce the WIC eligible but not enrolled gap and to support families through a child's 5th birthday. WIC is an important tool to reduce intergenerational health and food inequities in the city, yet only 57% of eligible individuals were enrolled between 2020 and 2021, which was the highest enrollment that DC WIC has seen in years. As WIC transitions to the new Community of Hope Clinic with the closure of the Howard Clinic, we hope to see departmental action to ensure that all families who have relied on the Howard University sites are fully transitioned to Community of Hope or another clinic. We also ask that the new Community of Hope Clinic receives timely support to be fully staffed and operational, and that direct measures are taken by DC WIC to reach community members who will benefit from these new locations. Finally, we encourage the DC Council to support the USDA's proposed changes to allow online transactions for WIC by submitting public comments through the federal rulemaking portal. This proposal would improve the WIC shopping experience while increasing equity and access to nutritious foods for WIC participants and thus positively impacting nutrition security. Thank you so much for the opportunity to provide testimony. I welcome any questions. Thank you.
Thank you. Okay, I don't see Ms. Rhodes. So we'll go to Nisa.
Good morning, Chairperson Henderson and members of the Committee on Health. Thank you for the opportunity to testify. I'm Nisa Hussain, Early Childhood Program Manager for DC Action, Chair of the DC Home Visiting Council, member of Under 3 DC, and Ward 1 resident. Today, my remarks will focus on the critical role of DC Health's early childhood home visiting programs and the need for increased funding so that programs can perform at their optimal level for families. Home visiting is an effective preventative public health approach to supporting the health and well-being of children, expectant parents, and families who are primarily families with lower incomes and multiple risk factors. Home visitors work with families to guide them towards their goals, whether that's to practice positive parenting, increase developmental screenings, offer resources for a healthy pregnancy, or just help them cope with everyday barriers. Home visiting uses a 2-generation approach of addressing the needs of parents and children simultaneously to ensure the whole family thrives. When a parent is less stressed and more confident in their parenting skills, their children can receive the care they need to meet their highest potential and healthiest outcomes. Home visitors are the extra support in the parent's corner, offering them the coaching they're seeking to care for themselves and their family. Later in this hearing, you'll hear powerful stories of home visitors from Mary Center and Georgetown University, and I hope you can appreciate the tireless ways home visitors support families who are dealing with deeply complex challenges when you assess the performance and investments of these services. In total, these DC Health programs were able to serve 768 families in 2022 and continue to provide tailored support to these special populations. While home visiting continues to play a critical role in the district, our programs currently face several challenges that I'll elaborate more in my full testimony, but for now, I'll outline our recommendations. 1, we recommend increasing home visitor salaries to reduce turnover since home visitors are leaving the workforce due to low pay. Not only is it unacceptable that some home visitors cannot afford to live in the communities they work in, but it also impacts the participants. When a home visitor leaves their role, this disrupts the services to the families they work with and have built trust with over time. We also recommend an overall increase in local home visiting funding to adjust for rising inflation and stagnant grant amounts. This will help programs meet the increasing needs of families, which have grown urgently since the pandemic and continues into the costly economic situation that we're all feeling right now. Additionally, we recommend that DC Health work with the Home Visiting Council and programs to reduce the administrative burden on home visitors to allow them to spend less time on duplicative data documentation and more time with families. In conclusion, we are seeking an increase in funding for the FY24 budget to ensure programs can continue their valuable work. We ask that the DC Council prioritizes home visiting as a key early childhood strategy that will fulfill DC Health's goal of improving community health outcomes. Thank you for the opportunity to testify, and I welcome any questions.
Thank you. Aaliyah? Okay, don't see her. Lucilla?
Yes, hi. Good morning, Chairwoman Henderson and members of the committee. My name is Dr. Lucilla Suarez, and I'm a pediatric resident and soon to be pediatrician in DC. In my 3 years of pediatrics training, I've cared for the district's infants, children, and adolescents in various hospital and outpatient clinic settings. I want to start by thanking you for the opportunity to testify on the performance on the Committee on Health over the past fiscal year. Today, I will focus my testimony on DC Health's home visiting programs, like Nisa was just talking about. DC Health funds numerous programs, including Mary Center Nurse Family Partnership Program, Mary Center Healthy Families America Program, Georgetown University's Parenting Support Program, Community of Hope's Parents as Teachers Program, and Mamato Village Perinatal Health Worker Training Program. Like many pediatricians, I'm passionate about preventative medicine and the critical role it can play in changing the trajectory of an individual's life. That is why I'm here today testifying in support of DC Health's home visiting programs, which are an essential part of protecting the health of our most vulnerable children and their families. What really excites me about home visiting is that it fills the gap many pediatricians cannot close by themselves. Much of the burnout in medicine stems from our inability as providers to address the social determinants of health in a 15-minute clinic visit, when we are also addressing medical and behavioral health concerns, education, nutrition, sleep, development, all while examining, referring, prescribing, and completing health forms. What ends up happening is that our children, like a 2-year-old boy who I see almost every week that I'm in clinic and saw yesterday, overuse the medical system to address issues at home. This is not only expensive and burdensome for the healthcare system, but also, unfortunately, ineffective. Home visiting, however, saves costs due to its effectiveness addressing these very issues at home. Research shows an ROI between $1.80 and $5.70 for every dollar invested. Home visiting has been shown in studies to promote healthy child development by creating a more stimulating home environment, referring children to early intervention programs, connecting parents to employment opportunities, reducing mental health problems within a family, and improving access to necessary supplies like food and diapers. And while we can certainly prescribe diapers and other supplies to our families, it is the home visitors who are able to deliver these supplies to the home, not the pediatricians. The COVID-19 pandemic has really opened our eyes to how much we miss as providers in the clinic, since even a glimpse into our patients' home environments through a Zoom screen during a televisit has been enormously informative about the factors impacting our patients' health. For example, when we cannot see the mold in a home that is triggering our toddlers' repeated asthma exacerbations in the clinic and the hospital, both the patient and the healthcare system lose. When we cannot see the decline in a family's mental health and subsequent changes in the home environment, especially with the rise in deadly domestic violence and child abuse cases during the pandemic, both the patients and the healthcare system lose. This is where routine home visits with the same trusted adult who oftentimes speaks the same language and shares the same culture as a family fill the gaps and complete the care that our healthcare system can provide. Home visitors are our partners in child health delivery and protection, and this is why I'm here to support the continued investment in home visiting programs. Thank you so much for your time, and I welcome any questions that you may have.
Thank you. Dina, I don't see. Oh, just kidding. Ms. Mozzie?
Good morning. Thank you for the opportunity to speak to you this morning as an ELL teacher for Roosevelt State High School. My name is Dr. Evgenia Mauzy. I have been a teacher since 2006. I also graduated from a medical college in 1989 and worked as a registered nurse for 9 years. Therefore, I have an experience and can see the issue of staff in our school with a nurse and a childcare program from different perspectives. I advocate for a nurse position and a childcare program for our school. Our school has a diverse population where some students have to work to support themselves or help their kids and families. The number of students with complex health conditions affects a teacher's ability to meet the needs of a whole child, especially combined with the impact of social issues such as poverty, violence, and the growing population of students who speak languages other than English at home. A childcare program will help our students to complete classes, eliminate the financial burden of finding babysitters during school time for our students. This program will help our students with kids to attend classes and finally graduate. Some students have access to good health care and see medical professionals regularly, while other students have limited access to healthcare. School nurse will advance health equity within our learning community and will help promote healthy students, families, and community. School nurse also can reduce absenteeism by helping chronically ill students to manage their conditions and educate them about proper measurements to prevent illness. I hope that our request for a childcare program and a nurse position will be approved, and Roosevelt State High School students will have access to a childcare program and see a school nurse when needed. Thank you, ELL teacher, Dr. Evgenia Mauzi. And I welcome any questions.
Thank you, Dr. Mauzi. Eric?
Hi, Chairwoman Henderson. How are you?
I'm good.
Good. Thanks for the opportunity to testify. You've heard from myself and Mr. Brenner, who's going to follow me a couple of times recently. So I'll just say thank you for the opportunity and thanks for all you do. You know, we have a bit of a moment now. There are 9,000 people roughly with Alzheimer's and dementia in the district. It costs the district $125 million just in Medicaid dollars. We're making progress thanks to the work of Mr. Brenner, but also all of our advocates across the district in our partnership with council over the last few years. DC Health is making an Alzheimer's state plan available for public review in March, a new one. They are launching, with thanks to the support that the council added, a $250,000 public awareness campaign about Alzheimer's and dementia. But we keep pushing forward because there are a lot of people who need help. So today we're here to ask for your ongoing support for continued oversight of DC Health, particularly as we move out of the public health emergency in terms of the implementation of the Dementia Training for Direct Care Workers Act, for support of our workforce and expanding their wages. And I'd just say, in our approach at the Alzheimer's Association, we do view the council, we do view DC Health as partners. We view ourselves as trying to be force multipliers. And we hope you'll join us on Friday, April 7th, to listen to some of our advocates as we have our annual DC Advocacy Day for the Alzheimer's Association, where we meet with members of council. But we just thank you for your support. Thank you for listening, and thank you for your commitment, as you have been, in bringing us all together, asking the necessary questions, and working to prioritize the different issues so that we can all move forward to help more people. So thank you for your time.
Thank you. Dean Brenner?
Good morning, Chairperson Henderson. Good to be with you again. My name is Dean Brenner, and I live in Ward 3. I'm testifying again on behalf of the thousands of DC residents living with Alzheimer's and the over 14,000 family members struggling to take care of them. For reasons that scientists can't explain, Alzheimer's disproportionately affects women, African Americans, and Hispanics, and the monetary cost of Alzheimer's is astronomical, as Eric just explained. In the last few years, we have begun to make some significant progress in DC in addressing the Alzheimer's-related public health crisis, but there are 4 pieces of important unfinished business, which I again urge this committee and DC Health to address quickly. First, all 50 states have an Alzheimer's plan, but DC's plan expired in 2019, Under a 2020 law enacted by the council, DC Health's Dementia Services Coordinator is required to update the plan, and she has prepared a draft. I've been told for many months that there's a draft plan. I've been told that it will be circulated in the near future, but DC Health has still not released the draft and, of course, not finalized it. So DC and all the people with Alzheimer's have gone for 4 years without a plan. So I think it's time for DC Health to issue a new updated Alzheimer's plan, and I'd urge you to press them on that. Second, as Eric explained, in 2020, the council passed the Dementia Training for Direct Care Workers Act, requiring dementia training for direct care workers, but that law hasn't been implemented because the Health Regulation and Licensing Administration hasn't adopted the necessary regulations. Last year's budget included $170,000 to do that, but that money was never spent, so the law is really just symbolic. It's essential that the same $170,000 be included in this year's budget and that HLRA quickly adopt the regulations to carry out the law. The law is essential to ensure that the direct care workforce receives the training that they need to provide quality care to people living with Alzheimer's. Third, DC Health has created a really good new website showing available services and supports for people in DC with Alzheimer's, but they haven't promoted the new website. No one knows about it. And that's why it's essential that DC Health move forward with the $250,000 Alzheimer's Public Awareness Initiative that was in last year's budget. And then finally, as Eric explained, and I know you're aware, there's a terrible shortage of direct care workers in DC because their pay is grossly inadequate. Raising their pay to a living wage of $24 an hour, ensuring that it rises with inflation, and doing that not just as the maximum or the average, but have that be the minimum, is essential to ensure we have enough aides and home health care workers to take care of the people in DC with Alzheimer's and other disabilities. Thank you very much.
Thank you. And thank you to this panel of witnesses for your testimony. Ms. Francis, thank you so much for speaking about the EWIC transition and then also sort of the move from the Howard site. I have some questions for DC Health about that to make sure that that transition is going well. I hear you on the part around allowing for online shopping. I think that was allowed during the pandemic as like a, oh, sorry, that was for SNAP, not for WIC. One of the benefit programs. So I think we can learn from what happened with SNAP in terms of what we do for the WIC programs as well. One of the things I wanted to ask you, and something that I learned, is that, you know, how are we working with, or in your opinion, how are we doing in terms of working with more grocery stores to make sure that they are accepting WIC?
So what we know from the community and the data that is available, one of the most amazing parts of the EWIC transition is that almost, I think, somewhere around the 90-something percentile by the 6-month mark were EWIC compatible. However, there are a couple still previous WIC retailers that haven't been able to be fully transitioned over to EWIC. And then furthermore, there's a few retailers that haven't been come on as WIC retailers because they don't have the technology capabilities to be EWIC retailers. No one's carrying around paperwork anymore. So this is the only way, the EBT card is the only way to move forward. So I think that out of the, you know, we did hit that really high 90% mark pretty early, which again was incredible. Something that I'd hope to look forward is have the district sponsor the technology to onboard new retailers to address any space gap, especially as we look at our food apartheids in the district, mostly in 7 and 8, make sure that these new retailers are brought on and then that DC helps subsidize the technology gap.
I think those are some really good recommendations. I hate giving money back to the federal government when we don't need to. And sort of the idea that, you know, we give back around $11 million back to USDA because we are only meeting, I think we're only capturing around 58% of eligible residents in the district. who can sign up for this program. And so I feel like, especially since the pandemic emergency allotment went away for SNAP, that if we get more people to sign up for WIC, that could help bridge the gap for some of the families who are having some trouble in sort of the in-between. So, we'll definitely be asking some questions about that. Thank you for your testimony. Dr. Mazzi, I plan tomorrow during the hearing with DCPS to ask specifically about Roosevelt's Day and the childcare issue there. I have already asked DCPS, and one of the things that they said was they were having trouble finding a provider to partner with, given the small number of infants and toddlers who would be on site. And so I'm going to ask them tomorrow in terms of what their plan is and updating, because I've received a number of letters and we've heard some really powerful testimony even yesterday in terms of how that has helped folks finish their education by having childcare on site to be able to provide that. Dr. Suarez, thank you for your testimony. I think you bring up a very excellent point, something that we've heard across the healthcare sector of individuals who are using the emergency rooms as their primary care physicians, when in fact, they can go to urgent cares and all of these different things. And I think it is partly around building out the healthcare infrastructure to make that happen. So we talked to DMHHS and healthcare finance in terms of the urgent care center in one of the urgent care centers east of the river that we're supposed to be bringing on was delayed. And so what do we do in terms of increasing that? But also, I think to your point around elevating education for folks to know that the emergency room and the hospital is for those emergency acute care needs and not for the everyday pieces. But I hear you in terms of home visiting, being able to help alleviate some of that we're seeing.
Yeah, absolutely. I think in terms of building out capacity within primary care, home visiting is an enormous resource that we can rely on for being able to do that. We're tasked with the impossible in primary care offices, and it's also nearly impossible to deliver primary care in an emergency room setting. So home visitors they do a lot of that work. And so I'm really hopeful that I can help to support continuing to fund that and increase funds as needed. As Nisa was talking about, there's a lot of turnover in home visiting, unfortunately, rightfully so, because they're not making wages that are sufficient to even put a roof over their own heads.
Right. And so I actually want to bring up that because Nisa, I think what you're speaking about and actually what Mr. Brenner is speaking about is something very similar. Who is being paid in sort of the home visiting? How much are the wages coming in terms of direct care providers? And I guess, well, I've talked to Mr. Brenner, so I kind of know in terms of what direct care providers are making. I've also spoken with sort of the long-term care coalition. But Ms. Hussein, what's the average pay?
For home visitors, the average is around $44,000. It varies across home visiting programs because of the requirements. Each program is a little bit different. Some of them do have nurses. Of course, that's going to be a little bit higher, but I think the range is $44,000. And the Home Visiting Council released a policy recommendations brief that kind of outlines some of those details around salary across programs, if that's helpful.
And Mr. Brenner, do you know what the average is for direct service?
The average, I don't know. I know that many, if not most, are paid the minimum wage. And I'll tell you what concerns me very much, Councilmember Henderson, is, so in last year's budget, there was not a nickel of local money, of DC local revenue that went towards increasing pay for home health aides. Instead, there was this promise that over a 3-year plan, year one was 100% ARPA money. Year two, which would be this FY24, was to be 50% ARPA money and 50% local money, just to have a raise, not nearly to the $24 an hour, to nothing remotely approaching that. But that requires the council to fund $14 million in the FY24 budget for home and community-based services. And I don't know where things stand on that. And I saw the revenue estimate from the CFO, and I'm just very concerned because that wasn't in the law. That was just sort of gratuitously discussed in the report to the Budget Support Act.
Right. And I have no insight on the budget piece myself,
Yes,
but we will all
yes.
learn about what's going
Yes.
to happen there in about 20 days or so.
Right.
But from the hearing that we had on Tuesday with 5 of the boards, in terms of the need to increase the pay for recruiting the workforce that we want to have, whether it be home visitors, whether it be direct care, whether it be caseworkers, and dealing with some of our housing challenges. So these are all very good points. And thank you all so much for your testimony and for being here. If you haven't submitted your written testimony, please do so we can have that for the record. I'm going to call the next panel of witnesses. We are making our way through the list. Rachel Ellison, Kimberly Brooks, Julie Krieger, Andrea Boudreau, Deepla Patel, Beverly Wheeler, Max Broad, and Caitlin Wilson. Again, for those who are joining, you have to affirmatively accept our invitation for you to join as a panelist. Okay. I don't see Rachel Wilson, so we'll go to Kimberly Brooks.
Good morning, Chairwoman Henderson and members of the committee. My name is Dr. Kimberly Brooks, and I am the program lead for the Healthy Steps program at Children's National Hospital and part of the Early Childhood Innovation Network, also known as ESIN. I'm here today to testify on the importance of the Healthy Steps program and the impact that it's had on DC families during fiscal year 2022. I thank you for this opportunity to testify today. At Children's National, we partner with the department on the implementation of our Healthy Steps program. We are partially supported with funding from DC Health through the Birth to 3 for All DC law. This funding has allowed the program to not only provide multiple services to parents and families at routine pediatric visits regarding issues such as feeding, behavior, sleep, attachment, caregiver depression and trauma, social determinants of health, and community resource navigation, but also engage families in our Parent Advisory Council. Our Parent Advisory Council provides families the opportunity to guide our Healthy Steps programming through suggestions and feedback regarding overall clinic issues, but also specific issues regarding Healthy Steps. We have continued to engage our Healthy Steps parents through our monthly virtual discussions about the program, parent topics, and health education sessions. Also, with the success of our 2 Healthy Steps sites in Ward 7 and 8, Children's National has secured funding to expand into a 3rd site in Columbia Heights. And this expansion allows Healthy Steps to support families in another under-resourced area of the city that happens to have a high Latino population. As we testified last year, the impact of the COVID-19 pandemic has shifted the way our program delivers services. The pivot to telehealth has not only impacted participation in services, but it's also allowed us to see improvement in mental health and wellness for parents. Offering mental health services and support group options virtually has offered many families options to participate in ways that were previously complicated by transportation, childcare, or work schedules. During fiscal year 2022, Children's National provided care and enrolled 233 families. We screened for developmental issues 352 children and also screened 243 mothers for postpartum depression. With more children and mothers being screened, we're able to impact the trajectory of care for children and their caregivers. And with early screening, children can receive services sooner and mothers can receive support earlier, mitigating the impact of maternal mental health issues on the mother-child relationship. For example, our virtual mother support group demonstrated that when mothers receive support early, depression and anxiety decrease, leaving mothers emotionally available and better able to care for their child. I commend DC Health on its commitment and investment in young children and their families, especially through its effective implementation of the Healthy Steps program. As Healthy Steps expands in the district, we'll be able to reach even more families. Thank you for the opportunity to testify, and I'm happy to answer questions.
Thank you, Dr. Brooks. I don't see Dr. Kruger.
I see her there.
I'm here. Sorry.
Oh, just kidding. Hi.
Hi, good morning, Chairwoman Henderson and members of the committee. I am Julie Kruger and I'm representing the school-based health centers at Dunbar High School and Ballou Senior High School, operated by Children's National. For over the past 150 years, Children's National has been an integral part of the healthcare safety net serving the district's children. And our school-based health centers cover the health and wellness needs of the students in these two high schools. We provide comprehensive adolescent-focused medical care, including preventive health visits, annual physicals, sports physicals, sick visits, childhood vaccinations, COVID vaccines, reproductive health services, dental service, mental health services, and health and nutrition education. I am privileged to be here to provide this testimony to the DC Department of Health, and I would like to highlight our successes over the past year. We see over 38,000 patients in our Children's Goldberg Division of Primary Care, but at the school-based health centers since 2016, we have seen 6,500 patients at the two high school sites. In the past year, we provided services to over 766 students, 381 at Ballou and 385 at Dunbar. These students often come back to see our team multiple times, and these 766 students have led to over 1,500 patient visits over the past year. We also have partnered very closely with Dunbar and Ballou high schools for community health events to participate in more mental health and dental health care, as well as the mobile vans over the past summer to offer more childhood vaccines to help address the No Shots, No School initiative. In the past year, we were able to administer over 1,000 vaccines in the school-based health centers themselves to continue to keep the children in the classroom. Getting students up to date with immunizations and offering the COVID vaccines was a strong mission of our pediatric team, and we were very grateful to work closely with the school nurses at the school-based health centers in this mission. We also had an integration of a focused health educator to help on reproductive health and a social worker that was very focused on mental health challenges that the students were facing in this past year in the high schools. Both of these services were well received. We really want to empower students to address their own health. It's a confidential space in the high school to help address things such as mental health and sexual health and do it in a responsible fashion. In these clinics, we offer accessible, affordable, and confidential care to adolescents. And we're so privileged to be co-located with school nurses and have a strong collaboration with them to help address the health of the entire school community. Despite our proven success, we consistently face challenges in funding for operations, and we do feel like it is important the district increase their investment in the school-based health centers to help meet families where they are and make sure these children have access to care. It's only with the continued support of the DC Health that the school-based health centers can be successful in reaching these students, and we recognize and appreciate that other teams in the district do this as well. Thank you for helping bringing this positive change for these students, and we look forward to collaboration, and I look forward to any questions. Thank you.
Thank you. Dr. Boudreau?
Good morning, Chairwoman Henderson, members of the committee and staff. I'm Dr. Andrea Boudreau. I'm a Ward 2 resident and have the esteemed pleasure of serving as the Executive Director of Children's School Services. You have my full testimony for the record, but in the interest of time, I'd like to share a few highlights of our contributions over the last year. As schools began to plan for the 22-23 school year and enforcement of immunization attendance policy, CSS and Children's National partnered with schools and DC Health to ensure that the health and safety of our students were prioritized by operating mobile vaccine clinics throughout the city in the summer and fall. Through the mobile unit and funding from the CDC and United Health Foundation, we delivered 1,416 vaccines to help children remain in school and protect their health at our Doscella vaccination weekend events. We look forward to repeating this program again this year. CSS continues to expand reach through Children's National Telemedicine. Last December, I received a call about one of our students who I will call Jay to preserve anonymity. Jay had been in the emergency room multiple times for asthma exacerbations, and there was a significant concern about his health as we approached the winter break. During my chart review, I discovered that there was not an updated asthma action plan which guides the care for the patient. So I reached out to Dr. Patel, whom you'll hear from later, to coordinate a telehealth appointment for him at school. Through this innovative program, Jay's asthma action plan was updated and he was prescribed new medication, which is now administered at school. We've been working with his family to address the barriers that they have to receiving care by helping them schedule appointments and providing transportation. The groundbreaking work that we do through telemedicine breaks down barriers of social determinants and most importantly, gives children access to physicians who can provide needed healthcare interventions. Today, we are in 95 schools and will be in 112 by the end of the month. As of this week, we've performed 162 visits, 108 of them video. It's very important because 70% of children who participate in a telemedicine visit return to class instead of leaving school for care. Our care coordination plays a critical role in connecting families and patients to resources. Care coordination is a core function of effective healthcare delivery. However, it is woefully underfunded to support the complex needs of our most vulnerable children. We believe that continued investment in telemedicine and care coordination can significantly impact pediatric health outcomes. This year, after learning of great community concern around diabetes care in the schools, we hosted our inaugural Diabetes Summit, where nurses from across the city received training on technology and didactic lessons on the etiology of disease. We encourage council to introduce and adopt legislation that promotes access to life-saving medications to treat students who have asthma and diabetes. This includes supplying schools with undesignated albuterol inhalers and spacers, as well as glucagon to be used in emergencies. As mentioned by Dr. Newman earlier this morning, the shortage of healthcare providers is one that we are all very familiar. The unfortunate reality is this issue will only continue to grow in the coming years. The U.S. Bureau of Labor Statistics reports that the shortage of available nurses will only continue to grow through the year 2030. We recognize the need to reimagine how we provide care in the district and look forward to working collaboratively with DC health leaders to implement a new model using a health equity approach in which we can identify the needs of the community and work to deploy staff and resources to the most medically vulnerable and underserved. Thank you so much for your time today, and I look forward to answering any questions.
Thank you, Dr. Boudreau. Dr. Patel?
Good morning, Chairwoman Henderson and the members of the committee. My name is Shilpa Patel. I'm the Medical Director for Impact DC, which stands for Improving Pediatric Asthma Care in the District of Columbia at Children's National here in Washington, DC. Thank you for the opportunity to provide testimony regarding our work with DC Health. For over 20 years now, Impact DC has been working to improve the care for children with asthma in the district. In the interest of time, I'm going to focus my testimony on our pediatric asthma registry and our partnership with Children's School Services and Unity Healthcare. The pediatric asthma registry is a powerful population health management tool unique to DC and supported by DC Health. The registry allows viewing of real-time trends. For example, the registry detected a 20% increase in asthma ED visits secondary to the viral surge this past fall. Impact DC is also using the registry to identify a high-risk cohort, those with more than 5 ED visits, 3 hospitalizations, or an intensive care unit hospitalization in the past year. We will provide enhanced care coordination to reduce asthma morbidity in this specialized group. The registry has also helped to power a novel interactive healthy housing map. The map identifies multifamily buildings in DC with both high rates of asthma morbidity and unhealthy housing conditions. This map allows us to identify buildings with the greatest need so that we can make improvements and study the impact of improved housing conditions on the lives of children with asthma. Impact DC continues to partner with Children's School Services to improve asthma health outcomes. We work with case managers to ensure all children have an up-to-date asthma action plan and to identify and connect children who require improved asthma control. As you heard from my colleague, Dr. Andrea Boudreau, we look forward to working with Council to adopt and support stock albuterol legislation in schools. This legislation will allow children in emergency situations to have access to albuterol while at school, as any delay in treatment in an asthma exacerbation can increase the risk for hospitalization. Additionally, DC Health Support has enabled a unique, robust partnership between Children's National and Unity Healthcare. A key component of this partnership is data integration. We will incorporate data for over 16,000 pediatric patients into our existing data repository. Both Impact DC and Unity will use this enriched data to target the highest risk children with asthma and provide personalized outreach. The second key aspect of our partnership with Unity is expanding clinical care to those who need it most. We have helped Unity Healthcare successfully launch an Impact DC at Unity Asthma Clinic on site to expand our model of care and serve more children in Ward 7 and 8. This way, when high-risk patients who receive primary care at Unity are identified via the registry, the patient can receive Impact DC model of care at Unity without having to leave their medical home. We completed training of the Impact DC at Unity staff in early 2022, and I'm happy to report they've been successfully operating independently ever since. All of this paints a picture of more kids having well-controlled asthma and a better quality of life. Our goal is ambitious but simple: to eliminate asthma as a barrier to any child's ability to sleep, live, learn, and play, and grow up stronger. Impact DC is getting there only with continued support, commitment, and collaboration from DC Health. Thank you so much, and I'm happy to answer any questions.
Thank you. Beverly Wheeler.
Good morning, Chairman Henderson. Thank you for the opportunity to speak at this oversight hearing. My name is Beverly Wheeler, and I'm here today as the Chief Knowledge Officer of DC Central Kitchen. Since 1989, we have targeted the root causes of hunger and food insecurity with innovative programs that lower barriers to employment, create good living wage jobs for district residents, and bring nutritious, dignified food where it is most needed. We are proud to partner with the DC Health's Community Health Administration on the award-winning Healthy Corners program. For 11 years, this nationally acclaimed solution has taken on the deep-rooted challenges of food deserts by empowering local businesses to become robust, reliable access points for healthy, affordable food, while working with customers to increase awareness of healthy options, build trust, and expand their purchasing power when making healthy choices. Healthy Corners sales are at an all-time high for several reasons. First is our growing variety of products, including locally grown items. Local hydroponic lettuce sales are up 132%. Sales of our entire line of local products have doubled this year. Second is our intensive store owner assistance around SNAP and WIC. Healthy Corners has tripled the entire number of retailers accepting WIC in Ward 7 and 8 over the past 2 years. An especially critical achievement, given that Ward 7's newest grocery store does not accept WIC, and a Ward 8 grocer suspended grocery sales entirely late last year. We have spent the last year helping these retailers transition to eWIC, providing free upgrades to their point of sales systems, and training store owners and clerks while making major investments in marketing and awareness campaigns for WIC customers. Third is our SNAP Match initiative. Over the past 6 years, we have pioneered this produce incentive with powerful results. We now have 30 stores who are doubling the purchasing power of SNAP customers when they select fruits and vegetables, providing critical resources to 15,000 SNAP customers each year who are at elevated risk of food insecurity and chronic disease. Madam Chairperson, Healthy Corners is not going to solve food insecurity or health disparities alone, but it is a homegrown solution that continues to step up, innovate, and earn the trust of customers and small businesses alike. I hope you will continue to value DC Health's strategic partnership on this project the same way we do. I also hope you will work to ensure healthy food remains a priority in the DC budget. We cannot afford to revert to 2019 levels of funding and reach because the need for healthy food remains far above what our city faced during the pandemic. Let's work together to rip out food insecurity and disparities by their roots. Thank you.
Thank you, Ms. Wheeler. Mr. Broad?
Hello, Councilmember Henderson and Committee on Health. My name is Max Broad. I'm the founder and chair of DC Voters for Animals Education Fund. The Ed Fund works to lift up the policies and politicians doing the most for animals, whether it's companion animals such as dogs and cats, animals in farms or labs, and wildlife. There are 3 items I bring forward for the consideration of this committee in DC Health. First is values-based procurement for food served by DC Health. Second is the status and benefits of the Healthy Hospitals Initiative. And third is the important role of DC Health plays in managing the city's rodent population. So let's start with values-based procurement. The first thing I want to share there is just emphasizing the importance and value of values-based procurement. So, procuring food, DC Health has a big budget for procuring food, and in doing so, applying funds, not just based on cost, but ways that we can use our food systems to improve the quality of our food, improve the lives of DC residents across many different indicators of environmental and social justice. The Good Food Purchasing Program has been implemented by DC Public Schools, and there's a full coalition, the DC GFPP Coalition, working to support the success of the GFPP adoption in DCPS. And I encourage DC Health to consider the same thing as a way to improve the nutrition, social justice, and environmental impacts of our food systems. Secondly, healthy hospital food, which is a key area of food procurement. Consumers are becoming increasingly attuned to the benefits of food as medicine, which is why we applaud DC Health and the DC Hospital Association for adopting the Healthy Hospital Initiative to promote healthier choices in district hospitals. This program pledges to help hospitals lead by example by serving food that is low in sugar and sodium and rich in plant-based nutrition. But clarity is needed around the progress that has been made thus far, what's happened with the initiative and how are hospitals implementing the program's goals. This progress is imperative to improving our city or helping our city tackle nutrition related epidemics while improving the quality and benefits of our food system. Lastly, I want to recognize DC Health's role in rodent management and share that rodenticide and glue traps are 2 of the most prolonged and painful ways of managing rodent populations. In particular, anticoagulant rodenticides, also known as rat poison, has a very slow and painful death. The animal that ingests the poison will bleed to death internally over the course of 2 to 14 days. And rat poison poses an immense threat to domestic pets and wildlife who may eat the downed rat and then ingest the poison themselves. And DC's wildlife lovers and pet guardians alike know the threats of introducing poison into our ecosystem. So I want to commend DC Health's Vector Control Division for their nonviolent interventions that include solar trash compactors, installing wire mesh, and educating the public. I just want to wrap up by sharing a few other interventions they can adopt, including strong waste management, natural deterrence, restoring the ecosystem, and using contraceptives, which there's already been a pilot for and would love to see expanded. So thank you so much for your consideration of these topics.
Thank you, Max. Caitlin Wilson.
Hello, everyone. Can you hear me?
Yes, we can hear you.
Okay. Okay. Hello, DCPS, Council, and others. My name is Caitlin Wilson. I come before you all to make a desperate case for a school nurse at the Garnet-Patterson campus. I recognize that we've been told that there's a shortage, but the same has been said about teachers and the district. Oh, there we go. The district and many others in the United States of America have searched high and low to either find teachers or find a suitable temporary solution. The lack of a medical professional and a suitable clinic on our campus is risky, dismissive, and unsuitable for our school community. This is my first year with DCPS, So I experienced a transition in insurance, as most people do, which during this time, I experienced a lapse in my coverage while waiting for human resources to process my paperwork. During that time, I rolled my ankle in late September. I could neither seek medical care due to the lack in coverage, nor go to my school nurse because we did not have one. Also, I can recall intercepting a young man, an art state student, on the first day of school who exited the restroom with a large, freshly reopened wound on his hand. I supported the cleaning of it and stopping the bleeding with paper towels. I didn't know so much as where to go to find a Band-Aid, let alone a medical professional. This similar moment has occurred various times with other students due to the high number of student workers in the service industry, and our school has little to no ability to aid them appropriately. I'm ever concerned that the school nurse and the resources a school clinic provides may very well be the only place many of our young students receive medical support, particularly our immigrant population. Additionally, very recently, a colleague hit his head on the job site and had to leave the school to seek medical assistance. It was a minor injury. A nurse could have very well handled this situation, but he had to leave the classroom, our students, and the school grounds to find care. Finally, we are quite literally teaching and learning on a live construction site here at Garnet-Patterson, as the building is undergoing a beautification process. And to not have a medical professional on site is downright foolish. I consider this small act of healthcare and well-being to be a right, and I know I cannot be alone in my opinion. In my perspective, public schools exist as a mini beta utopia of inclusivity and equity. However, this issue has certainly challenged that viewpoint. Thank you all for your time.
Thank you, Ms. Wilson. And I think you're on the right panel, as we have so many of the professionals from Children's National that is our partner in the school nurse program. So thank you so much for your testimony. And I'm not sure if we don't provide nurses for the stay programs, but that's certainly something that we can follow up and ask in terms of that put together. Mr. Broad, thank you so much for your testimony. I don't think a lot of people realize that animal control services falls under DC Health. And I recently had an opportunity to meet with the Humane Rescue Alliance in terms of their work and the needs that they have, especially around needing a new building and the contract that's going on there. So thank you for being here. Ms. Wheeler, thank you for being here and for your continued advocacy around healthy food and nutrition. We recently met about the Healthy Corners program, and I still want to take you guys up on the offer of being able to visit a couple of the sites to be able to talk to some of the store operators, especially the ones who, what did you guys say? You put some slushy machines out of business in order for some more fresh produce vending to go into effect there. So thank you for that. And also, I guess kind of goes with a little bit, Dr. Dietz, who was on the earlier panel talking about school lunch. Kudos to DC Central Kitchen. I've tried your food. It is good. And the work that you all are doing there is great. I want to turn to the folks from Children's National. I feel like I should have put you on the panel with Dr. Newman, so all of you could have just like been together. But in particular, I want to start with Dr. Kruger. You talked a little bit about the school-based health centers at Ballou and Dunbar. DC Health provided us with some numbers in terms of total number of visits and what those various visits were for. One thing that stood out to me, and this kind of goes a little bit to, there was someone who was speaking about this earlier from KIP, or we're talking about dental, but there aren't any oral health visits for either location for Ballou or Dunbar. What is that about? Is it you don't have that necessary equipment on site there, or do people not know about the oral health piece? Can you give some insight there?
Yeah, great question. The dental health services are available there at Dunbar and Ballou, and we have had a dentist on site. Currently, it is 1 day a week based on the funding dental providers, and I do believe you have a few coming up in your panel in the near future. It's a pricey endeavor, and so there have been dentists on site for the past few months. In the earlier part of the year, it was hard to get someone in, and now we have someone who's available, but we have had a hard time getting some of the patients and students to be aware when we're there. So we just did a dental hygiene fair to help bring up the recognition that we have the services available. And at this point, just continued outreach is our plan to help them understand that the services are right there.
Right. Because I mean, you know this, right? Prevention is super important, or getting that preventative care before it develops into something more serious that requires surgery or, you know, something else to that effect. And I've seen the mobile dental unit that Children's has in partnership with the Washington Nationals, which it's a fabulous setup that you all have there. But I think as we talk about the whole child and whole wellness, we want to make sure that we're including dental in that conversation. And I see on the next panel, we have some folks from the Dental Society. So I think they probably would agree with that. Dr. Patel, and I guess it was sort of, Dr. Boudreau, you kind of mentioned this as well. Hear you all loud and clear in terms of needing to make albuterol and glaucon more accessible and available. We're working on that legislation. So just so you know, we're going to get there on that front. But I guess the one question I have is, would this require a standing order in the similar vein that we had to do for EpiPens?
Yes, it would.
Okay. All right. That was well, you guys remember that was a bit of a controversy last time of turning to find a physician who was willing to do a standing order for the whole city. But I feel like that is a role for DC Health. You are the state health agency. You should be able to do a standing order for the quote unquote state, well, the future 51st state, if you will. So thank you for that. Dr. Patel, you know, in the data that we have around the number of students who have an asthma action plan, we made some strides from 2021 to 2022. Are we on target in your feelings around being able to meet our goals for 2023?
I think so. I think one of the latest advances is the electronic asthma action plan that I think is actually going to make this task even a little bit easier, not only to identify which patients in our registry who have asthma, and more importantly, persistent asthma that don't have an asthma action plan, and then coordinate with our children's school services. So I think the EAAP is really going to help. In addition to that, like I said in my testimony, Dr. Boudreau's team and the case managers at Children's School Services, we work actively on a regular basis to identify patients who rise to the top. I just got an email yesterday about 50 kids who need them, and so we're going to be working to getting them into our clinic. So I think the answer is yes, and there's many things that are that bode well for that promise.
Okay, great. That's awesome. And you know, this is something that has come up quite a bit, or at least, you know, even back when I was a staffer, sort of trying to understand how we can get some coordination on this. In terms of the work of Impact DC, I know this is a health hearing, but has Department of Buildings, formerly known as DCRA, and the Department of Energy and Environment been helpful as you all identify these buildings that have the greatest need?
I think I'm going to have to circle back on the details about that. However, we did recently apply for a DOEE grant to help with individual outreach and video home visits, continuing that program for our patients. So we hopefully will hear back on that funding soon. And they are our partners. So we do refer to DOEE when we have patients who are hitting roadblocks with their landlord. The map is new, so outreach in terms of, specific agencies in the city is kind of ongoing and just started. But we have also pending partnerships with large funders to possibly do, like I said, a single kind of demonstration pilot project to really take the building with the highest asthma morbidity and housing issues and renovate and then follow using our registry the asthma outcomes for those patients who are living there. So that is something that's on the horizon. And we'll have hopefully more information later, but I agree. We are in the process of also reaching out to our local partners on those issues.
Okay,
and
great.
the map is available. It's a public link, so anyone can access it. I know Dr. Boudreau looks at it regularly for her.
Good. Well, that's good. I mean, I think I have some questions for DC Health in terms of the inspector situation, right? Like, this was a thing that I found so bewildering and very frustrating when I first became a council member, is that we had no fine structure when there was mold. Then we had no inspectors who was certified on mold. And we know all of these things are connected, but we need all parts of the government to be working together. And again, it goes to those larger social determinants of health, because it's not necessarily DC Health's responsibility as a whole, but how are they working with the agency partners around some of these things as well. I am well over my time, my gosh, but you guys are covering so many issues. Dr. Brooks, I didn't even get a chance to talk to you about Healthy Steps, but you know, the testimony from the witnesses on the prior panel in terms of the quality and effectiveness of the program. I'm hoping that we can see an expansion in terms of the work that you all are doing there. Dr. Boudreau, I don't know if you heard yesterday's hearing, you had some colleagues who testified there, but on school nurses, this is an increasing challenge. And obviously we talked to Dr. Newman about that before. I am interested to hear from DC Health how your all's conversations are going about how we perhaps revamp this program to best serve the needs of our public and public charter schools to make sure that everyone has access. I have to keep moving because I have to, or we're going to be here all night. And so thank you so much for your testimony. Please make sure we have your written testimony. Dr. Patel, I'd love to follow up. Dr. Boudreau, I'm going to talk to you. I'm sure of that. And Dr. Kruger and Dr. Brooks, thank you so much for being here, and for all of the panelists who testified today. So thank you so much.
Thank you.
Okay, we're making progress. We're halfway there, y'all. Almost halfway there. Next panel, we'll have Dylan Craig, Clarissa Williamson, Sarah Barclay Hoffman, Tanya Pita, Camilla Perez, Kurt Gallagher, Gerald Marlin, and Samantha Trumbull. I see Dylan. So Dylan, why don't we go ahead and have you get started?
All right, thank you. Good afternoon, committee members. I'm Dylan Craig, a teacher at Roosevelt State Opportunity Academy and a Ward 4 resident. I am testifying today to raise awareness about our immediate need for a nurse at Roosevelt State Opportunity Academy. First, I want to thank the council so far in their support for Roosevelt State community, especially regarding our move to the Garnett-Patterson building and our push for safe and appropriate facilities for our students. We are grateful for our space and the plans for a health suite to be built out this summer, and hopefully also a very necessary childcare facility once we get the mayor's support. However, right now we need to bring attention to how our community is currently suffering without a nurse on campus. We often serve a vulnerable population at Roosevelt State, including many expecting mothers. Without a nurse on campus, we have frequently had to call an ambulance for students facing health concerns that need immediate attention. Waiting for an ambulance is incredibly uncomfortable and scary for our students, especially when there is no healthcare practitioner in the building to respond right away, putting both the student and sometimes an unborn child at risk. It is not hard to imagine the terror an expecting mother feels when they're at school, a seemingly safe city facility, and they begin to feel pain only to learn there's no nurse on campus to take appropriate measures. Even beyond this specific population, we just need someone in our building to administer medication, provide basic health supports, and advise if further medical attention is necessary for all of our students. We are leaving our students at risk of not receiving proper treatment when an emergency arises. Even our, even our most well-trained staff do not compare to a licensed nurse when a student's health is at risk, or worse, their life. Knowing our student lacks a nurse on campus is enough to keep some students from coming, pushing them further and further away from earning their diploma. Our students can spend 40 hours a week with us, and that is too much time to be away from proper health resources. Also, given the older population we serve, many students are aging out of their pediatric providers, and most have not yet developed relationship with adult providers, putting them in even more of a precarious position. I understand that there's a nationwide nurse shortage, and we are not the only school suffering due to this issue, but it's important that the council understands Roosevelt State's particular need and the urgency of finding a solution now. The risks are too immense to wait and ignore. Thank you for taking the time to listen and for all that you do.
Thank you, Mr. Craig. Clarissa?
Chairwoman Henderson and committee members. Thank you for the opportunity to speak today. My name is Claire Williamson, and I have been a home visitor in the District of Columbia for almost 7 years. Currently, I work with the Parenting Support Program at Georgetown University, which supports parents with intellectual and developmental disabilities, or IDD. I am also a supporter with the U3 DC Home Visiting Council. District families are often among the most stressed about their economic well-being. Home visitors provide expectant parents and families with young children the support and positive reinforcements necessary to manage their family life alongside a challenging external environment. My testimony today focuses on continuing support for the role of home visitors, as well as the advocacy for home visiting that creates a strong, effective, and connected early childhood system within the district. Home visitors, like childcare teachers, have been some of the most dedicated yet underpaid professionals working with the district's families and children for years. As a home visitor, my values are building parental confidence and supporting equitable parent experiences. These values matter to me because it has led to positive family outcomes and strengthened the parent's voice. In the work that I do at PSP, I've seen many families benefit from a program that allows home visitors to focus on supporting the family's unit and overall well-being. DC Health recognizes the unique support needed for parents with IDD and continues to strive for building parental confidence and trust in DC Health and other community resources available. Home visitors are crucial in supporting the whole family and building trust with the caregiver. Home visitors across programs are doing great work. At the same time, home visitors in programs are experiencing huge turnovers due to the limited opportunities for advancement in their careers. Increasing wages for home visitors will help retain a workforce critical to achieving the district's goal of reducing maternity mortality and building a first-class early childhood system. I would like to take the opportunity to thank DC Health for seeing the need for home visiting and ask for your support for the continued growth of the home visiting profession. Thank you, council member and committee members, for hearing my testimony today.
Thank you. Sarah?
Good afternoon, Chairwoman Henderson and members of the committee. My name is Sarah Barclay Hoffman, and I am the Policy Director of the Early Childhood Innovation Network, also known as ESIN. We are members of Under 3 DC, and I thank you for the opportunity to testify. Sound mental health is the foundation that supports all other aspects of human development. It begins in the earliest years, prenatally, and the experiences in an infant and toddler's life can strengthen or disrupt their emotional well-being. Supporting the mental health and concrete needs of parents is one of the most important strategies we can deploy. Healthy Steps and home visiting programs are evidence-based upstream interventions that accomplish this and more. As others have noted, Healthy Steps is a national program that integrates early childhood supports and staffing into the pediatrician's office. There is a significant evidence base speaking to the positive outcomes and cost savings of Healthy Steps. Preliminary results from a recent local qualitative study indicate that Healthy Steps plays a crucial role in pediatric primary care and supports caregiver mental health, which is essential to healthy child development. We commend DC Health for their steadfast support of Healthy Steps. We look forward to the coming expansion of Healthy Steps in DC with a new locally funded site utilizing FY23 funds, and also applaud the investments the council has made over recent years in Healthy Steps. Furthermore, we appreciate DC Health's participation as a steering committee member of Easton's Prenatal to 5 Capacity Building Collaborative, a local public-private coalition focused on strengthening investments and improving equity in health services that support DC's infants, toddlers, and families. Healthy Steps sustainability is a focus of the collaborative's policy agenda, and we look forward to continued partnership with DC Health and other agencies in this area. While there is widespread support for Healthy Steps, workforce shortages pose challenges. To address service delivery and workforce issues, we support recommendations highlighted in the Path Forward report. We also recommend maintaining current investments in Healthy Steps so that this model can continue to pay dividends in DC. As you have heard, home visiting is another critical evidence-based strategy that helps meet the physical and emotional health needs of young children and their families. We support an increase to existing home visiting grants at DC Health to adjust for inflation and support workforce retention. Easton appreciates DC Health's work to support Healthy Steps and home visiting programs and investing in young children and families in DC. We look forward to continued collaboration. Thank you again for the opportunity to testify today, and I welcome any questions the committee may have.
Thank you. Betiana?
Dear council member, thank you for the opportunity and the platform to share with you today. My name is Betania Panetta. For the past 2 weeks, I have been training for my new role as program supervisor for the Healthy Families America home visiting program here at Mary Center. But for the past 2 years, I had the opportunity to work as a family support worker. For the entirety of my time as a family support worker, I did have to work a second job to ensure I could live comfortably. At times, I felt overworked and drained, and I would think about how my retail job was in fact paying me a higher hourly rate than for the work that I do with my profession with an actual degree. The uncertainty of being able to survive my FSW salary alone is what kept me working twice as hard, but never discouraged me from continuing the meaningful work that I do. And as I step into my new role, I have been thinking about the low compensations of home visiting from a different lens. I've been thinking about my colleagues and team members who won't be receiving a merit increase this year from our institution. And I think about how each of these team members and their families will be impacted. The insufficiency of home visiting salary indeed has led to much turnover in our staff, and as we continue to provide services to families, us, the team members that stay, have to take on additional work for the same pay. So I'm confident that stronger investments will aid my team in hiring the right candidates to continue providing support for the families in need. And I'd like to share a little bit about myself, as I am a former recipient of services like home visiting. And I'd like to think that I'm a product of success that comes with these types of parenting support and early education programs. As a child, I participated in the early education multicultural program along with my mother, who was able to engage in parenting classes, English and computer classes. This type of support was super essential to my family, and it aids families in connecting with different resources and services in the district. It builds parenting confidence skills, provides guidance from professionals without fear of judgment, and gives the opportunity to meet other parents within the community. This type of support definitely does strengthen a community. I'd like to think that this specific program made a difference in my upbringing and my academics, and I can say that I owe part of my success to them. And here I am today providing supportive services to families who are looking for a sense of home and occasionally need a shoulder to lean on. So recently I seen a quote that really spoke to me. Social work is the art of listening and the science of hope. And this is the perfect way to describe what home visiting is. The work that we do as home visitors, we have to wear many hats. We are case managers, counselors, teachers, advocates, resource providers, translators, and too many other roles to name. But regardless of the hat that we wear that day, we often have to lend an ear, and we leave our participants with a sense of a hope for a better tomorrow. As in my own experience, early childhood and family services such as home visiting led to a positive family outcome. What makes home visiting so special is that we can prioritize the well-being of a child, not only by helping the parent build strong bonds and attachment with their children, but also by helping reduce the likeliness of child abuse and neglect. Home visiting makes for stronger families and even stronger communities. By investing in home visiting, you are giving your own community an opportunity and direct connections to a preventative approach to overcome barriers that impact their day-to-day life. So I ask that you support us as we continue to collectively work to support families and see them thrive. Thank you.
Thank you. Camilla?
Good afternoon, Councilmember Henderson and committee members. Thank you for the opportunity to testify today. My name is Camila Perez, and I'm a community health worker in the home visiting department at Mary Center. I'm going to express gratitude to the current investment into our program as a the opportunity to partner with families to focus on their well-being. Personally, I know how beneficial social programs are because growing up, my family accessed social support, healthcare, health education, and services like the ones offered through Mary Center's home visiting program. It is essential that DC continues to make sustainable investments into home visiting to make sure that the workforce can continue to have long-lasting positive impacts in the lives of our neighbors and families in DC. I want to share with you an example where I supported a participant in the home visiting program. Sometimes support can be as simple as asking, "How are you doing?" and holding space for them to answer. During the enrollment process, we complete screenings to check in on our participants' emotional well-being. It was during one of these screenings that I noticed Mom beginning to choke up. The participant told me that no one had checked in or asked her how she was feeling emotionally. I paused the screening and asked if she would like to share what was on her mind. Being participant-centered allows us to build a strong connection from the start, and it was here that we began to build our professional relationship as home visitor and participant. Because of the rapport I was building with Mom, we could have honest conversations about her health and well-being. Mom felt like she could safely explore and share the challenges she was facing with me. This is important because as Mom progressed through her pregnancy, complications arose, and I provided health education on her gestational diabetes diagnosis. With my support, we were able to reiterate the importance of managing her gestational diabetes for her and her baby's health, as she was reluctant at first. Through conversation, she realized it was vital for her to take ownership of her health during and beyond doctor's appointments that she had previously been ambivalent about. She shared that food insecurity was also making it difficult to make healthier choices. We worked to connect her to a food bank and reviewed the WIC approved list so she could better self-manage. The mom has been able to take steps in the right direction and make those necessary changes, and I see how proud she is of her efforts, and I enjoy celebrating these victories with her. Home visiting helps families build a positive and meaningful relationship with organizations and professionals focused on public health and well-being. But it is a challenge to deliver services successfully when home visitors tend to have a high turnover rate. Families want to be healthy and well, but if the workforce is not supported, more departure means more difficulty in successfully supporting families and their health. My participants really benefit from this program. Participants can improve outcomes for their children and themselves because of the support and resources we provide for them. By ensuring that home visiting programs are funded and home visitors receive thriving wages, we can reduce the interruptions families face when working to access services. Home visiting is an investment in our community, and as Councilmember Henderson says, your zip code should not determine your opportunity for success. So by continuing to invest in home visiting, we can support families and improve their health and well-being. Thank you.
Thank you. Kurt?
Good afternoon, Chairperson Henderson and members of the council. Thank you again for the opportunity to testify today. I want to expand upon some of the comments I offered during Tuesday's hearing, and I'll be followed by a longtime DC dentist who can testify personally to some of the challenges of staffing and licensing in DC. During the 22 performance oversight hearing, I offered the following recommendations, and I offer them again. I just want to provide a reminder that all of our efforts to build the healthcare workforce, which are laudable, will not be successful if those professionals are not able to secure a license once they come to DC. Number one, I recommend that DC Health improve the communication and responsiveness with those whose license application is not automatically approved upon submission through the licensing portal. It is a great success that a large percentage of applicants were approved automatically, but I want to focus on those who didn't have that experience because those are the members and professionals who are having challenges. Applicants should receive a detailed list of deficiencies or missing items from the application so they can correct them. And that list should be provided within a timely timeframe, ideally when they submit their application. In cases where applicants have reached out to the DC Health, some of them have waited weeks and sometimes months for a response, and those requests have come to us, which is how we become aware of those challenges. Number two, DC Health should improve the time frame in which it updates applications once additional documentation is provided. Sometimes, again, days and weeks can lapse before applications are updated and the applications can be approved. And then finally, I would encourage the council to request that DC Health report meaningful statistics on licensing processing trends. And it's important to separate those who had their licenses approved automatically from those who are having a challenge. If they're all included together, the statistics will be skewed. But specifically, we encourage the council to request data related to the number and percentage of applications that are automatically approved. Request data related to the number and percentage of applications that are approved after a manual review. Data on the number and percentage of applications that are in process, including a meaningful breakdown of the number of days that have passed since the application was submitted. And this last statistic might be helpful for all advocates moving forward in identifying problems. A meaningful breakdown of the cause of delay, such as if a specific type of document is missing, or if applicants lack clean hands, or if there's another cause. And then finally, a number of requests for assistance received in the days that it takes to resolve those requests for assistance. We will provide additional details in our comments in writing, but thank you again for this opportunity to testify today.
Thank you. Mr. Marlin, Dr. Marlin.
Good afternoon. I'm Dr. Gerald Marlin. I've been practicing as a prosthodontist in the District of Columbia for 45 years. And I'm concerned that there is problems that the district is encompassed with issues. There is I've been dedicated to practicing in the district to the point that I am only 100 yards from the Maryland border. And yet I've opted to be in the district, practice in the district, but in 3 years from now, I have to seriously reconsider that thought. Why is that? The district is in danger of becoming a pariah in the dental industry. It doesn't matter whether you're a doctor, a dentist, it doesn't matter whether you're a hygienist, and it doesn't matter whether you're a dental assistant. You don't get the responses that you are supposed to get on a timely basis to do the necessary paperwork. We're talking about candidates that don't have to take any tests. They're already licensed in other areas from the people that I've been hiring. As an example, I hired a hygienist from Jacksonville, Florida, and she was willing, she wanted to come to the District of Columbia. She wanted to practice here. 3 weeks later, nothing was happening, so she opted out. Followed by another hygienist who obtained her Virginia license within a week or two. 2 months later, she still didn't have it until at the very last minute she got it by starting off with emergency. Then there's dental assistants that haven't been able to be hired. And now we're talking about the reputation of the District of Columbia and people opting out of coming to this area. The ramifications, in my opinion, are huge. And once a negative takes hold, it can possibly take up to 10 years before people with dentists want to open practices in the district. And I suspect there's going to be several dentists that are going to leave because the cost of doing business is way too high. We all know that if it takes so much time to get your licensing done, you're going to be thinking hard and a lot fast about whether you even want to come to the district. At the end of the day, it comes down to 3 words: accountability, technology, and standardization. And what I mean by that is accountability to get the job done, answer the questions, respond to the email. I raised the question and I realize I'm slightly running over. I raised the question whether you should have a software program for licensing all the professionals in the District of Columbia. Why not? If we can do it in the other states, if we can do it in the motor vehicles in other states, why can't we have something more automatic so that the huge load gets eliminated? I ask you to be thinking about that. Secondly, I raised the question whether the standards for the dental assistants are so high that it is cluttering up the system. You must have somewhere between 1,500 and 3,000 dental assistants. That's going to make all the work that the board has to do in the paperwork to get it done, makes it even more difficult. I thank you for your time, and I hope we can see some rectification. Thank you.
Thank you. Samantha?
Good afternoon, Chairwoman Henderson and committee members. Thank you for the opportunity to enter this testimony into the record. My name is Samantha Trumbull, and I'm here as the Executive Director of Common Good City Farm. Common Good has been located in Ladroit Park since 2008 and has been a Produce Plus vendor and farm market since 2017. We have seen time and again how Produce Plus has made it possible for families, and especially seniors, to access fresh and healthy produce. Since 2021, Common Good has been operating a pay-what-you-can farm market to ensure that our market is accessible to all, regardless of their ability to pay. In its first year of Pay What You Can, our tiny market gave out more than $15,000 worth of subsidized foods, mostly fresh vegetables. This program most often serves individuals and families who fall into benefits cliffs, those who have decent income and therefore can't participate in food assistance programs, but also have high expenses due to medical costs or other household expenses. Because customers can pay what they are able, and sometimes nothing at all, we often have Produce Plus shoppers who spend their full Produce Plus benefit amount, in addition to putting some of our subsidy to use. It's clear to us that there is a significant need for fresh produce among our neighbors, as they're spending their full Produce Plus benefit amount plus some. Because of our unique market, I'm able to reflect on some additional data points that you may not have otherwise seen. In 2021, before the benefits were switched to monthly amounts and the weekly benefit for Produce Plus was $20, more than 65% of Produce Plus shoppers went over their benefit amount each week. When that happened, customers spent an average of $8 more than their benefit amount. We've also seen over and over how those who don't make it into Produce Plus continue to need support. Common Good staff went door to door at neighboring public housing complex to sign up neighbors for the program last April. However, week after week, too many of those residents came back to the market to ask when they would be able to participate, and we continually had to tell them that they were unfortunately still on a waiting list. Our Pay What You Can market subsidizes those customers as well. However, the reality is that we shouldn't have to raise tens of thousands of dollars from private foundations to provide this public good. We need our elected officials and representatives to fully fund programs like Produce Plus as an entitlement. Everyone who qualifies should get benefits in an amount that will meet their needs. We asked the council to add $460,000 for the Produce Plus program, raising its budget from $1.5 million annually to $1.96 million. These funds will empower Fresh Farm and the farmers market community to address the significant demand for this acclaimed nutrition program by increasing the number of DC residents it serves by 30% to a total of 8,000 people. This will address the critical need of 4,500 seniors and other food insecure DC residents in wards 5, 7, and 8, building upon last year's investment. Thank you for considering this request. We look forward to a successful market season, and we hope to see you on the farm for a visit soon.
Thank you, Sam. And thank you to all of the public witnesses who testified. Dylan, I'm not sure if you're still here because I think you might be teaching. But we're going to check in on the school nurse situation for Roosevelt Stay. Like I said before, I'm not sure if the stay programs are not included. So for instance, does Luke C. Moore have a nurse or not, or Blue Stay? So we'll check in on that. Claire, thank you so much for your testimony and sharing your experience being a home visitor. And I appreciate that you've been doing this for for a little bit of time now. I'm not sure if you heard from the earlier panel, also talking about home visiting as well. You know, based on your sort of lived experience as being a home visitor, what would you say is like the top 2 things we need to do to be able to recruit more people to do the work that you do?
Probably, I probably don't have top 2, but I think one of the major things is increasing in wages. Not being able to sustain a living definitely turns over home visitors. And again, like Ms. Panita was saying, it kind of leaves families without support in the district.
Okay, thank you. That's very consistent with what we've heard, you know, from all the folks in that program. So appreciate the other folks who testified about the home visiting program. Mr. Gallagher, thank you for being here. Definitely heard you loud and clear in terms of your testimony on Tuesday and then now even today. And Dr. Marlin, I appreciate you providing a little bit more color to the specific issues that are facing the dentistry industry. You know, I did almost longer than an hour, almost 90 minutes, sit down with DC Health, just looking specifically at their licensing system. And I got a chance to see what it looks like on their end in terms of the software updates. And I know that they have plans to make some other additional changes to better help with the usability. But there were some things that came up with the hearing on Tuesday around, you know, what do we have enough people who are available for customer service to be able to just even answer the phones when somebody calls about a question in terms of their application? Are there other different types of things that folks can see? But Dr. Marlin, it also sounded like in your testimony, you were saying it's not just about the licensing piece from an application standpoint, but that perhaps we have some requirements here in the district that others don't. Is that, or did I hear that incorrectly?
No, you heard it correctly. Realistically, dental assistants, some of the requirements appear to be awfully stringent, and I would encourage you to work with Mr. Gallagher, who can be in contact with other dental societies in other states and verify for you that perhaps we need to rethink how restrictive we are with that area. If you think about it, there are 1,500 to 3,000, somewhere in that range of dental assistants. And if you requirements are so high, then you're clogging up the system inherently. And I think that is something that's going to be very difficult to overcome unless you reassess exactly what do we really need for patient effectiveness and safety. After all, working in a dental office side by side with a general dentist, I'm a prosthodontist, I'm a specialist, but working together with general dentists or prosthodontists or any of the surgeons, they're under the supervision of the dentist to begin with. And everybody is wanting to do their best job and their best quality. So they're going to walk through the path of making sure that their dental assistant is doing the best that she can do. So I encourage you to that. And the other thing I'd like to make as a point that I think is very important. There's probably, I'm not familiar with this, but there's most likely software programs that allow all this licensing to go on in a much more cohesive, rapid manner, especially with each generation moving up of the younger ones who are so facile. All of this could be handled in such a timely basis. It almost comes across as cavalier, the fact that my hygienist had to, over a 2-month span, had to make 2, 3, 4, 5, 6 interactions. So is that the way it should be? So I bring that up as well, because that's really clogging the system, because probably answering 1 or 2 emails would solve it, especially in this day and age.
Right. And, this has come up before in terms of, the committee last year added some additional staff for HRLA to help in terms of licensing processing. But how that staff is allocated amongst the various boards varies based on volume, right? In terms of what we're dealing with. The number of dentists is obviously less than the number of licensing certifications that they're doing for the Board of Medicine. And so there can certainly be improvement. So we'll definitely bring that up. And I've also sort of shared with my staff too, I think Dr. Lewis would admit this, I feel an update to the health occupation regulations in our future coming up. So, we can get to some of these things there as well. But thank you so much to all of the witnesses for your testimony today. We're going to move on to the next panel. And just as an expectation setting for where we're going, because I think we're going to be on number 49 here. After this next panel, we need to take like a 5-minute break for my staff and I and the cable television and the support services who are here. And then we will come back and we will finish. And then we will take another break between public witnesses and the government witnesses to allow for our government witnesses to actually come over because they'll be here in person. So with that, we'll call up the next panel, Suzanne Bathgate, Pamela Hess, Elizabeth Talferroa, Patricia Quinn, Carrie Vaughn, Alicia May, Josephine Shu, and Samira Washington. And as a reminder for those who are joining us, you have to affirmatively accept our invitation to be elevated as a panelist. Okay. All right, I see Dr. Bathgate in the attendee room, so just giving her a moment to be promoted. Awesome. All right, Dr. Bathgate, you are first on this panel.
Can you hear me?
Yes, ma'am.
I can't see myself, so thank you.
Okay, we can't see you either, if that was what you were hoping for.
I was hoping for that, but in the interest of time, I may not fool around with it and just talk. So I apologize.
That works. No problem. Go ahead.
So I'm speaking today on behalf of the Medical Society of the District of Columbia, which is the largest medical organization representing metropolitan Washington physicians in the district. Thank you for the opportunity to testify at today's hearing. The MSDC encourages the committee to consider the following during the budget process: to implement regional license reciprocity as soon as possible. The Board of Medicine has shared regional reciprocity should be online in the summer of 2023. The council must keep the boards to this timeline, ensure the DMV license reciprocity process is fully operational, including IT infrastructure. Also reform the certificate of need process. MSDC is disappointed in the department's interpretation of the district certificate of need process to increasingly include private practices that traditionally have not had to inquire about certificate of need. We urge DC Health and the council to refine the CON statute to ensure practices making nominal changes such as hiring a replacement for a departed employee do not require a certificate of need. Third, provide grants for physician wellness. The Mayor's Healthcare Workforce Task Force has numerous recommendations on physician wellness. At that time, we encouraged the department to provide grants for private sector wellness initiatives. This is a big issue that requires big thinking. Fourth, to publish and share workforce data. The physician survey attached to the license renewal application is a robust source of data on the district's physician population. In previous cycles, DC Health has published infographics and reports from the data. The last cycle had none of this. DC Health should continue to publish information from the workforce survey, and if helpful, work with private sector sources to interpret the data. Fifth, to support the Mayor's Healthcare Workforce Task Force survey. MSDC was proud to serve on this important task force and supports many of the recommendations, including the call to reform prior authorization. DC Health and the Council should work together to adopt these recommendations as soon as possible. And lastly, to resist scope creep when considering reforms to the HORA. DC Health has been sharing that it is preparing an update to the HORA. We urge DC Health to resist what other states have done when reconsidering their health licensing laws. Change scope of practice laws to reduce requirements to practice medicine. Please reach out to the MSD office if our membership can be of assistance on these or any issue. We look forward to working with you and the committee to make the district the best place to practice medicine.
Thank you, Dr. Bathgate. Pamela Hess. Elizabeth Telfara, Dr. Telfara.
Hi, should I go?
Yes, it's your turn.
Okay. So good morning, good afternoon, Councilwoman Christina Henderson and members of the Committee on Health. Thank you for the opportunity to address the council today. My name is Dr. Liz Talafero, my pronouns are they, them, and I'm a resident of Ward 4. I'm testifying about the Department of Health's early childhood home visiting programs, which the agency funds both directly and through MIE-CHV funding. As a pediatric resident here in DC, I work in various clinical settings. In certain settings, such as in the hospital, I am meeting families at one of the hardest moments of their lives, the illness or injury of their child. In other settings, such as in the primary care clinic, I have the benefit of getting to know families outside of moments of acute crisis. What remains consistently true in all settings is that most children spend a very small fraction of their time interacting with the healthcare system. As such, their health is impacted by many factors beyond the hospital or clinic walls. The care that we physicians provide in the healthcare setting is not enough on its own to allow families to achieve the healthy lives they deserve. Home visiting programs meet families where they are in ways that healthcare providers cannot. I'm planning to pursue a career in primary care after my graduation in June. During annual checkups, in addition to completing a physical exam, we talk about nutrition, sleep, school, and home life. It's a privilege for families to trust me with this level of knowledge of their lives, and I often learn about barriers to health that cannot be fixed with a medication or referral to a specialist. For example, families who cannot afford healthy food options or do not have access to healthy food options do not only need information about nutrition, they need resources. Families who are struggling to navigate the challenges of parenthood, both general and unique, need someone who can meet them where they are to provide emotional and tangible supports. Home visiting addresses many of the issues we uncover in the pediatric setting, but do not have the capacity to directly impact. Home visiting is an evidence-based strategy that connects families with a trained professional who guides caregivers with resources, skills, and general support to reach certain outcomes. As a pediatrician, I daily confront the way that social determinants of health negatively impact children's health. However, I know that home visitors can mitigate some of these harmful effects. As such, I strongly support increased funding for home visiting programs in DC. In 2022, DC Health funded home visiting programs served 768 families in DC. Many of these families and the home visitors have shared their stories on various platforms, including some testimonies here today, reinforcing the benefits of home visiting and the programmatic challenges due to limited funding. Please strongly consider these stories when deciding whether to support increased funding. You have the power to significantly and positively impact the health of children and families in DC in a way that I as a physician long to, but cannot. Your investment will be worth it and the benefit to the health of these families and to the DC economy and community at large. I hope you choose to make this investment. Thank you for your time and consideration. I'm certainly available for any questions or comments.
Thank you. Patricia?
Good afternoon, Councilmember Henderson. Thank you for the opportunity to testify today. I am Patricia Quinn. I'm the Vice President of Policy and Partnerships at the DC Primary Care Association. DCPCA has as partners the 8 federally qualified community health centers and other community health centers across the district. They serve almost 200,000 patients in every ward of the city. Our members serve the district residents most impacted by inequity. 95% of health center patients are racial or ethnic minority. 88% have incomes below 200% of the federal poverty level. And 37% are best served in a language other than English. Health centers are at the nexus of the efforts to rewrite DC's story of health inequity. And we're grateful for the partnership we've forged over decades with the DC Department of Health. That partnership has only strengthened through the crucible of the COVID pandemic. I will focus today on the Office of Health Equity and on healthcare workforce. In 2018, the Office of Health Equity released a seminal health equity report that directly linked health outcomes to 9 drivers of health that impact quality of life and life expectancy for district residents. They followed this report with a Health Equity Summit in 2021 that amplified the roots of inequity that resulted in such disparate impacts of COVID-19. OHE focuses on facilitating multi-sector partnerships to identify and solve community health problems related to the social determinants of health. In that capacity, OHE has engaged DC PAC, a cross-sector collective impact coalition facilitated by DCPCA and focused on building an accountable health community that provides the care and social conditions for racial equity, health equity, and community well-being. They are a lead partner in a recent proposal that we submitted to Robert Wood Johnson Foundation focused on the role of data in dismantling racist systems. DC Health's commitment is a model for how government can partner with residents to build community power. DCPCA, like other healthcare organizations, is gravely concerned for the state of the healthcare workforce. An informal polling of just 3 federally qualified health centers revealed over 175 vacancies today. FQHC CEOs have frequently discussed major challenges in recruiting and retaining, particularly the behavioral health workforce needed to meet the needs of their patients. In a comparison between 2019 and 21, every DC health center saw a decline in the number of behavioral health visits. Given what we know about rates of anxiety and depression and substance use disorder and the exacerbation of behavioral health conditions during the pandemic, this decline is alarming. DC Health convened the Mayor's Health Workforce Task Force, an all hands on deck call to identify viable pathways to meet health workforce needs in the short and long term. The recommendations for licensing, payment, reducing provider burden, building public trust, eliminating barriers to entry, and defining career pathways, and youth exposure and immersion to opportunities should all be adopted if we hope to ensure residents access to high quality health care. DC Health plays a critical role in health outcomes for every individual and every community in the district, and we're grateful to have the committed partnership of DC Health for the work still ahead. Thank you. Apologies
Carrie?
for going over.
Hi, good afternoon, Chair Henderson. Thank you so much for allowing me to speak. It's been really fascinating listening to everybody this morning, so I'm kind of envious of this interesting job you have. I am a resident of Ward 6, and I work as the farm director at Building Bridges Across the River, and we have 7 urban farms in our network. And we have a farmers market that we run and also a CSA. CSA stands for Community Supported Agriculture. It's like a subscription program for people to get fresh produce. So my top level message is similar to other people who have spoken about Produce Plus. We really need to increase funding for Produce Plus. Specifically, we want to add $460,000 to that program, which will add another 8,000 residents who can participate. And I just want to specifically contribute our experience, both growing the produce in the city and also distributing it, that produce, as Produce Plus funding goes up, people really use that funding. They are excited to have it and they get produce from us. And then we are better able to support the work of the people who are growing the vegetables. So I think this is a really great program, really well received by customers, and of course, really important to us as the providers of produce in the city. In Ward 8, as you know, we only have one full service grocery store, so a farmer's market really makes a big difference in the neighborhood. Also, I come to this having been a vegetable farmer for 20 years in Prince George's County, Maryland, just over the border. So currently I'm a DC resident, but not that long ago, I was living in Maryland. And I just want to speak to the fact that, in addition to getting produce from inside the city, we really only have a couple of acres under our management. We would really need about 20 acres in order to feed the number of people that we're serving on a weekly basis at our market. So of course, we end up buying produce from nearby farmers. When I was a grower in Maryland, I established close relationships with my customers in the city. And when COVID hit and everybody else was suffering these supply chain problems, we were still so closely linked with our customers and they were still getting produce from us. So Produce Plus is also benefiting the farmers in our very close region that are making such a huge difference in the lives of the residents of the city. So even though that money is going just over the border into Maryland as well as into the city, it's really all kind of coming back to benefiting city residents and this tight network of help that we have for each other. Okay, thanks very much.
Thank you. Alicia May, see you in the attendee room, but you have to accept our invitation to become a panelist. So we'll give you a minute. I don't see Josephine. So I'll go to Samira.
Good afternoon, Chair Henderson and council members. My name is Dr. Samaria Washington. I am the chair of the District of Columbia Healthcare Association and Regional Director of Operations for Bridgepoint Healthcare. I will keep my testimony brief in the interest of time, but I will submit my full testimony. Today, I'm speaking as a healthcare professional and chair of DCHCA. I would like to recognize DC Health for the incredible job they have done supporting long-term care facilities. A particular note of thanks to Dr. Sharon Lewis, the interim director of DC Health, Arian Gibson, the interim senior deputy director of HRLA, Renata Cooper, the associate director of HRLA, Tamara Freeman, the survey team supervisor, and their staff for their ongoing efforts to ensure that the most vulnerable residents of the District of Columbia receive quality care while residing in long-term care settings. We realize that they have the difficult task of providing oversight to numerous entities in addition to long-term care facilities. We have noticed the increased resources and technological improvements aimed to improve efficiencies and services within the agency. Ultimately, we are all here for the benefit of those in need of our care. We appreciate and value the ongoing communication and stakeholder meetings with HRLA initiated by Mr. Gibson and Ms. Cooper. The long-term care community in the District of Columbia is experiencing an unprecedented challenges with staffing. Unfortunately, this is not something that the individual facilities will be able to fully address alone. We are aware that DC Health is currently addressing our concerns regarding the professional licensing process. We're excited about the steps that are being taken to address this issue and eagerly await the positive outcomes. We are becoming more dependent on new healthcare workers and workers from outside of the District of Columbia to meet the needs of our residents. This particular group they tend to have a more extensive process in trying to get licensure here in the district. We are fast approaching a time where we will need to think outside of the box to find ways to address the staffing issues facing the district and, quite frankly, the rest of the country as well. The DCHCA looks forward to our continued collaboration with HRLA to effect positive change in long-term care delivery. While the PHE may be ending, the increased burden because of COVID-19 for operators is not likely to lessen in the foreseeable future. We are thankful for the efforts and support of the leadership of DC Health and their work to try to help our industry prior to and throughout the pandemic. We respectfully ask for your continued support. We are eager to continue the good work we do in partnership with the leadership of the District of Columbia. Thank you for your leadership and the opportunity to testify. Have a good afternoon.
Thank you. Okay, I'm gonna go back really quickly. Alicia May, if you do want to testify, please accept our invitation to join as a panelist. Okay, all right, we'll let it ride. Thank you to all of the witnesses on this particular panel for your testimony. Again, I think some of you have echoed some of the things that we heard from earlier panelists, and we'll be asking some questions to DC Health about certain things on those. Dr. Bathgate, thank you for being here and for your continued advocacy on behalf of the doctors and the medical society in general in the district. I met with the head of SHPTA last year, talking about the certificate of need process, and in particular trying to think about some of the challenges that we heard from individuals who were trying to do telehealth work, and then being told they needed to get a con. And so I think I have a question or two about the certificate of need process for DC Health. So we'll be asking about some of that, and definitely hear your testimony on prior reauthorization, regional licensing, reciprocity, making sure all of those things work together. So thank you for that. Dr. Talafaro, thank you for your advocacy on behalf of the home visiting program. I think you heard from the previous panelists in terms of, checking in around the healthy steps and other types of visiting programs to make sure that that is a needed part of the ecosystem. Ms. Quinn, thank you for your testimony. Did you submit your written testimony?
I did just today. We are suffering from some of the same staffing challenges as our members, so I apologize.
Okay, because I know you cut some things, and so I just want to make sure that we have the full scope for the record. Ms. Vaughn, thank you for your testimony about Produce Plus. Again, is a very popular program, and anything I think we can do to sort of expand the idea of food as medicine and just building healthy wellness. That's always good. We were looking at some data from the Community Health Administration, and the leading cause of death in DC in 2021 was heart disease, which goes into not only healthy wellness practices, but also what are you eating, what are you putting in your body. And so I think oftentimes people overlook that that's there, and we don't necessarily pay enough attention to how we address some of those issues. And Dr. Washington, thank you again for being here as well, and for your testimony. So I don't have any specific questions for anyone here, and I don't see any of my colleagues. So thank you so much to this panel. Okay, so as I telegraphed before this panel started, we are going to take a 7-minute break, and we will be back. What will happen next is that we have another panel of 8. Well, actually, it's like 7 public witnesses, and then we will do 2 panels of our students who are signed up to testify, and then after that, we will take another break, and then we will have the government witnesses for DC Health before us. So for those who are trying to plan out their situation, we're hoping that we will get to the government witnesses by 2:30. But we'll kind of see. So we will be back in, what did I say? 7 minutes.
Thank you.
Thank you. Great. Welcome back. We will resume our hearing and call up the next panel of witnesses. Kimberly Crawford, Jawad Ali, Rachel Ellison, Sal Bigigo, Anastasia Smith, Carolyn Babin Dreyer, and Veronica Sharp. Okay. I see Ms. Crawford. So if you want to begin.
Sure. Good afternoon, Chairperson Henderson, members of the committee and staff. My name is Kimberly Crawford, and I am the Training and Outreach Coordinator at the DC Coalition Against Domestic Violence. DCC-ADV is the federally recognized statewide coalition of domestic violence service providers in the district. It includes domestic violence-specific housing providers, counseling and case management services, legal services, and culturally specific organizations serving Black, Latinx, Asian and Pacific Islander, immigrant, and LGBTQ survivors of domestic violence. Our members also serve teens and youth and survivors who are deaf and deafblind. Our 18-member programs work tirelessly to address the epidemic of domestic violence across all 8 wards of the district. Domestic and sexual violence are a major public health concern. There is a myriad of data showing the devastating prevalence and impacts of this violence, especially on the district's youth. We know that young women and girls between ages 16 and 24 are at the greatest risk of experiencing dating violence and relationship abuse. Nationally, more than half of cisgender women and men who have been physically or sexually abused or stalked by a dating partner first experienced abuse between the ages of 11 and 24. To transform our culture and end intimate partner violence, strategies that increase resiliency and reduce risk factors are paramount. As noted by DC Health in their recent community needs assessment, injury and violence prevention is one area in which the district has seen the health indicators getting worse. We recognize that the work to reduce and prevent violence does not happen overnight, and DC Health has made an important commitment by recognizing dating and sexual violence as a public health issue. We're grateful to work with DC Health and our community-based partners to address this prevalence through the Sexual Violence Prevention Community of Practice. Over the last year, we've been able to provide valuable training to school staff to help them address forms of teen dating and sexual violence within schools. Moving forward, we plan to continue working to identify state-level indicators of dating and sexual violence and create a strategic plan for youth dating and sexual violence prevention. The coalition receives a small portion of rape prevention and education funding from DC Health, and we are excited to continue our collaborative work to enhance DC's violence prevention work. This year, with the support of DC Health, we've been able to assist DC public schools in the implementation of the Expect Respect curriculum. However, our efforts have only been able to reach a limited amount of school staff and students due to funding and school schedule constraints. It is long overdue for DC to prioritize primary prevention education. DC must recognize that primary prevention allows us to curb violence before it occurs. With multi-year funding from DC Health and a budget increase of $400,000, the coalition and our member programs will be able to continue and expand efforts to develop prevention education curricula. Thank you, Chairperson Henderson, for the opportunity to testify today, and I'm happy to answer any questions you may have.
Thank you. I don't see Rochelle, so I'll go to Sal.
Okay. May I start?
Yes, sir.
Okay, good. Yeah, my name is Sal Salvaggio. Thank you, Councilmember Henderson, for the opportunity to speak to you of a current and expanding crisis we have in healthcare. This crisis concerns the insufficient number of healthcare aides and certified nurse assistants we have to care for our senior residents and others in need of their services. I'm currently a volunteer and supporter of Northwest Neighbors Village, as well as a member of the Iona Citizen Advisory Group. I'm also working with the DC Coalition on Long-Term Care to address this issue. As a retired dentist, I saw in my practice the important role healthcare aides played in providing care for my patients who could no longer self-care. Now, I know you've been provided statistics and survey information, by the coalition to inform you about how our insufficient healthcare workforce is unable to currently meet the needs of our older population and how the situation is getting worse as this demographic increases in DC. So I won't reiterate those statistics here, but what I'd like to do is perhaps illuminate other situations where this inadequacy will have an impact and is having an impact. Hospital patients will be unable to be discharged from their beds to allow care for others because they require trained in-home care. Without an adequate healthcare workforce, hospital administrators cannot release patients into an unsafe home situation. Rehabilitation facilities won't be able to accept patients because they won't have sufficient staff to take care of the needs of their patients of all ages who require rehab after an accident, surgery, or illness. Children of aged parents will have to face the emotional and financial consequences of the decision to stay at home and care for their loved ones or make a living. Residents of nursing homes and long-term care facilities will not receive the care they need because the staff is stretched to the limit. Our recent experience with COVID has showed us the vulnerability of these residents only too graphically. The remedy to this crisis, of course, is to create an educational pipeline for people to enter the healthcare aid and CNA professions. But in order to have prospective workers enter that pipeline, there must be the financial incentive to do so. This is why the DC Coalition on Long-Term Care and the Fair Budget Coalition are working to establish a $24 an hour wage for these workers. They have carefully analyzed the labor market and determined that only by having a wage that is competitive can we attract potential workers into these fields. For the health and safety of our current and future population of older residents and others in need of services, I encourage all our council members to work in cooperation with the many advocates and stakeholders to address this untenable situation and create a healthcare workforce that will continue to allow DC to be a vital community for all our citizens to live and thrive in. I'm happy to answer any questions you might have.
Thank you. Anastasia? Oops. Unmute.
Good afternoon, Chairperson Henderson and panel. My name is Anastasia Smith, and I am a student at Roosevelt State Opportunity Academy. I am also a Ward 8 resident. I recently turned 18 and am excited to become a voter in Washington, D.C. I am testifying today because Roosevelt State needs a school nurse. This is important to me because if someone gets hurt, they need somewhere to go. Also, a nurse can be a safe person for students to talk to. When I was young, I had an accident in school. If there hadn't been a school nurse, I probably would have stayed in the bathroom all day. Nurses have all sorts of things that students may need and then some. Now, I see different reasons why we need a nurse. We know many people in DC struggle with drug use. If a student is tripping out, a nurse would be helpful, or teachers should not. A nurse would be helpful. Our teachers should not be expected to handle medical emergencies. Our pregnant students may have questions for the nurse, like what to do if they are cramping or what discomfort is normal. I have primary care doctor. Many of my classmates do not. The nurse may be the only medical care they receive. They need someone to check up on them and their well-being. In conclusion, Roosevelt State needs a nurse. Thank you for your time.
Thank you. Carolyn?
Hello, my name is Carolyn Babinger. I'm the supervisor for the Healthy Start program at Mary Center. I started out as a community health worker and want to thank you all for the support that you have provided towards struggling families through your investments in home visiting. I firmly believe, as I'm sure you all do, that investing in families and the health and well-being of our children is most essential. In my direct work with families as a home visitor, I have seen how transformative these interventions can be for children and their home family. However, insufficient funding and investment in home visiting is resulting in negative impacts on staff and ultimately the families on our caseload. I have also experienced the challenges with providing consistent services during staffing departures and turnover due to DC grants not facilitating thriving wages for the workforce. I see this even more now as a supervisor and hiring manager. Our home visitors are extremely dedicated to their families and yet do not receive the fiscal support that would ensure their long-term stability and success in the role. It is a struggle to maintain consistent engagement when we have staff turnover. Staff turnover results in many families being transferred to new home visitors, sometimes unfortunately without warning or preparation. These disruptions can cause a damage to the family's relationship with the program and new home visitor. This results in the need for more investment of time and longer re-engagement periods, which is taxing for the home visitor, already burdened with a significant caseload, which weakens the overall quality of services participants receive. This has been especially true since the pandemic, where the need for support that families seek has increased, and so too the burden on our home visitors. My own team has been managing turnover for over a year while not being fully staffed. We had 1 month of being fully staffed in August, and before then it had been well over a year without a full staff since I stepped into my role. This is not even including the staff that have had gaps due to family and medical leave. The staff that has remained in the role for the almost 2 years of partial and understaffing have not received any increase in salaries during their time covering unfilled positions in the program. As a hiring manager, we try to hire quality candidates who can quickly train and begin supporting families, but I have seen qualified, wonderfully engaged, and passionate candidates shy away from the position after hearing the maximum salary we can offer. This is not sustainable for our program participants. I have heard candidates reference their own family situations for why they can't accept the salaries we offer. For example, an incredible candidate recently shared that the salary would be unacceptable because it would not allow her to support her family as a single parent. We lose on high quality candidates when we can't offer thriving wages. Participants lose on high quality support when our programs are undervalued and overburdened. We thank the council for their investments, as we know home visiting is an effective early childhood service. This strategy leads to positive family outcomes and reduced child abuse and neglect. Home visiting is truly an investment in communities, a holistic preventative approach to supporting families in their health, well-being, and economic stability, especially when participants face more disparities. However, for home visiting to continue to be the most effective strategy for supporting families in their health and economic stability, we need to be competitive in attracting candidates and incentivizing workers. We want qualified and passionate candidates to remain in the role long-term, to focus on their work with families, not be concerned for their own economic stability. So I ask you, how can home visitors expect to support families become economically stable if they themselves are struggling to do the same with the wages the grants force us to offer? Our home visiting professionals should be able to support their families. Thank you.
Thank you. Veronica Sharp.
There we go. Sorry. Good afternoon, Chairperson Henderson and members of the Committee on Health. My name is Veronica Sharp. I'm the president of the District of Columbia Healthcare Association. We represent all of the district's licensed nursing facilities and several assisted living communities. The relationship between DCHCA membership and DC Health has always been a good one. Over the past 3 years, the relationship has been strengthened, and I believe it was essential that we work together as partners throughout the public health emergency. I want to also say that DCHCA members respect the leadership of Dr. Lewis and the staff of DC Health. DC Health has been invaluable throughout the last 3 years. They continue to meet with DCHCA membership regularly on COVID-related matters, and of course, support individual facilities when it's needed. We now need to focus on safely lifting restrictions that have kept long-term care community residents virtually locked up for 3 years. It appears our current situation will continue for years to come, and we need to make sure that these individuals can live their best lives. We have a meeting with DC Health Epidemiology next week, and we will work together towards safe relief for everyone. The pandemic has truly brought the lack of nurses and direct care staff to the forefront. The ability to hire an interested candidate for either of those positions must be seamless. Delays due to licensure or testing make hiring much needed staff even more difficult. Members have called me several times to intervene on a candidate's nursing license application, and Dr. Walsh and her team have always responded quickly. The sense that I get, though, is that the applicants feel like there's no customer service or a lack of communication, and that's what we need to work to improve. With the dire shortage of direct care staff, it is time to look at ways that we can expand the pool of individuals that enter the healthcare sector. One idea is to lower the age to work as a direct care worker. The current age is 18, but lowering that age to 16 or 17 would allow high school students to get part-time work and to enter into the healthcare center. In terms of the Board of Long-Term Care Administrators, Several administrators and training licenses applications were delayed in getting their licensed nursing home administrator license because the board did not have a quorum to be able to conduct business. I understand the desire to have district residents hold the seats on these boards, but a change needs to happen. Either the executive director is given the authority to make the decision on licensure, or the capability to serve on a DC board could include long-term licensed nursing home administrators who've worked in the district for a certain period, perhaps 5 years. We have several administrators that their entire career has been here in the district, and they would be excellent people on the board. Lastly, as the Long-Term Care Workforce Coalition makes the case for DHCF to fund providers, we ask that DC Health, if they are asked, support are asked for the individuals that provide the human touch and such important and necessary work. Thank you.
Thank you. And thank you to this panel of witnesses for being here today. I want to start with Anastasia, because I see that you're still here, but you might also be in class. So I'm going to get you back to what you're doing. Roosevelt State recently changed locations. You went from the main Roosevelt campus in Ward 4 down to the Garnett Patterson site in Ward 1. I just asking, there was a nurse that was at the old campus, correct?
Answer the question. What was the question? I'm sorry.
Yes, there was a whole medical.
Oh, yes, it was a whole medical suite, but that really wasn't for a stay. It was for regular rows. And then, but they let us use it.
Right. Okay. So we'll just need to follow up with DC Health around that point. But thank you for being here and for providing your testimony.
Well, thank you for having me.
As your earlier teachers also testified in favor of that as well. So we'll be asking some questions on that. Thank you to the rest of the panel of witnesses for your testimony. Ms. Sharp, we had a hearing on Tuesday with 5 of the boards, and we talked, I think I asked a question of most of them in terms of like, have you ever had a situation where you couldn't meet quorum? For those particular boards, they didn't. And all of those boards also had, well, maybe psychology didn't, but most of them had delegation authority for the executive director to approve applications in lieu of the board convening full time. But it was raised by some of the board chairs around the difficulty that they have in terms of recruiting folks to serve on the boards, especially when you think of the number of people who are licensed in the district versus who live in the district.
Right.
A very different number. Do you think that people would be open to changing that requirement? That you don't necessarily have to live here, but that you have to work and have worked in the district for X period of time?
I think it's a good idea. I mean, because we have several administrators that would be happy to serve on that board, but they don't live in the district. They've worked in the district. I've been in my position for 20 years. These people have been working in the district for at least 20 years or more. So I think they'd be excellent candidates.
Okay. We'll ask about that. I think we have to sort of work through some issues, but I think, even the conversation that we had on Tuesday was very helpful in sort of understanding even the numbers, right? Maybe a quarter of the doctors who are licensed in the district actually live in the district. The percentage is even less for nurses. I think we have something over 40,000 nurses that are registered in the district, and maybe about 3,000 or so live here. So when we think about the pool of candidates of who can serve on these boards, it gets smaller and smaller across the board. So we'll take a look at that. But you all were, I hear you loud and clear around, especially the need for improved communication. There could be a delay, but can someone pick up the phone to let me know? Or if I am missing a piece of my application, what does the communication look like to ensure that, I know, and I'm not going months without not hearing anything. Mr. Salvaggio, thank you so much for your testimony. Others have testified similarly. And I've actually met with Ms. Sharp and the long-term care coalition, specifically around the wage issue. And that's something that we brought up with the Department of Healthcare Finance and will continue to bring up with all of the entities around that. Ms. Crawford, thank you so much for your testimony in terms of the work. I don't think a lot of people realize just how many grants DC Health has that kind of cross the continuum of things. But I don't have any specific questions for this panel. Thank you all for being here. And if we don't have your written testimony, please make sure that you submit it to the committee.
Thank you.
Thank you. Okay, so we are going to move on to our final two panels. I'm going to call the names. As I understand, for a lot of these are students with the young, excuse me, with the Young Women's Project. Some of them are still in school because they thought that this hearing might go a little bit later than we are progressing. So what I will do, and I'll make this a public commitment, I think Nadia is listening, Nadia Marchis, who is the executive director of the Young Women's Project. For any of the students who aren't able to testify, Nadia, just reach out to my office. We can set up a separate time for us to meet. So we can hear these students in terms of their particular concerns. But I'm going to call who we have. I'm going to just split the final list into two. Anjanae Walker, Eris Hines, New Quinn Dow, Bailey McFadden, Carter Hale, Jesus Milan, Rowan King, Lily Horn, and Jaya Jubert. For those students who are just joining, you just have to affirmatively accept the invitation to be elevated as a panelist. And I'll give it a minute because I see some of you in the attendee room. Okay, I don't see Anjanae, but I do see Eris. And please tell me if I'm saying your name wrong when you introduce yourself. And I apologize if I'm getting it wrong. But you can go ahead and present your testimony.
Hello, Chair Henderson and the committee. Yes, you are saying my name correctly. It is Eris. My name is Eris Hines, and I'm the Youth Health Educator Program Coordinator at the Young Women's Project. I'm also a Youth Development Specialist and soon-to-be Master's in International Education graduate from the George Washington University. The Youth Health Educator Program at YWP develops youth as sexual health champions who work to reduce DC's teenage pregnancy and STI rates through peer education, resource provision, and clinic referral initiation. You will soon hear from a few of our amazing youth advocates. Recently, our peer educators created a youth-led survey on sexual health and wellness to better understand the needs of DC youth and to address ongoing issues within schools. Our survey found that peer educators fill the gaps in school-based sex education. As stated within the 2021 DC YRBS, 59.7% of respondents reported that they have not been taught about HIV or AIDS infection within school, yet 28.5% of DC youth have been having sex, according to DC's YRBS. DC Health has reduced its reach and funding for this work. The Sexes program and campaign is no longer doing community outreach. On top of that, the RAP-MC Youth and Adult Certification Quiz has been down for months. To put it frankly, there's just not a lot going on at high schools. Condoms are not being distributed. In fact, YWP has now taken the initiative to partner with teachers and school administration to provide free condoms. Among the youth within our survey that said that they were sexually active, 12.1% of them said that they were not using a condom during sex. This number is even higher within the DCYRBS, when the number sits at 18.3%. In our survey, we saw that youth didn't use a condom because they simply didn't have one and/or they just didn't know how to use one. So lack of access to condoms is a significant barrier to using them. Our survey also showed us that 17.6% of respondents didn't even know that their school gave out condoms. So I want to take a minute to also acknowledge that the rates of sexual violence and teen dating violence are also very high for high school girls in DC. The 2021 DCYRBS found that 8.9% of high school girls have been physically forced to have sexual intercourse, 10.6% have experienced sexual violence, and 23.6% 0.3% have reported that someone that they were dating or going out with has purposely tried to control them or emotionally hurt them one or more times. So youth sexual health is in jeopardy. Limited sexual health education and condom distribution are putting our high schoolers at risk. So we are asking from YWP that you all help us by revitalizing DOH's Sexes program and campaign. This would actually help us to meet the 2009 condom availability policy, and our youth and adult staff would totally be pleased to work alongside DOH. We are also asking that you help us by compiling and sharing data, and also ensuring that youth engage in sexual health classes. Our students need support in this supportive education interventions, and our youth and adult staff would also really be willing to help work alongside DCPS and DCPCS. With that, I just want to also say that we were funded by DOH for 6 years, and then they cut our sort of 5-year grant short. So we are now funded by the Office of Out of School Time Learning. We would also just hope to sort of get that funding back. With that, I say thank you, and I'm going to pass it along to my amazing students.
Thank you. Let's see, new. I do see Bailey. Bailey, if you're speaking, you're on mute. Here you are.
Hi, can you hear me now?
Yes, I can hear you now.
Okay. Good afternoon. Thank you for the opportunity to testify today. My name is Bailey McFadden, and I have been a youth health peer educator with the Young Women's Project since August 2022. YWP offers me the opportunity to develop youth leaders and to solve community problems. I am testifying today to raise awareness and advocate for the needs of youth across the district. This program is essential to reach students who are more likely to reach out to peers for sexual health information and resources like condoms. My peers and I have passed out 3,275 external condoms to DC high schoolers so far this year. This translates into students' ability to practice safer sex, reduce risky behavior, and decrease the risk of STI contraction and teen pregnancy. There are only 5 YWP peer educators at my school. This means that a significant portion of the student body is not able to access support services. 12.1% of youth who participated in our survey that said they were sexually active were not using a condom during sex. 8.9% of sexually active respondents did not use a condom because they didn't have one, and 1.3% just didn't know how to use a condom. We are advocating for critical support to increase sexual health education and condom distribution in DCPS and charter high schools, with a goal of reaching 25 schools and 10,000 youth. Peer educators and organizations like YWP should be engaged as part of this work to increase effectiveness. Thank you for your time.
Thank you, Bailey. Carter? Carter, if you were speaking, you are also on mute. There you are.
Hello.
Hello.
Mute. Sorry. Thank you. If I cough, I'm very little under the weather, but yeah, here we go. Hello, Chairperson Henderson and members of the committee. Thank you for providing me with the opportunity to testify today. My name is Carter Hale, and I live in Ward 6. I'm a sophomore at Basis DC Charter School and hope to one day work for the UN. I started as a peer educator at the Young Women's Project, YWP, in 2022. I joined YWP to help my community, my peers access materials and support on sexual health. I'm testifying today to share the work that we are doing as peer health educators and to encourage you to continue to help us in our efforts. I will also share some of the preliminary results of our recent 2022-2023 Youth Sexual Health Survey taken by 529 youth across 24 DC high schools. Being a peer educator taught me to be open-minded and motivated doing my part in making the world a better place for everyone. During my time as a peer educator, I learned about the consequences of not having safe sex, and my condoms do more than just prevent pregnancy. This work not only helps my community, but also empowers me because I am able to make a positive difference. I actively contribute to STI prevention by providing condoms and demonstrating how to properly use them, sharing accurate information on STI prevention, and referring peers to clinics for STI testing. Being a peer educator provides me with invaluable job experience and has helped me restore my faith in my city, which allows me to give back to my community. Sexual health information and resources continue to be an acute need within DC schools. While condoms are available in my school, it is not well communicated where they are available, and sexual health classes do not start until 10th grade and last for only 1 week. Basic students, like many high schools, are actively having sex, and they're not provided with sexual health education until 10th grade. It's a missed opportunity to strengthen youth's ability to make safe and informed decisions about their lives. As a 10th grader, I received zero sexual health education, which is a huge cause for concern. This has directly led to me making unsafe choices in my own behavior. I know that the lack of education has also led to several other basic students making unsafe sexual choices. This is not an anomaly. According to our Youth Sexual Health Survey, only 29.7% of students have received sexual health education this year in the DC region. Our work at YWP helps many students feel more comfortable with themselves and allows them to understand how to practice safe and healthy sex with partners. Sexual health and wellness are vital to ensuring that all students can perform their best in school, or breaking harmful stereotypes around sex, sexuality, and gender. However, we need your support to improve policies and to increase financial resources to enable the youth of today and tomorrow to make the best choices when it comes to sexual health and wellness. Excuse me. We would like to see action. We are concerned because we experience the realities of what is happening in our schools. We live it every day and we need change. We are asking that you help us in the effort to support sexual health education and condom distribution in DCPS and DC charter high schools. Thank you for your time.
Thank you. Tyus?
Thank you, Chairperson Henderson and members of the Committee on Health. Thank you for the opportunity to testify today. My name is Thais Bian, and I'm a sophomore at Basis DC and a resident of Ward 6. I hope to major in humanities when I attend university. I joined the Young Women's Project and became a peer educator to ensure that others would not face the same problems I experienced with limited access to information on sexual health. I'm testifying today to share the work that I've been doing as a peer health educator and to encourage you to help us in the effort to support sexual health education and condom distribution in high schools. YWP's Youth Health Educator program develops youth leaders as change agents to improve sexual health decision-making through peer education. I'm working on solving challenges we found based on our data from surveys by distributing condoms, information, and helping to establish more permanent sex education structures in DC schools with YWP. Youth health educators contribute to STI prevention by providing information about accessing free condoms, demonstrating how to properly use condoms, sharing accurate information about STI transmission and prevention, and referring peers for STI testing. My peers and I have passed out 3,275 external condoms to DC high schoolers. We've reached over 1,000 students and answered hundreds of questions about pregnancy options, anatomy and the menstrual cycle, condoms and contraception, reproductive and sexual rights, and healthy relationships and partner communication. YWP has allowed me to be my peers with information and a spirit of camaraderie. In turn, this has led me to open up about my own life and experiences. I'm often approached by fellow students who do not have access to condoms and all the information for safe sex. Being a peer educator enables me to help them. My school is becoming more aware of the lack of sexual health programming and its consequences through the feedback we provide. Sexual health information and resources continue to be an urgent need within DC schools. DC Health has reduced its reach and funding for this work. In my school, we do not have access to resources like condoms, and the informational sex ed course is relegated to the end of high school. Even the data clearly demonstrates students in 11th and 12th grades are most sexually active. My grade will have its first class in March of this year, and this is considered an improvement in our school, as previously it was taught in later grades. However, our one teacher for sex ed has little support despite their advocacy efforts. Youth health educators try to fill the gap in school-based sex education. Within our sexual health survey, we found that less than 30% of respondents received hours and/or instruction on sexual health this year. But filling this gap is not enough. We want to see permanent change so others are able to make informed decisions that will impact their futures. Our work at YWP has the opportunity to help many students throughout DC. However, without your help, the resources and information we provide will not be enough. We are asking you help us in the effort to support sexual health education and condom distribution in DCPS and charter high schools. Thank you for your time.
Thank you. Rowan?
Hi, sorry. Can you hear me?
Yes, I can.
Good day, Chairperson Henderson and members of the Committee on Health. Thank you for the opportunity to speak to you today. My name is Rowan King. I live in Ward 4 and I'm a sophomore at School Without Walls. In college, I intend to study engineering and data science. In 2022, I started working as a peer educator at the Young Women's Project, and I'm going to share the work that we do as peer health educators and encourage you to support sexual health education and condom distribution in public schools. YWP's Youth Health Educator program develops youth leaders to improve sexual decision-making through peer education, clinic referral initiation, and resource provision. YHEP is an essential program for DC youth that provides sexual health education and resources. I participate in weekly trainings to help equip peers with the knowledge and information to protect and make informed decisions that are right for them.
Being a peer educator allows me to make a difference in my community. I've gained valuable information about topics like STIs, birth control, healthy relationships, and consent. I am able to foster a safe space where my peers can request condoms or ask questions about sexual health without fear of judgment or criticism. Youth health educators contribute to STI prevention by providing information about access to free condoms. We also demonstrate how to consistently and effectively use condoms, sharing accurate information about STI transmission and prevention, and referring peers to get tested. During the survey process, I gained insight into the experiences and needs of my classmates. Additionally, I was able to lead the School Without Walls project, where I gained experience in data analysis, identifying gaps, and working in a team. Sexual health information and resources continue to be a critical need within DC schools. Although School Without Walls has accessible condoms and a sexual health curriculum, there is room for significant improvement. Condoms are not widely distributed, and our sexual health curriculum focuses on birth control and fails to cover topics like STIs. Many students at Walls tend to get sexual health information from Google sources, which may not be reliable. I strongly believe that the work we do at YWP has and will continue to greatly improve the lives of many students. We would like to see action taken based on our concerns. We are asking for your support to expand sexual health education and condom distribution in DCPS and DC charter schools. And we urge this committee to prioritize youth sexual health and collaborate with YWP to increase access for DC youth to the necessary education and resources. Thank you for your time, and I look forward to discussing this further.
Thank you. Lily?
Can you hear me?
Yes, I can.
Okay. Hello, Chairperson Henderson and the committee members. Thank you for allowing me to testify today. My name is Lily Horn, and I'm a sophomore at Basis DC and a resident of Ward 6. I'm a peer educator at YWP, a program that develops youth leaders and contributes to solving community challenges. I became a peer educator to share important information on sexual health with my peers. I am testifying today to raise awareness about the importance of increasing access and resources for sexual health and wellness education. Being a peer educator has taught me that I can actively change my environment in my community. Through the YWP's Youth Health Educator Program, I am developing youth leaders as system change agents to improve sexual health decisions, clinic referral initiation, and resource provision. As an advocate, I receive extensive training in sexual health, STI and pregnancy prevention, data collection, healthy partnerships, and physical and mental health. For example, I provided sexual health information to many students on topics from how to use condoms to describing the benefit of various methods of birth control. This enables me to keep my peers safe and healthy, as well as making sure that they know and understand all of their options regarding their bodies and consent. Additionally, participating in developing that youth sexual health the sexual health survey taught me important skills on data collection and analysis. Our survey was split into 4 sections: school-based sexual health education, youth sexual health experience, access to sexual health services and resources, and school environment and support. Our results are preliminary. However, here are some of the highlights. 70.3% of respondents said that they received 0 hours and/or no instruction on sexual health and wellness. Only 14.2% of respondents said that they used condoms or dental dams the last time they had sex. That is only 2% above the 12.1% of youth that said they did not use any protection. Furthermore, 48% of respondents said that the condoms should be available for free at their school. The data demonstrates the lack of sexual health education students are currently receiving through the school system. Additionally, students lack the basic information about their bodies, especially as it relates to sexual health and wellness. We are advocating for additional support for sexual health education and condom distribution in DCPS and charter high schools. Peer educators and organizations like YWP are an essential part of this work to increase access to services. Youth voices are critical, and we want action to create significant change. We are asking that you support our efforts to improve sexual health education and condom distribution in DCPS. I welcome additional opportunities to connect these initiatives. Thank you.
Thank you, Lily. And Jaya.
Hello. Good day, Chairperson Henderson and members of the committee. I am grateful to have the opportunity to give a testimony. My name is Jaya Duber, and I'm a resident of Ward 8 and a junior at School Without Walls High School. I hope to attend the Massachusetts Institute of Technology once I graduate. This is my first academic year as peer educator and advocate at the Young Women's Project. I became a peer educator so that I could share important information on sexual health with my peers. I'm testifying today to reinforce the collective voice youth across the district in order to better prepare us for future after high school. I'll also share some of the preliminary results of our 2023 Youth Sexual Health Survey. Our program develops youth leaders as change agents who mobilize and advocate for rights, resources, and accountability for DC youth. Our citywide peer educators work to improve sexual health decision-making through peer education, clinical referral and initiation, and resource provision. We need YHEP and other peer organizations because of the impact it has on youth. My knowledge of sexual health and ability to teach others how to keep themselves safe enables students to have more autonomy over their bodies and choices. In turn, I'm a person who others can engage with to discuss uncomfortable and difficult topics. I am proud to be someone that is trusted with my peers' personal details and challenges and the ability to guide them. Being a peer educator taught me that I can change my environment and my experience. This is a very powerful lesson to learn. So many youth believe that they are helpless and unable to influence the ecosystem that they are a part of. I provide free contraception to my peers, answering questions they might have and direct them towards the resources that they need, all while dispelling harmful myths and fallacies. For example, I inform my peers about safe sex practices and the facts about STI transmission, including how HIV is and is not contracted. We collected survey data on our peers' knowledge of sexual health and behavior, and were able to collect hundreds of responses. The results revealed gaps, such as approximately only 1/4 of the student responses said that they use school resources or health classes as a source for sexual health information. And only 16.1% of students reported having more than an hour of school-based sexual health education. There is not enough sufficient sexual health education available for youth in the district. We need to ensure that our young adults are properly equipped with the knowledge that will protect not only themselves, but those around them. As a resident and youth peer educator, I am requesting support so that we can improve sexual health services and education. We are asking that you help us in this effort to support sexual health education and contribution to DCPS and charter houses. Thank you.
Thank you. And thank you so much to all of you who testified, especially since I think some of you were still in class or, surrounded by your classmates. So I appreciate that. I do have some questions for the students who are still here. I'll bring some of you guys up. Okay, so I believe all of you are in high school. And I guess one of the questions I have is, or there's been an ongoing conversation around sexual health education and like, when does it need to start in terms of conversations? I think a number of you mentioned in your testimony that, even some of the classmates that you're talking to, they're sexually active, in the survey, there are a number of people who indicated that they were sexually active, but they didn't know how to use a condom. And so I think given your experience and sort of talking with your classmates, but also like your lived experience as a teenager in the district, a student in the district, what do you feel like is the appropriate time for us to start having some of these conversations? Anyone can answer.
Well, I would say that I believe starting the education on it earlier on, like early middle school, late elementary school, maybe even before then, helps to destigmatize a lot of these things, and helps us make the conversation about these things easier.
Anyone else want to?
I think that there are, sorry, hold on.
Oh, it's Bailey and Carter. Y'all
Hi,
in the same
sorry.
room.
We're in the same room. I just
Okay.
wanted to add that the conversations around sexual education, sexual health education, those can include things like consent, which can be taught to kids who are like way younger, because like even just sexual education, you need to talk about things like emotions and how to respond respectfully to people. And all of that can be taught when kids are really, really young. So it doesn't all have to begin in middle school.
You're right about that. Go ahead, Carter.
Yeah, like, right, okay. Thank you. Yeah, sexual health education doesn't necessarily mean, yeah, as Bailey was saying, teaching about directly like what sex is and how to have safe sex. Like you can start with things as like just what puberty is even earlier, because like we were basically never taught that. We had one class on anatomy in 6th grade, and I received 0 other sexual health related teachings at all. And I think that that's a pretty big concern.
Yeah, that is a pretty big
Yeah,
concern.
I can second that.
Oh, go ahead, Lily. Sorry.
I can second that totally. Like, I didn't receive any sexual health or even puberty classes or like growing classes or anything about my body, even throughout elementary school, and I still haven't.
Yeah, that is concerning, but it is something that we're trying to address. So the State Board of Education and in concert working with the Office of the State Superintendent of Education, they've tried to update the health standards so that we could start having some of the conversations that you guys were talking about, like puberty, consent, et cetera, earlier in elementary school, just sort of going based off the data of when more, young people are starting to have questions. Because the last thing we want to do is have our young people learning about sexual health education from like TikTok. Not that TikTok is wrong, but we'd like to make sure that it's grounded in more. One of the things that has come up, and this came up, I think, a little bit in the behavioral health hearing, is that there was a desire for from young people to see more peer educator programs. And I'm curious if you feel like your classmates respond more to information from you all than perhaps they would from an adult, or would it be fairly equal in your mind?
I would say,
Go ahead.
I would say that part of it is the ability to see someone who is your age, your status, and be on even ground with them and be able to talk to them. When there's an adult or, other teacher or I don't know, like people who are higher than you in any hierarchy, it is going to be more difficult to talk about more private things. And so when we have people that are on the same level, that becomes easier, much easier.
Yeah, I definitely agree. I think it's much easier for me to talk to my friends, people in my community, about things that are private to me. And I think that's the same thing for a lot of my friends. I think that when you're talking to adults, there's a lot of fear of judgment from people who may not have the same experience as you. So I think that definitely peer educator programs should be expanded because it's much easier to connect with people your own age.
Great. Well, thank you all so much for taking time to testify and for being here. I'm going to go to the next panel, which includes perhaps some of your classmates, but thank you all for being here. I see new Dow in the attendee room, so if we can bring them up on the next panel. We'll also add Rhea Jordan, Chamika Orusagui. Sorry, Shamika, if I'm butchering that. Zainab Balta, Maya Burgess, and Elsa Boheme. And I think Maya Burgess was the other as well. Okay, I see new, and I apologize if I'm saying it wrong. But if you wanted to go ahead and do your testimony.
Hi. Good afternoon, Chairwoman Henderson and members of the committee. Thank you for the opportunity to testify today. My name is Nick Quindell, and I am a senior at Benjamin Banneker, and I live in Ward 4. I'm attending college in the fall to pursue a degree in nursing. In 2020, I joined the Young Woman Project as a peer educator. I became a peer educator so I could share and teach important information on sexual health with my peers. I am testifying today so I can raise awareness on the sexual health of youth and to request the committee to consider the urgent needs of youth across the district. The youth health educator program goal is to increase teenagers' knowledge and access to sexual health services. We reach youth with information, distribute condoms, and refer them to community clinics. I'm proud to raise awareness and spread awareness to my peers about the importance of sexual health, since my school does not provide any. This month, I am working with my fellow peer educators to present classroom presentation on sexual health topics. For example, during my time here, I learned about the different types of STIs. Prior of joining this program, I only knew about viral STIs, but now I'm ready to educate my peers on bacteria and parasitic STIs. Being a peer educator taught me that I can make a difference in my community. My peers and I work together to share accurate information about sexual health to protect students. Many teenagers are afraid to seek help and ask for condoms and contraceptions. In many instances, they are not aware of the risks associated with unsafe sexual practices. At school, we distribute condoms and conduct sexual health and what solutions are needed. The YWP 2022 and 2023 sexual health survey showed that majority of students are unaware of the facilities and research that are available to them because they were not taught any. This includes Planned Parenthood and DC Health and Wellness Centers. Therefore, we try to inform students. As a concerned students and youth educator, I'm requesting additional support so we can all do better. In fact, we must do better because majority of the teenagers lack knowledge about safe sex practices, which could lead to unwanted pregnancy or contracting STIs. This is critical as many students are afraid to seek help because they are uncomfortable or they feel judged. In 2021, DC YRBS report, only 52% of youth said they used a condom during their last sexual intercourse. What about the other 48%? This shows that school needs to do better and take action. We would like to see action taken after we voice our concern. Therefore, we are asking for efforts to support sexual health education and condom distribution in DCPS and DC charter schools. Thank you.
Thank you. Rhea? Rhea, we can't hear you. Nope. Okay, we're gonna go to Shamika, and then we'll come back to you.
Can you hear me?
Yes.
Okay. Good afternoon, Chairwoman Henderson and the committee members. My name is Chamika Orasakwe. I'm 17 and I live in Ward 5. Thank you for allowing me the opportunity to share my testimony today. I'm a senior at Benjamin Banneker Academic High School, and I plan to go to Penn State in Harrisburg in the fall to become a therapist and specialize in human development. I joined YWP the summer of 2022 because I've always had a passion for women's health, and I want to destigmatize talking about sexual health, provide a space for open dialogue and discussion. I'm testifying today to raise awareness on sexual health of youth and to call the committee to reconsider what the actual needs of youth are across the district. I will also share some of the preliminary results of our recent 2022 to 2023 Youth Health Survey, taken by 529 youth across 24 DC high schools. The Youth Health Educator Program develops youth leaders who help to improve sexual health outcomes for DC youth throughout peer education, condom distribution, and by expanding sexual health understanding. I love being able to connect with my peers about the confusion confusions of navigating through our development into adulthood, like how to deal with relationship conflicts, finding out who we truly are from our individual personalities to our sexuality and the kinds of people we would like to grow to become. I love being able to be someone they can rely on to give them unbiased information and guidance. As a peer educator, I'm a reliable, non-judgmental source of information for my peers when they have questions. This year, I've passed out condoms and lubricants to my peers, as well as helping to create a survey in order to better grasp the information we needed to start talking about in sexual health educators. Based on the survey, we've learned that we need increased discussions about different methods of having safe sex and different forms of contraceptives, such as long-acting reversible contraceptives. While our results are preliminary, a highlight is that 70.3% of respondents said that they have received 0 hours of sexual health and wellness education. Our work is making a difference because we're trying to provide resources and bridge that gap. As the curriculum in my school, there has been no changes or sexual health education taught. This is harmful because it leaves it up to teens to gain this information, often from unreliable sources, and spread misinformation. We're asking that you help us in the efforts to support sexual health education and condom distribution in DCPS and DC charter high schools. We urge the committee to prioritize youth sexual health and collaborate with YWP to increase access to DC youth to the necessary education and resources. Thank you for your time, and I look forward to discussing this further.
Thank you, Chamika. Sorry for mispronouncing your name. Zainab? I think they were here.
I think she's having internet trouble connections right now.
Okay.
But I'm next, so I can go before her.
Okay, go ahead.
Can you hear me? Is everything okay?
Yes, go ahead.
All right, perfect. Chairperson Henderson and members of the committee, thank you for the opportunity to testify today. My name is Maya Burgess-Forrest, and I'm a 10th grader at Basis High School and a resident of Ward 5. My future goal is to major in sustainability and to become an environmental lawyer. I'm a peer educator at the Young Women's Project. The project aims to train youth leaders to advocate for positive change in their communities. I became a peer educator to normalize sexual education and health in schools and empower students in their decision-making. I am proud to know that I can make a difference and help people who are once like me, confused and scared to learn about myself and sex. Being a peer educator taught me that making a difference is possible in a compassionate environment. Since working here, I learned to confidently teach and support others who may be in precarious situations. The Young Women's Project has given me the opportunity to not only cultivate my job skills, but learn more about my emotional health. In December, we conducted a sexual health survey. While our results are preliminary, the data demonstrated that sexual health information and resources continue to be urgent within DC public schools. Sex education is being overlooked and community outreach and funding have declined. Our survey found that 23.6% of youth have been sexually active within the last 6 to 12 months. This is comparable with CDC's 2019 YRBS national report stating that 27.4% of students are sexually active. Additionally, the RAP-MC Youth Certification Quiz no longer functions. Despite reaching out to DOH multiple times and requesting for the link to be fixed, it still remains broken. Luckily, my school has allowed us to distribute condoms and educate students on the importance of sexual education. Students are also interested in learning more about sexual health and reproductive health and often approach me with questions. Youth health educators ensure teens know how to access and negotiate condom use and birth control methods. In the 2021 DC YRBS report, 52% of youth said that they used a condom during their last sexual intercourse. This means that 48% of students are not practicing safe sexual behaviors. This demonstrates that our schools need better sexual health initiatives that listen to and work with youth leaders. We are asking that you help YWP in the effort to support sexual health education and condom distribution in DCPS and charter high schools with the goal of reaching 25 schools and 10,000 youth. We want to see tangible change on the issues raised to protect and empower DC youth. Thank you for your time, and I look forward to answering any questions.
Thank you. Elsa?
Can you hear me?
Good afternoon.
Afternoon.
Good afternoon, Chairperson Henderson and the Committee on Health. I apologize in advance for my voice. I'm a little sick. I promise I'm not on the verge of death. Thank you for the opportunity to share my experiences with YWP. My name is Elsa Boehm. I'm 15 years old, a resident of Ward 6, and I attend Basis DC High School. In the future, I hope to attend college and get my degree before going on to become a lawyer. I joined YWP at the beginning of summer 2022 because I wanted to see a change in my school's sexual health curriculum. I'm testifying today to raise awareness on the sexual health of youth via YHEP and to call on the committee to consider the needs of youth across the district. My school has extremely limited access to any resources on sexual health and just does not have a strong sex education program. For example, at my school, 52% listed TikTok as a primary source of info for sexual health, while only 14% listed Basis itself in the YRBS survey we conducted. YHEP has helped to bridge the gap by providing sexual health resources in terms of condom distribution and evidence-based information, providing vital foundational skills that students will build on for the rest of their lives. Being a peer educator taught me that I can change my environment and my community. Youth advocates receive extensive training in sexual health, STI prevention, peer education, project development, mental health, and more. We work every day to make our city a better place. As a peer educator, I'm able to provide condoms to those that do not have access to the sexual health resources they need. Just as importantly, I'm able to give hope and options to students. With every condom I pass out, slide I make, or piece of guidance I give, I learned that I can contribute to improving my community. Youth health educators contribute to STI prevention by providing accurate information and demonstrating the proper use of condoms. We've reached over 1,073 students and have answered 393 questions about pregnancy options, anatomy in the menstrual cycle, condoms and contraception, reproductive and sexual rights, and healthy relationships and partner communication. Being a peer advocate has allowed me to connect with my peers, helping them gain important information about sexual health, which they would otherwise not have access to. Given the sensitivity and judgment that teens feel around these topics, we strive to develop a kind and supportive network that they can turn to when they need help. This is an underestimated and valuable service we provide in a world where teens so often feel isolated and alone. We are hurting because schools are not providing enough sexual health resources to students. At many schools, such as my own, the only people who are educating youth are YHEP peer educators. We are asking that you help us in the effort to support sexual health education and condom distribution, with the goal of reaching 25 schools and 10,000 youth. Youth do not want only to be heard, we want to see sincere change. So thank you for your time.
Thank you, Elsa, and I hope you do feel better. I will say, I appreciate your testimony, but when you said 52% of your survey respondents cited TikTok as their primary source.
For Basis, yeah.
At Basis, you said?
At Basis, yeah.
I was just at Basis on Monday. I'm going to talk to your head of school about this. No, I'm kidding. No, but thank you so much to everyone. Oh, wait. Oh, hold on. I think, is Zainab, is she joining Maya? Or I ask some questions. Hold on. Is Zainab there?
Yeah, I'm here now.
Okay. All right. I want to make sure you get a chance to testify.
Hi. Hello, Chairperson Henderson and committee members. Thank you for this opportunity to testify today. My name is Zainab Balta. I live in Ward 3 of DC and currently attend Basis DC as a sophomore. I joined YWP as a peer educator and youth justice advocate in 2022 with the purpose of learning about sexual education in order to foster change within the school system. I am testifying today to raise awareness on the sexual health of youth and to call on the committee to consider what the needs of youth are across the district. I will also share some of the preliminary results of our recent youth sexual health survey taken by 529 youth across 24 DC high schools. For years, the Youth Health Educator Program has developed leaders as system change agents who mobilize and advocate for rights, resources, and accountability for DC youth. Our peer educator network seeks to improve sexual health decision-making through peer education, clinical referral initiation, and resource provision. Since joining YWP, I've passed out condoms, answered questions, distributed surveys, and examined faults in Basis's curriculum. Overall, most teenagers either harbor incorrect ideas or are completely lost when it comes to sexual health. I myself have only recently gained this knowledge because of YHUP.
But this job goes beyond the scope of sexual education. For example, I've grown more confident, outgoing, professional, and analytically skilled. Being a peer educator allows me to improve my environment and community. It taught me that no matter how small or insignificant I may believe my actions are, they could have a great impact on someone else. This past November, we created a survey on sexual health and wellness to better understand the needs of DC youth and to address ongoing reproductive health issues within our school. While our results are preliminary, certain data points are clear, including that 70.3% of respondents said that they have received 0 hours and or no instruction on sexual health and wellness. On this basis, sexual health information and resources continue to be an urgent need within DC schools. The safety of high schoolers is at risk and often overlooked because of the stigma related to sex. When students cannot look to their parents for information, schools should be able to fill the void. And when both sources fail, where does that leave them? Only this year has BASIS begun to include 10th graders in a week-long sex ed initiative. Thus, we are entering maturity with no knowledge in our own bodies, sexual health, and basic relationship expertise. This increases the likelihood of unprotected sex, consequently increasing the likelihood of unwanted pregnancies, STDs, and more. Sexual health resources and services are critically needed to ensure teens understand the facts and emotions connected to sexual health and have the vital information for decision-making. We are asking that you help us in the effort to support sexual health education and condom distribution in DCPS and DC charter high schools. Youth must be informed and given the tools to make informed choices, and a great way to do so is through a program. Thank you for your time.
Thank you. And again, thank you to all of you who testified. To New and Chamika, I think you were the two who mentioned that you wanted to pursue careers in the health profession. One of you is going to school for nursing. Another one of you said you wanted to be a therapist. I hope that you come back to the district. We need your talent here. But I do have a question for anyone who's still able to be here. So a number of you testified in terms about condom distribution at your school. I'm curious, are you also seeing your classmates be interested or taking up also offers to get tested as well?
So I can go first. In terms of offers to get tested, I'm not sure if there have been that many, or at least I haven't heard that many, but people are definitely very interested in taking condoms.
Okay.
So yeah, I don't think really like.
And when I say tested, I'm talking about like STI testing.
Yeah.
Those kind. Yeah. Okay.
Definitely, yeah. I haven't I don't think a lot of people BASIS have come forward about like having STIs, or at least like not to us. But yeah, in terms of like wanting sexual health services, I think a lot of people at BASIS do, and I think like especially when we bring condoms, like people definitely want to take them. So I think that's a good sign.
Okay. New, I see your.
To answer your question, along with condom distribution, we try to help make referrals to like clinics, to their community clinics, and what works best for them. So as youth health educators, or at my school, there were some some times where a peer of mine will come up, and then based on what they want, based on their needs, we can try to help make clinic referral for them and try to hope which one is best for them.
Awesome. If somebody else wanted to chime in on that. Okay, well, the other question that I asked the earlier panel of your classmates before you was around peer support education versus something that you're getting in a classroom. Do you feel like the peer health model works and is something that should be expanded?
If we, it'd be great if I could talk first. So I think the peer model works extremely well. I think people are more, especially from what I've experienced, I know my peers have experienced, it's much easier to talk to people who are your own age because you don't feel judgmental from other teachers. So I think if we could expand that, that would be amazing, because I definitely think it's super effective.
Yeah, I agree with Maya, because students are not really they don't really want to talk to our teachers, especially ones that they don't have a prior connection with. And they're more likely to talk to us, especially for more personal experiences, and if they need help.
Okay. Anyone else want to answer on that? Oh, Tamika, if you're speaking, we can't hear you. No. Are you in the same room with somebody else? Maybe you could hop on their computer. Look at that.
Can you hear me?
Teamwork makes the dream work. I can hear you now.
Okay, thank you. I was saying how I definitely think that when it comes to personal one-on-one questions, when it comes to like peer educators really help with that. But in terms of like a structured way to gain information on sexual health, like having like a proper curriculum in schools is a better way to go about it. But when it comes to like referrals or personal questions or like condom negotiations, I definitely think that's where peer educators step in and really help out each other.
Yeah, I think that makes sense. And that's a really good model. I think also to you all have even heard from today, right? You guys, some of you attend different schools. What you're getting from an education standpoint looks very different. I think maybe it was Carter from the earlier panel who said like, you got anatomy in 6th grade, but he feels like he got nothing else. Another school might be getting it at a different age, or they might be getting some other sort of health class, but meeting some sort of standard across the board on that front. The Office of the State Superintendent is before the council tomorrow, and that might be something that we ask. But I want to thank you all so much for taking time to testify and for being here. And I look forward to engaging with you all more. And thank you for your service to your fellow students, because I do think that you all are providing a valuable service in the work that you're doing. And so thank you so much for being here. Enjoy the rest of your day.
Thank you.
Right. Okay. We made it to the end of the public witness list. As I sort of televised earlier, we were going to take a short break, probably a 15-minute break, and then we'll be back with the government witnesses, and then we will go from there. Thank you. All right, and we are back. Now before us, we are in room 500 of the John A. Wilson building. I have Dr. Sharon Lewis, who's the interim director of DC Health. She will provide testimony for the committee. But before you begin, it is now not a new rule of the council that everyone has to be sworn in. You have a lot of people who are with you. So I'll do, like I also asked Director Turnage, anyone who may possibly come up to the table with you, can they also raise their hands and take the oath? Everyone. For the folks at home, we have a crowd in this room. Okay. Do you swear or affirm on a penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth? Great. Dr. Lewis, when you're ready. Oh, you turn your mic on. There you go. Thank you.
Good afternoon, Chairwoman Henderson, members of the Committee on Health, and my staff. My name is Dr. Sharon Lewis, Interim Director of the District of Columbia Department of Health, or DC Health. Thank you for giving me this opportunity to testify before you today, and congratulations, Chairwoman Henderson, on your appointment as Chair of the Committee on Health. On behalf of Mayor Muriel Bowser, I am pleased to provide this testimony on DC Health's achievements, activities, and overall performance in fiscal year 2022 and 2023 to date. I am a registered nurse with a doctorate in healthcare administration. I've had the pleasure of serving as interim director of DC Health since July 2022 and have more than 30 years of service to DC government and a resident of Ward 7. Prior to serving in this role, I was the Senior Deputy Director for the Health Regulation and Licensing Administration, also known as HRLA, for 7 years, where I oversaw the district's 19 professional boards that regulate 72 professions, food safety for approximately 7,000 establishments, rodent and vector control, animal services, pharmaceutical control, radiation protection, healthcare facilities, clinical laboratories, intermediate care facilities, criminal background checks for health professionals, compliance, investigations, and surveys for the licensing and certification of facilities. Before I get into the testimony today, I would like to take a moment to acknowledge the tireless work of our DC Health staff, the district's healthcare workers, and the sacrifice of first responders and other community partners who work with us to continue to protect our health and safety and to save district residents' lives over the past 3 years here in the nation's capital. DC Health promotes wellness and equity across the district and protects the safety of residents, visitors, and those doing business in our nation's capital. Today, I will share with you the broad agency-wide approach that DC Health, as Chief Health Strategist, is taking to improve population health through an equity-focused lens and address the upstream social determinants of health. Leveraging our 2021 post-pandemic recovery framework and lessons learned, the agency continues to embrace the Public Health 3.0 principles and improve data and analytics, modernize our essential healthcare infrastructure, leverage flexible and sustainable funding, build new and expand existing strategic partnerships, and expand our healthcare workforce. Our agency also continues to advance the Fair Shot priorities of Mayor Bowser's administration's budget and further the district's comeback plan. This includes ensuring that all residents have equitable access to health services and facilities. The COVID-19 pandemic response triggered a new mode of opening at both the macro and micro level and demonstrated how the district can plan, implement, monitor, and evaluate complex programs, service delivery, and policies at a much faster pace than pre-pandemic times. The response also demonstrated the importance of having a workforce that can be nimble and innovative enough to operate successfully through significant change and uncertainty. It is more important than ever for us to leverage community partnerships and meet the current appetite for bold public health action at all levels, including laws, regulations, and institutional policies. Since 2015, we have centered equity in our process of transforming DC Health and have used our learnings from the DC Health 2021 Health Equity Summit and our recommendations and approaches to reducing health inequities as outlined in DC Health's Health Equity Report. Our collective action must be intentional with respect to all the 9 key drivers of health: education, employment, income, housing, transportation, the food environment, medical care, outdoor environment, and community safety. Our work and the mayor and council's investments in DC Health and the interventions to address the social determinants of health will chart us a path to an inequitable future that will enable every resident to achieve their optimal level of health, regardless of where they live, learn, work, play, or age. Health IT and data are critical to identifying emerging issues and identifying inequities in our community. With effective systems, we are better able to protect and improve the public's health by promoting prevention and even intervention opportunities, as well as improving service accessibility for residents. DC Health continues to make significant progress towards modernizing its IT and data capabilities and has a bold plan for the coming years to continue its investments in both data systems and the customer experience. I would like to thank Councilmember Henderson and other members of the council for their letters of support for a CDC grant strengthening U.S. public health infrastructure, workforce, and data systems. We currently receive that will invest over $8 million over 5 years in enterprise-level information infrastructure. This project will focus on the dual impact of investment in enterprise analytics and customer relations management as its primary strategies. We are using this funding to respond to the post-pandemic environment, which has created a new sense of urgency to meet the expectations of the public for timely data and a robust customer relations experience. The agency continues to make significant investments in enterprise-level information management, built upon the gains made under prior infusions of emergency funding from the COVID-19 pandemic response, improved responsiveness and accountability to district residents, made high-value information more readily available to the public, and helped the DC Health workforce operate more effectively and efficiently. Key achievements include the development of an online portal for the State Health Planning and Development Agencies, also known as SHPTA, Certificate of Need application. Previously, applications were only available by submission of hard copy paper documents. This modernization will allow incoming or health facilities wanting to expand to apply, get status updates, and begin serving district patients more quickly. The implementation of a digital licensing portal for all health facilities. Previously, all applications and renewals were submitted by hard copy paper documents. Our new portal will provide a paper-free, automatic, and user-oriented experience for all facilities and will accelerate the process of expanding DC Health's healthcare system. Modernized the Office of Food's Certified Food Protection Manager's application, which is now online. Since moving to an online application, we have processed 1,525 Certified Food Protection Manager applications with an average processing time of 6 days, and 42 mobile vending applications in an average of 20 days, which includes an inspection and plan review. Also, transitioning medical orders for scope of treatment from a paper form to an electronic form known as eMost this month. The district is empowering patients by allowing them and their providers to quickly and easily create an advanced care plan and make it immediately accessible at the point of care with over 1,000 area providers, including all DC hospitals. DC Health will roll out awareness and training over the coming months as the new system is adopted by patients and providers. The launch of the new DC Health EMS e-portal in February 2023, which is an online certification management platform for EMS personnel. The district is now the first in the nation to provide real-time validation of national certification, which will cut down on certification delays and more quickly get EMS technicians to work. The DC Women, Infants, and Children, WIC, program has completed a statewide transition from paper voucher benefits to an electronic benefits transfer, also known as EBT card system, while simultaneously onboarding a new management information system, referred to as eWIC. This two-pronged statewide program enhancement will modernize the process of enrolling participants, issuing benefits, and supporting participants' nutrition needs. The change will also help improve the shopping experience for WIC participants and streamline the payment process for participating stores. The most recent enhancement of our health licensing system in February 2023 allows applicants to know what information is missing, which addresses a long-standing concern by external stakeholders. DC Health's commitment to integrating an equity lens into program and policy development has resulted in an increase in the number of youth and children who have documented having received routine pediatric vaccinations. DC Health, in conjunction with Children's School Services, District of Columbia's Public Schools, Office of the State Superintendent, and public charter schools, was able to shrink the percentage of children in public and charter schools marked non-compliant with routine pediatric immunizations and doses, the district's immunization information system, by almost a third, from 25.5% of children non-compliant to 17.5% of children non-compliant. Clearly, we have more work to do to protect our children from vaccine-preventable diseases, but this is progress that we hope to build on. We want to thank those schools that worked with us to expand access to immunizations, obtain records of the vaccinations their students received, and updated the immunization registry with that information. DC Health also acknowledges the impact that the national and local nursing shortage has had and continues to have on the ability for schools to have full-time nursing coverage. An early proponent of the whole school, whole community, whole child model, DC Health ensures that the public health and school health sectors are aligned to give each child the opportunity to be healthy at school. To that end, DC Health uses the health needs of children at each school along with other data, such as health suite utilization, to ensure that every child who needs access to a nurse has it. Of the 177 school health suites at DCPS or public charter schools, 113 or 64% have 40 hours a week in-person staff coverage. Another 25 or 14% have 32 hours a week coverage, and the remaining schools have 24 hours a week of in-person staff coverage. Importantly, all schools have access to a nurse or allied health professional, either in person or with an allied health professional or by telephone coverage by a nurse. However, the inability of children's school services to hire sufficient nurses is concerning to parents, school staff, CSS, and us. The district statute currently requires 40 hours a week of in-person coverage by a nurse. This goal has never been met and is unlikely to be met in the next several school years due to the national and local nursing shortage. We are therefore working with CSS to explore alternative models for full staffing of school health suites that will meet the goals of the whole school, whole community, whole child model and needs of children without relying solely on nurses. This model and modern school health services do not aim to replicate existing healthcare services within a school setting, but rather ensure students' health needs are met while in school and appropriate referrals are made to connect a child to primary care, mental health, and social services as needed. Health planning in the District of Columbia includes both population health planning and healthcare systems planning. Effective planning begins with a shared understanding of the health trends and key drivers of health outcomes observed within a population. To improve population health planning, DC Health released its framework for improving community health in January 2023 to prevent the leading causes of death, protect and promote the health of mothers and children, and eliminate racial and ethnic disparities in health. This framework outlines strategies on expanding access to health services, improving clinical preventive services for adults, ensuring adequate reproductive health services, prioritizing support and care of young children, expanding preventive services for children and adolescents, reducing tobacco and marijuana use, and addressing nutrition and physical activity and weight status needs by residents. This framework has measurable 5-year outcomes and lists actions to help achieve those outcomes for key sectors, including healthcare, health insurance, community-based organizations, employers, schools, and government. Any individual organization within the district that works in any of the areas above can identify and implement evidence-based action laid out in the framework to improve population health in the district and work towards eliminating racial and ethnic health disparities. Last May, the State Health Planning and Development Agency, SHPTA, released its annual implementation plan, the AIP, which provided an update on its 5-year health systems plan, HSP. This will inform the new HSP and chart the path for the district's healthcare landscape for the next 5 years. The AIP aligns the health systems plan created over 2 years ago before the COVID-19 pandemic with the post-pandemic realities and centered around the SHPTA's role in the context of all other district public health plans and strategies. It also brings together the various district-wide reports over the past 5 years and incorporates the priorities into the AIP. This AIP included 3 broad recommendations: promotion of seamless, safe, and effective care transitions, promotion of primary care and urgent care engagement, promotion of COVID-19 post-pandemic and emergency responses. These recommendations are tied to recommendations from the myriad of health-related reports developed over the years and will be used to help fill the service and workforce gaps identified in the district's health system. Leveraging our health system improvements over the past several years and lessons learned from COVID-19, DC Health was able to quickly and effectively address an mpox outbreak in the spring and summer of 2022. DC Health and partners quickly developed and implemented a vaccination registration portal, resulting in over 39,000 vaccinations and only 6 new cases since November of 2022. We also opened 3 standalone mpox clinics in high-need wards in the district and worked to address racial disparities in vaccine access through communication and outreach strategies. DC Health created MPOX guidance for schools and childhood and child care facilities and created an online dashboard to report data on a weekly basis to increase transparency and ensure community groups, partners, and members of high-risk groups had the information they needed. This resulted in DC Health receiving national praise for our quick and equitable response to the outbreak. The past 3 years have been a challenging time for healthcare workers and public health professionals. They have worked long hours at great personal risk to ensure that district residents, visitors, and workers were safe. These long hours and health risks, however, took a significant toll on workers and have exacerbated existing healthcare worker shortages through burnout and retirement. Though DC Health has previously worked to grow the workforce and expedite licensing, while still protecting patient safety, that effort took a new urgency since the start of the pandemic. Since DC Health was last before the committee, we have begun several new projects and initiatives to support and grow our workforce. Last summer, the Mayor Bowser established the Healthcare Workforce Task Force. The task force was comprised of a multidisciplinary group of leaders across the district in education, employment services, healthcare, and government. The task force was charged with examining the barriers that negatively impacted the district's healthcare workforce. Members were then assigned to 6 subcommittees to provide recommendations on how to expand a resilient healthcare workforce in the District of Columbia. 1, strengthening recruitment of existing qualified healthcare workers, increasing district resident employment in healthcare occupations, improving opportunities for advancement in health careers within the district, focused retention of health professional students post-graduation, enhancing access to high-quality allied health training programs, development of a health careers pipeline strategy. The report summarized the barriers and challenges created short-term, mid-term, and long-term recommendations to expand the district's healthcare workforce. Strategies include aligning education with modern job skills, expanding scholarship and other tuition support opportunities, conducting further analysis of the workforce landscape, and expanding opportunities to more district residents to enter entry-level healthcare workforce careers with opportunities to move up. Over the coming years, DC Health, its sister agencies, and community workforce and education partners will shift to implementing these strategies. DC Health has also been updating the Health Occupations Revisions Act, or HORA. For the first time in almost 2 decades, the HORA is the governing statute over healthcare professions, licensed and unlicensed, and dictates the structure and makeup of boards, as well as how and when telehealth can be provided. This update will consolidate several small boards into larger boards and add new members to reflect the change in boards' purview. This will reduce the burden of frequent meetings on staff so that they can spend more of their time processing applications and supporting existing licensees and new applicants. It will also allow for more cross-learning within boards as new professions are added to boards and those practitioners are able to share with their colleagues emerging practices from their own professions. This legislation will also allow all licensed health professionals to provide telehealth services consistent with applicable standards of care and scope of practice. This change would increase access to healthcare services for those who are homebound or unable to easily travel to a practitioner's office. Last year, our agency worked closely with council, particularly members of the Committee on Health, to pass an expansion of the Health Professional Loan Repayment Program and build out a new health professional scholarship program. The Health Professional Loan Repayment Program is a long-standing effort by DC Health to incentivize health providers to work in high-need communities. Previously, the program provided loan repayment assistance to full-time primary medical, such as physicians, physician assistants, nurse practitioners, registered nurses, and certified nurse midwives; dental, for example, dentists and registered dental hygienists; and mental health, such as licensed clinical social workers, clinical psychologists, nurse practitioners, and licensed professional counselors, providers only at non-profit or public sites. The Health Professional Loan Repayment Program also included medical providers who practice in wards 7 or 8 and specialize in psychiatry and obstetrics and gynecology. Thanks to the expanded legislation Council passed, DC Health expanded the program to medical specialists and subspecialists that address the leading causes of death in the district, adding a part-time option for healthcare workforce that work less than 40 hours per week and for-profit sites that provide care to underserved populations. The other portion of the legislation that Council passed created a health professional scholarship program, which is designed to bring new talent into the healthcare system, particularly in entry-level positions that have a high number of vacancies. DC Health was granted the authority to begin this program at the beginning of fiscal year 23 and is looking forward to starting the program soon. Beyond supporting new strategies to expand the healthcare worker pipeline, DC Health has been working to improve its licensing process for new and existing healthcare workers. This work is informed by community and stakeholder engagements, as licensing board staff have met with schools and other key stakeholders to identify opportunities for improvements. This includes customer-facing improvements through information technology, but also updated regulations and a codified temporary license, which was first introduced in 2021. DC Health will shortly be launching a DMV reciprocity agreement for the Board of Medicine, a step that could eventually be shared across all healthcare professions. DC Health has also enhanced the licensure system to improve quality assurance, included a workforce survey in every renewal application, and created a notification system related to when an applicant has uploaded requested information. Taken together, this new modernized licensing system will further speed up application processing, which in fiscal year 22 took 28 days and has already dropped to 18 days in this first quarter of fiscal year 23. I want to thank Council for providing an enhancement this year for funding additional licensing specialists. This investment has been instrumental in our improvements to speeding up processing of applications. Applicants for licensure have several pathways to licensure that depend on the license type, the existence of licensure portability options, and if they are a new applicant or renewing. When reviewing applications or renewals, DC Health's licensing boards consider the EEE in reviewing license applications to ensure that all licensees are qualified and capable. Education: has the applicant graduated from an accredited school? Examination: has the applicant passed the required examinations? Experience: has the applicant obtained the necessary clinical experience to competently practice? The boards also have several screening questions. Determine if any fees are owed to the district, such as the clean hands. Complete a background check and request the applicant to provide proof of licensure in another state, if applicable. And in some cases, complete a jurisprudence exam. Some applicants may be required to submit additional documents if there are issues identified in the initial application. DC Health, however, does not automatically deny even those applicants who may have positive results on a background check or a disciplinary history, but rather gives them an opportunity to provide context to the board so they can tailor their decision to each applicant. Finally, I want to share that our agency has also recently completed its strategic planning process, or SP 2.0, in accordance with its status as an accredited agency by the Public Health Accreditation Board, also known as FAB. This strategic plan will ensure that an organization, DC Health, is working towards common goals and continuously improving population health in the district. DC Health developed SP 2.0 as a continuum on the progress it achieved over the past 5 years through its first strategic plan, SP 1.0. Having engaged over a third of the agency staff and nearly 50 external partners, SP 2.0 will guide the internal development of the agency as it furthers its mission of advancing population health. In closing, I hope my testimony on some of our recent efforts has offered a clear picture of the important work DC Health has undertaken as the district's chief health strategist, and how our larger strategic vision is focused on improving population health, addressing equity, and expanding the capacity of our agency to meet emerging public health threats. I again want to thank DC Health's team for their sacrifices over the past several years to keep us safe. I also want to give special thanks to Dr. Jacqueline Watson, Chief of Staff, and Keith Fletcher, our Chief Operating Officer, for their support during my interim directorship. I appreciate the members of the committee for giving me this opportunity to testify, and I look forward to any questions that you may have at this time. Thank you.
Thank you, Dr. Lewis. You covered a lot of ground there in your testimony, but we'll get into some of those via questions as well. And I think we've also been joined by one of my colleagues, and I'll turn to them after. We're going to do 15-minute rounds. Okay, so let's start at the top in terms of organizational. DC Health had a 24.5% vacancy rate in FY22. Has this affected your operations, and what is your strategy for retaining and hiring for these vacancies in the future?
And thank you very much for that question. I will also ask Keith Fletcher to join me, our Chief Operating Officer. And yes, currently DC Health has a total of 745 FTEs, and you will see a 0.8. That's because we have people working various times, such as part-time or whatever it may be. I will say, as part of our SP 2.0, we have worked very hard in looking at our pool of employees. We have been very active in making sure that we do recruitment. We have been very successful in bringing on additional staff. I will say that we do have a significant number of new staff at DC Health. And I'm excited because I'm able to greet them at least every 2 weeks, because I do see them on the floor that I am currently located. So with that, we're able to continue with our current operations. We have not had any deficits in any of our projects or our visions or any of our mission focused areas.
Okay, that's good to hear. Do you all have independent hiring authority, or do you hire through DCHR?
We hire through DCHR, okay. Yes.
One of the things that I brought up with Director Maxwell at DCHR is that oftentimes I'll have conversations with agencies. They'll say we have X number of vacancies, and then we go to the DCHR site and I don't see any for your agency that's posted. How frequently are you all posting and keeping positions open? I guess a better question is, are you satisfied with the level of collaboration with DCHR in terms of making sure that your positions are being posted timely and are staying open for a long enough manner for you all to actually get applications?
I will say that we have been pleased with working with DCHR. We have been very effective with the hiring fairs. We have been engaged in, I believe, at least 2.
Okay.
And we have hired a significant number of people. I believe even through one of the hiring fairs, it was more than 50 plus individuals that we were able to hire.
Okay.
So we have been very successful with that. We have not had an issue with them not posting our positions.
Okay.
I think that we have some pretty assertive managers and trying to make sure that their information, their vacancies are posted.
I love all the word choices that we are using. Assertive, yes. And I'm going to use this question as a sort of transition to talking about COVID-19 and what's going to happen as the public health emergency is over. But, we saw recent news this week that you all are going to be transitioning away from using public libraries as a point of distribution for the rapid test. But I know from my going to the library, you all had staff who were there manning those tables. What's going to happen to those individuals?
So currently, those individuals that were in the libraries and the other locations are actually contract staff.
Okay.
Just to be clear on that, currently we still have our COVID centers, one in each of the 8 wards. Our district residents can still go there. They can have their PCR test. They can still pick up the free antigen test or the quick test if they so desire.
How long are we keeping our COVID centers?
Well, at this time, what I can say is that we have a clinic in each of our 8 wards.
Now, come on, Dr. Lewis, like we can have this conversation
what
today,
I can say.
and then y'all send a press release tomorrow, and then we look ridiculous. So, obviously, for some of the sites, right? Okay, I think the site in Ward 2 is in an office building. I think the site in Ward 6 is in an office building. The site in Ward 4 is in a church. There's going to come a time when some of these places are going to want their spaces back.
So at some point in time, yes, the sites will close at some point in time, but what we're making sure that our district residents would be fully aware of is that they will still be able to have some of these services managed. So we have definitely engaged our partners such as our pharmacies and other, I don't know if I should actually indicate names of companies, but that will be available to any of the district residents to go and get their vaccine. We do know that as of May 11th, there may be some changes depending on the type of insurance you have. There may be some co-sharing or co-pay that may be required, but that's not something that comes under our purview.
Okay.
But there will still be services that will be available to our district residents as it pertains to getting the vaccine or testing.
Okay. Well, one of the things that I actually had a resident who emailed me about who's immunocompromised and basically said, I understand that case counts overall are down, but for those who are immunocompromised, we are still very much at high risk if we contract the disease. And one of the questions he had specifically was, what's going to happen in terms of the data reporting, because he uses the data to determine whether or not this is a higher risk time for him to go out versus not. So my question to you is, will the reporting continue in terms of case counts, or will we now maybe pivot to doing more of our reporting from wastewater surveillance? How are we going to pivot as we move to the next phase, but acknowledging that people still very much need this information to make decisions about their everyday lives?
Yes. So I will say that effective May 11th, CDC will not require the states to actually submit information on the case counts. That's something that we internally can continue to discuss what we would want to maybe have available on our website. So I will take that back to our team and further discuss that. In regards to what we want to make sure that our district residents and of course the council are fully aware of, we definitely want to make sure that those that have not received their bivalent booster do so. I will say that if I were to look at the District of Columbia as a whole, about 80+% of our district residents have had their primary vaccine, and just under 30%, around 27% have had the bivalent vaccine. If I were to take a look at those that are aged 65 and up, I would say that over 90% have received all of their primary vaccines, and that well over, I think it's around 60% or so, or 50% have actually received the bivalent. So we're looking very good. I think we're actually at second state, if I will, as far as our residents having received the bivalent vaccine.
Okay. Well, one of the things, I mean, Mark Miller from the long-term care office, he raised this earlier in his testimony. Only 70% of residents who are living in assisted living facilities and 72% of residents in skilled nursing facilities have received their booster. What are our efforts specifically with those communities? I know that we've been doing it writ large, but I think there's still some concern in terms of our seniors and elder population, making sure that we're making those boosters available.
Yes. So what I will say that our staff, not only from CPPE, the EPI staff have been working very closely with the long-term care facilities, but also the staff of Health Regulation and Licensing Administration, the long-term care team, specifically the Healthcare Facilities Division and an Intermediate Care Facilities Division have been working very closely with our long-term care facilities. What we must remember is that everyone has a choice. So within our nursing homes, and I know that I've had some conversation with Veronica Demishin-Sharp, who is over the Executive Director of Health Care Association over the nursing homes and assisted living, that there's been a concerted effort to try to get as many of our nursing home residents vaccinated as it pertains to the booster. Many of them have received the primary vaccine. With that, some residents have just said no, and we have to respect their right with that. But we will continue with that conversation.
Okay. I know that you said for some of the things in terms of the public health emergency, you all ending, you can't control, but one question that has been raised is around access to antiviral treatments like Paxlovid or Paxlovid, that one. Will that end with a public health emergency? Like, will it now be based on what your insurance will cover?
No, that will not end. You will still have access to treatments.
Okay. Right. One of the things that I hope, as we are sort of thinking about moving to sort of an endemic space and then, stuff with the Community Health Administration, is even if we're rolling back the COVID centers, is it a way for us to be nimble enough to respond to spikes? And what I mean by that is, in the same way that flu season, we know when flu season is going to spike, is it possible for us to think about a strategy where we as a district are saying, okay, we're coming into flu, maybe possibly increases in COVID season. So we're going to roll out some additional locations. We're going to make flu shots available outside of the pharmacies, et cetera, to handle the capacity issue. And then we roll it back as the spring erupts on us. And so I would love to continue talking with you about that. We've been having conversations, obviously, across the health cluster because, frankly, I feel like there are a lot of things that are kind of happening all at once this summer. End of the public health emergency, we're bringing on new MCOs, we're transitioning the behavioral health folks to MCOs. We are doing redeterminations for Medicaid. We are doing redeterminations for the Health Alliance. And I don't want anybody to get left behind in all of this movement. And so I just want to make sure that everybody is talking with one another about that.
Yes, and we will want to continue that conversation with you.
Okay, great. Let me just ask one other question in terms of the public health emergency. DC Health had DC Health had allocated $5.1 million in federal public health crisis response cooperative agreement grant. Okay. You were allocating it among health providers in clinical settings, school staff, and other health professionals. I'm curious how you all allocated that funding, and then also what are your plans? Are you on track to spend down that money before it sunsets in June of 24?
Yes, so I'm going to look to my partner to my right.
Okay. If you could just introduce yourself again for the record.
Hi, I'm Keith Fletcher, the Chief Operating Officer. I don't know the exact details of the FEP grant, so I'll have to dig into my book to find it.
Okay.
One
Don't
of the
worry, we'll have a whole budget section, so I'm going to save this question and I'll come back to it for you. Okay, let's talk a little bit about opioids and substance abuse. I obviously got into this a lot with Dr. Bazaran and the Department of Behavioral Health, but I don't think a lot of people realize that DC Health actually plays a strong role in the Live Long DC strategy. And you all co-chair the Opioid Fatality Review Board. I went to the hearing for the chief medical examiner and obviously have been reading the surveillance reports that have been coming out in terms of overdoses. How are we as a government using that data, not just on the numbers, but the demographics and the geography of where these deaths are occurring to change our strategy from a public health standpoint in terms of communicating with people about substance abuse?
I would say that we have, at DC Health, we've been working very closely with our partners, including the CBOs, because they are on the ground and know many of our residents that have needs. As it pertains to what we do largely with DBH and even with OSSI, we have joined in with a memorandum of agreement such that we, of course, are supportive of having the naloxone even in the schools. So with that, with our nurses in the health suite, we help with the training if we're asked to do so or to train others on how to administer naloxone. So with that, we also have our prescription drug monitoring program, PDMP, as we refer to it, where we do monitor even with the physicians and how they order certain controlled substances. And so we take a close look at that as well. So there are a number of things that we incorporate and include within DC Health across all of our administrations, as well as our sister agencies.
Okay. It says DC Health is currently installing 6 vending machines for free naloxone and other health-related products for drug users in the district. What is the status on this and where will these vending machines be?
I believe they're currently already posted in the communities that we have identified. I will have Clover Barnes, who is the Senior Deputy Director of HOSTA, to present on that piece.
Good afternoon.
Good afternoon.
So we do have 6 vending machines that are created through a partnership with 2 community-based organizations. We use the geospatial mapping you were speaking about from the OCME to figure out where to put those. 3
So
of
they're
them,
already out.
3 of them are out.
Okay.
And there are 3 that are being placed. There was an issue with the order when they came in. We got caught up in the fun of COVID and having things delivered and distributed. But 3 of them are placed and we are working to get the other 3 out as soon as they are available and ready.
Okay. And so is DC Health going to be the one that's responsible for keeping them stocked and tracking usage?
The community partners keep them stocked and track their usage. We receive reporting monthly on the usage and what's stocked in the.
Okay. I'm over my time and I believe we've been joined by Councilmember Vince Gray. Councilmember Gray, there you are.
Thank you very much. How are you?
I'm good. Good to see you.
You too. I have a few questions I want to ask. We'll start with you, Dr. Lewis.
How are you, Councilmember Gray? Good to see you.
I was thrilled to hear about the update to the licensing portal.
Yes.
To make the process more transparent. Can you tell us more about that? And if it was tested before it went out to go live? I'll look forward to hearing a little bit about that, okay?
Yes. So, and thank you for that question. This is actually really hot off the press, a new feature that we have added to our licensing portal. We've listened very, very attentively to not only our council, but as well as those that are submitting their application and our members that of our healthcare facilities. So one of the major things that people have verbalized is that they're not sure of what it is that may be missing or the status of their application. We do recognize that we submit emails to the applicant to let them know what may be missing, although we also realize that some of those emails will go to spam, and whether or not people think to look in that area, we recognize that piece. But what we added to our licensing portal is a new drop down that the health licensing specialist will now click on to identify what's missing in the application. For example, if I have submitted my application, but I've paid for my criminal background check, but I have yet to actually go and have my CBC criminal background check done, or my test scores are not in the drop-down menu, that health licensing specialist will now check off those items that will now be visible to the applicant. That's a new feature that was just implemented. So we're excited about that. We did do some testing with that to make sure that that feature works. So hopefully we will have less concerns from the public in regards to what is missing in their application.
Thank you, Dr. Lewis. Last year, I worked with you on legislation to provide scholarships for high need healthcare training. Where are we on the implementation of that, Dr. Lewis?
Yes, well, we're excited that that did pass the high need scholarship plan. Unfortunately, we did not have any funding to go along with that, so we have yet been able to actually implement that. However, of course, we still strongly encourage many of our schools to do the recruitment. As you know, we have one high school here in the District of Columbia, and there may be another one, but I am very sure of the one high school that does have a school for entry level for CNA. But we would be so excited to be able to get some supportive funding for that, so that we can truly move forward with that high needs scholarship program. That was not only for like our CNAs and home health aides, but it also included with EMS under HEPRA. So also for the entry level person to be able to go through the program. So with that, we would be ready to move forward as soon as we can get other supports.
Can you tell us what schools there are that will be involved in the effort, Dr. Lewis?
I would have to get back to you on the schools. I will say that while we were doing the planning, we did reach out to several schools to see if they would be interested in the program. And they did acknowledge interest in supporting the program, but I would have to get back to you on that.
Okay, well, we'll look forward to getting the additional information from you, Dr. Lewis, that we can provide to the schools that have expressed an interest. Are you at liberty to talk about what the schools are?
Well, the schools were some of the CNA schools and the schools for HHA, home health aides and certified nursing assistants. And then as well for the EMS side, that was for the paramedics.
Okay. Last year, we worked with you on a number of efforts to try to be able to move forward with this. We know we have a shortage in healthcare workers. Can you talk to us about reciprocity and what that would look like?
Yes, you're asking a couple of good questions here. So let me just tell you what's hot off the press in regards to I don't want to say reciprocity, but we try to hold true to our word at DC Health. We want to listen to our constituents and be very responsive. So with that, as you know, we had talked about through the Board of Medicine, which we do have the compact there, but, you know, stating that you want a compact, you have to rely on that commission to make sure that they can develop all of the API, being able to speak from their system to our system. They have to develop all of that connection. So we moved forward and we listened, and we even did brainstorming within our office, and we reached out to our counterparts in Maryland and Virginia as it pertains to their boards of medicine. I am pleased to say that I have signed off on the memorandum of agreement between DMV for the regional Board of Medicine licensure. So that just happened. So I am really excited about that.
That is great news, Dr. Lewis.
Yes, thank you, thank you. Now, next note, now that was just one start. So the next thing that we have done, we have actually sent out communications to Maryland and Virginia for nursing, because we know that those are our top two. They're not the only. This is just the beginning, but we know how important it is to have that portability for nurses. So I will say that our executive director has reached out to her counterparts in Maryland and Virginia to start that conversation in regards to having a regional nursing licensure as well. So I would be really excited about that as we start those meetings. But that communication, actually the written documents, as far as we need to set something up, that has happened already. So that's just the beginning.
Okay, well, that's great news also, Dr. Lewis. And thank you for your efforts to be able to make this, you know, make these opportunities available to people that otherwise wouldn't have it if we followed the same course that we have historically. Reciprocity. Can you just so we're clear? Can you be clear about where we are with that? What that would look like?
So in regards to reciprocity, DC Health actually has 3 that I can recall reciprocities. One with the Board of Medicine, but as I said, we're waiting for that commission to get their processes in order so that there's that communication IT-wise for initial licensure. Something has been developed for renewal, but not for initial licensure. For PT, physical therapists, we do have a compact in place for physical therapists. We also have the Psych Pack compact. They all are a little bit different. I know that there's been a lot of discussion about the nursing compact at this time. The District of Columbia, I will say that I'm not going to say that we're not going to continue discussion on it. We will, but I just want to alert all that with the nursing compact, we're going to be a little bit cautious. And let me just tell you why. So if you've been looking at the news, I believe it was on January the 25th of this year, the Department of Justice announced that the FBI had completed their Operation Nightingale. I wish they had chosen a different name, but Operation Nightingale. And it was identified that there were several schools in Florida that were actually issuing fraudulent diplomas. Unfortunately, some of these schools did have legitimate programs, and then things went awry with a few. I think there were about 25 people that were pointed out that were under very close scrutiny. Some of those individuals that were licensed through this fraudulent process actually were in the compact. So, you know, with that, as you know, here in the District of Columbia, I already talked about the 3 E's. So we want to make sure that when we look into the educational component, that we can truly verify that these individuals have graduated from an accredited program and that it is a legitimate document. So with that, what I'm going to say is that we will be very aggressive in making sure that we reach out to our partners in Maryland and in Virginia to see if we can have this regional licensure for nursing. And we will continue with discussion with our Board of Nursing and the public as it pertains to the compact.
Thank you very much, Dr. Lewis. And I, by the way, appreciate the training that you have worked hard to make happen here in the District of Columbia. So thank you very much. Other jurisdictions have allowed training for medical careers to begin for those who are still in high school. Can you tell us more about that?
Yes, so the one school that we have in a district, and I think it would be nice to say that's Coolidge, they have the CNA program so that while the students are in high school, they can start to take the coursework to become a CNA. And I will say, I know it was mentioned earlier today by some of our public witnesses about the Horrid Health Occupations Revisions Act, and I even mentioned it in our testimony. We're working very hard. It is on my desk to review. And within that document, we are planning to lower the age because I believe it's depending on what profession is either 18 or 21, but we do plan to lower the age. So we have listened to our stakeholders, if you will. So with that, the students in the high school setting can go ahead and take the course and then take the test and work. I will say that I'm an example of that. While I was in high school many years ago, before we had a number of the rules in place, I actually took a CNA course at the then Providence Hospital and was able to work while I was in high school as a CNA. And I found it to be quite rewarding. And of course, now I am a registered nurse. So yes, we want to continue that discussion.
Fantastic. And you are certainly a tremendous worthy product of the training that we spawned here in the District of Columbia. So can you talk a little bit more about the programs here in the District of Columbia that have been helped to get started, and what more needs to be done to be able to facilitate the next steps for them?
So if you're talking about some of which programs, are you talking about the schools or you're talking about licensure programs?
The schools, yes.
The schools. So, yes, depending on the profession, like for example, our Board of Nursing, as well as the staff within our HEPRA, there are requirements for the different schools. We work very closely with the schools for technical assistance. However, they must meet our standards and requirements because we want to make sure that not only is the course curriculum a solid curriculum, but also the clinical experience is that what it should be, such that hopefully they will be successful in passing their certification exams or licensure exams, whatever it may be.
Mm-hmm. Thank you, Dr. Lewis. Do we know, by the way, how many people are participating in what we spawned? And that was the loan repayment program in the District of Columbia and its recent expansion, what we've been able to do in the recent past?
I may have to get back to you on that number. If that wasn't a number that was asked, I have a very thick book in front of me. If that was a number that was not asked, I may have to get back to you on that.
Councilmember, okay. We could add that to the list of follow-ups that we send to the department.
Thank you. I appreciate that.
And thank you, council member and the council for that support in passing that. That was very helpful for us to be able to now move from full-time to be able to engage those that are part-time in this program. So thank you all for very much for that.
Well, we're glad to be able to do that, and we'll look forward to continuing to work with it, Dr. Lewis.
Thank you.
Okay. All right, Madam Chair.
Thank you, Councilmember Gray. I want to follow up on just a couple of things that you all talked about, and then we'll get back to opioids, so don't go anywhere. You know, one of the things that came up not just today, but came up on Tuesday, was around the certified nurse assistant program. And you announced, I don't know if it was an announcement, but I'm gonna call it an announcement, that you do plan to lower the age. What are you gonna lower the age to? 16? That was the request. I didn't.
What I recall is 16 in the horror. 16.
Okay.
Yes. Mhm.
The other thing that was raised specifically, I think from the long-term care group around that, was the certifications and trainings for both the CNA and the home health aide are similar, but they're different programs. And then you have to go through different processes, and then you have to pay separately for those licensing fees. Is something that you all are considering a way to, I don't know, dual track that work, so that someone who is a CNA can go back and forth between the two if they also, or they can pursue the licensing process at one time without having to go through separate processes?
So the training is slightly different for the CNA and home health aide. So for the home health aide, I mean, the CNA I have memorized, it's 120 hours of curriculum. For the home health aide, if I'm a CNA, want to become a home health aide, right now, that bridge course is 32 hours. That includes a clinical experience, I believe about 16 hours, and the other part is coursework. With that, one of the major differences is being able to manage the patient in the home. Cooking, diet, all of that is very different than the CNA who's going to be in a facility. That home health aide is more under the supervision of that staff nurse that's going to make a visit once or twice a month. Very different than that CNA that's working in a facility under constant supervision. What we are looking at, and as we continue to revise our regulations, is how we can make it easier for that CNA to be home health aide. The testing is currently different at this particular time for both. So we will continue to have that discussion. I know that our Board of Nursing is quite interested in that as well. So we will continue to have that discussion. We'll keep you informed.
Okay, great. That's good to hear. And then in the conversation that you had with Councilmember Gray about the nurse compact, now I can appreciate what happened, the due diligence on our side, as well as us being cautious, because I remember when I got the news alert about what happened in Florida, I was like, oh, yeah, okay. Given that we know that a lot of jurisdictions had suspended some of their licensing rules just to get healthcare workers in during the pandemic, I had wondered how many people, how many states had been impacted by what was happening out of that facility. And frankly, if we're going to be honest about the situation, I'm sure there are probably other places in the country where this is happening as well. But as Dr. Newman mentioned in his testimony, 39 other states have joined this compact. And so I guess are we going to still consider this? Or are we putting it on ice for the long haul for right now?
We will continue the discussion, but let me just make a couple other things clear about the compact. With the nurses compact, it was one of the first ones, and it is a little different than the other compacts such as the psych pack or the PT pack, physical therapy pack compact. For example, with those two, if there is someone, let's say in Utah, who is licensed, a member of the compact, and then they say, you know what, I'd like to come to District of Columbia and work, then there's communication with those boards to let them know that Sharon Lewis, physical therapist, Sharon Lewis, psychiatrist, wants to come to the District of Columbia to work, and a letter is sent to those boards to acknowledge of their approval and that they meet all of the requirements. For the nursing compact, there isn't that communication. So once again, I'm Sharon Lewis, nurse. I live in Utah, and I'm a member of the compact. I now say, I want to add the District of Columbia to my compact list. They will then, money is exchanged. No money comes to the district though. Not even for, no money comes to the district, just no money. So therefore, they add that on to their list. They don't get any type of credential, no communication with our Board of Nursing. So I would not know that that individual is here in the district working.
Oh, wait, so they don't have to make themselves known?
No, they do not.
Interesting.
They do not. In addition, so they do not. They don't have to make themselves known to us. And I know that money is not everything. I know it'll be well over $1 million that we would lose because, as you know, nursing is our largest RN. Now, let me just have you think about something else, our council members and our district residents. I am an RN nurse practitioner. So here in the district, you get your RN license and you add on your nurse practitioner. If I want to join the nurse compact, that would only be for that RN component, not the nurse practitioner component. So here in the district, especially during the pandemic, I will say that not only did we utilize a large pool of RNs from other states that came in via the nurse staffing agencies, which we have between 150 and 180 licensed nurse staffing agencies that brought nurses in here to the District of Columbia. Here in the District of Columbia, as a nurse practitioner, you have independent authority, you can prescribe, so you have abilities to add to what the needs are here in the district, where to as a support, even equal support to the physician. Very different, but you still have independent authority. You can have your own business, if you will, as a nurse practitioner. So that's not going to help that nurse practitioner with a compact. And as you know, our numbers have been increasing with our nurse practitioners here in the district. So it's one thing to say that let's enter into the compact. I think we need to really have full understanding of what that compact would then mean for us.
Okay. That was helpful in sort of explaining a little bit more. Is DC Health developing a training for more direct care workers to receive medication aid training? I know you spoke a little bit about the differences between a CNA and a home health aide. My understanding is that there's a separate training for medication aid. Yes. So with that, we have been working closely with one of our local universities in regards to development of a program, as well as some of the other schools. I would have to get back to you on the status of that. But that is something that our Board of Nursing, as well as the staff within the Board of Nursing within Health Regulation and Licensing Administration have been working very closely with. Okay. At the licensing board hearing on Tuesday, I think it was the board chair for pharmacy.
Oh, yes, Dr. McCann.
Dr. McCann described a recent policy change to no longer require Social Security numbers, therefore allowing health professionals to apply without disclosing their immigration status.
I'm not aware that we required Social Security numbers with our application, do we? So I would have to get back to you on that. I am not aware of a recent change. So let me get back to you on that.
Okay. I think that goes to a conversation that we had specifically on licensing around, DACA recipients and things like that who have been here, they have legal protected status, they go through the training, they meet all the requirements, but then when we have things like this in our applications and processes, can they actually go about getting a professional license to be able to practice? So we can definitely delve into that a little bit deeper. Another thing that came up on Tuesday was around the critical vacancies that we have for some of our licensing boards. And talking to some of those chairs, obviously, they said, we're working on it. We have some people in the process. We have some people in the pipeline. But one of the things that was raised was the requirement that if you serve on the board, you have to live in the District of Columbia. And I'm curious if you all are having conversations to change those requirements to something maybe have lived or have practiced for X number of years in the District of Columbia in order to be able to get our numbers up for vacancies. Because while none of the boards that testified on Tuesday had issues in terms of quorum, we did hear from someone today who was talking about, I think with the Board of Dentistry, that they've had some issues. And when you don't have quorum, you can't approve the applications, and then they don't have delegated authority, the whole nine. So I'm curious how those conversations are going with the Mayor's Office of Talent and appointments?
So we are having internal conversations of what that may look like, because that would mean that we would have to make that change as well to the HORA. So with that, I have not fully read the document yet, so I cannot really describe all of the changes that would be in that. I would say that, of course, our first hope is that an individual would reside in the District of Columbia, because that would be so important. At a minimum, they would have to have full engagement in employment. I would think there has to be that interest,
of course,
in the district and our district residents, and making decisions on standards of care and that type of thing. So I can let you know where we are with that conversation.
Well, speaking of the HORA, what's the timeline?
So I will say-
estimations.
Yes. Well, I've had it for less than 2 weeks, so if you can give me at least till the end of this month, that would be helpful.
Okay. We're just trying
It's
to
a pretty thick document.
I
It's not
saw
a
the
200-page
binder
piece.
that you had that one day, and I was like, oh gosh.
This looks similar to it as well.
Okay, great. I think we're all just going to hold hands and get through it together.
Yes.
But I was like, yeah, I do feel like that's in our future.
Writing notes here, end of the month.
So exciting. Okay. In FY22, we had a much higher rates of abandoned applications for behavioral health licenses than perhaps in other categories. 54 graduate social workers, 34 independent clinical social workers, 32 graduate professional counselors, 49 professional counselors. Why do you think that this rate is so much higher in the behavioral health categories than for other licenses?
So I am not aware of the exact number. I know that we recently did address very old applications before we deemed them as truly abandoned. We did send out an email to all individuals to give them another opportunity if they wanted to add to their application. These were all individuals where their applications were incomplete. I will say that during COVID, there were a number of people that did come here to work during that time. And if you recall, there was a period of time that individuals, as long as they were licensed in another state, did not have to submit an application.
Right.
So I don't know if that's some of them that started an application, and then when that went into effect, just did not follow up. I cannot really say what their position was, but we did reach out to all.
Okay. One of the things that I asked some of the board chairs, and they didn't necessarily know the specifics. I was like, okay, I'll bring it up with DC Health on Thursday, is around DC Health or HRLA more specifically, collecting and publishing some of the data that you all are receiving about the demographic information of the people who have been licensed. So by race, by ethnicity, gender, practice setting, right? Like for social worker, are you at a school, are you at a hospital, are you whatnot, et cetera. I don't want to put this as a reporting requirement because I know you got a lot of reporting requirements already. However, I do find that this would be very valuable information as we talk about healthcare workforce in general, is to truly understand what does the workforce look like in the district beyond the chart I think that you all had on your slide presentation here. Is that something that we have the capacity to do with the information that we have?
Yes. So what I will say that pre-COVID, we made a concerted effort to publish the workforce survey for medicine. I will say I don't recall us publishing a workforce survey for nursing. But what I will say that what has happened within the recent last 6 months or so, we have made sure that we have a workforce survey for at least 70 of our professions.
Okay.
So we will be, once we go through that renewal, it happens at the time of renewal. Once we go through the renewal process, then we will be able to collect the data and to analyze the data and then publish. So we will make sure that that is a priority.
The one area that is of particular interest that I think cuts across a variety of committees is social work, psychology, and professional counseling.
Mm-hmm.
Social work in particular, because that's not just health, that's education, that's housing. And I think that will help sort of inform some of the decisions that we're making, and also an understanding from a salary perspective, because we've gotten into this a little bit, right? Like if I have NLI CSW, do I go to a school where I can make 68 and then I could be a supervisor, they pay for my professional development, blah, 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 blah. Or do I go make 50 and be a caseworker at one of our CBOs to help for housing? We just need to have a better understanding of the landscape. Saying all that, everybody keeps talking about this healthcare workforce task force, and yet I don't see a report from said healthcare workforce task force.
Yes,
Yeah,
yes.
okay.
So it's
When's that come
it's the
in?
Mayor's Healthcare Workforce Task Force. And I actually moved it to the next level above me for review to my senior leadership to review before we would then send it to the mayor.
Who's that, Wayne?
Yes.
Okay, great. So
Yes.
I just want to know who I have to follow up with.
Yes,
I
I just sent it. I just sent it. So, give him
okay,
a
you just
minute.
sent it, so I'm gonna give him a minute. Okay, great.
And I did ask if he and I could discuss it next week. So I just sent it.
Okay, great. I have a list.
Okay.
I literally went to the CA's hearing just to give him my list of reports that I keep hearing about that everybody says is with him, but nobody has seen. And he was like, oh, come on, Councilmember, and so we're just work through it.
Okay.
But I'm gonna give, oh, yes. Oh, okay, great. Councilmember Gray is still here. I'm over my time. Councilmember Gray? You're on mute, Mr. Gray. There you go.
Wait a minute. Okay.
Yep, we can hear you. Go ahead.
Okay, thank you. We found out some people when we're looking at people's applications and credentials and that. Now we found that some people were submitting false educational credentials for medical licensing. Are you aware of that, Dr. Lewis?
I am not aware of medical license that were false. I am aware that we were able to identify, as I made reference earlier to Operation Nightingale, before that became public in January, we were able to identify a few nursing applications that we could not approve because of concerns with the education. I'll leave it at that.
I see. Okay. Thank you, Dr. Lewis. We found out that there were some reports that was taking months, that people were taking months to get licenses in the District of Columbia. Do you know anything about that?
Well, I will say that I have personally reviewed with one of the executive director for one of the boards. Someone asked me about an individual's application, and it had been maybe 6 or 7 months. When I went back to the office and reviewed, and the executive director looked into it, it turned out that that particular individual had to fulfill some course requirements because of a charge that they had. But that's not something that we can tell anyone other than the applicant. We can only have that discussion with the applicant. We cannot have that discussion with the facility or the provider, that the reason is taking the person that you're trying to bring on board 6 or 7 months to get through the licensure process is because they may have a positive criminal background check and they need to fulfill all the requirements for that. So with that, there are some cases where, yes, it has taken several months, but it's not because of the fact that, we have been negligent. We have really put forth a lot of effort and trying to make sure that we turn around these applications. And I'm very thankful to the council for providing to us additional health licensing specialists. It has really made a major difference. We brought on additional people in November, and about 5 or 6 or so. And it's really been remarkable. We've added, of course, a large number of them to the larger boards, of course, because that is where we identified the need. But, I appreciate that support.
Okay, Dr. Lewis, we appreciate that as well. And thank you for working with us. let me talk just briefly, I guess, at this disease prevention. Disease prevention, cancer, and unintentional death were the leading causes of death in the District of Columbia. Was that true for African Americans in a substantial part, Dr. Lewis?
Say that again. Is it true that African Americans are what again?
Yeah. Disease
Unintentional
prevention.
deaths?
Yeah, we're talking about
Yes, that is our now number 3 cause of deaths for 2021. I can ask Dr. Farley if he wants to come forward to address that.
Okay.
Dr.
Yeah,
Farley is the Senior Deputy Director for our Community Health Administration. And if I may, Councilmember Gray, when you asked me about the length of time it takes months, I shared with you my experience in looking at an application. One of the other things that we have to keep in mind too is testing. If an individual has submitted the application, but they have not, they're waiting to take the test. And I think pharmacy is one good example where it may be months while they're waiting to take their test. Then the application is going to go on file. So it's going to look as if it's a long time that we're trying to process their application, but it's not because of that. They have to pass, for example, their national test, and then they have to take, for example, the jurisprudence test. So there's a number of factors that we need to think about. And once again, it depends on the profession. Okay, let me turn to Dr. Farley to see if he can address, again, the 3rd leading cause of death, and that's for 2021.
Okay, thank you, Dr. Lewis.
I'm sorry, council member, I want to make sure I'm answering the right question. So can you repeat the question?
Yeah, we were talking about disease prevention. Cancer and unintentional death were the leading causes of death in the District of Columbia. Were you aware of that?
Yes, so the number 1 cause of death in the District of Columbia is heart disease. The number 2 is cancer. And the number 3, depending which year you're looking at, is either unintentional injuries or COVID.
Right, okay.
And that's true, you know, for the overall population. That's true for African Americans specifically.
I see, okay. Thank you very much. Do we have any additional information on your efforts to address smoking, for example, which we know is a leading cause of death with people as well, especially with African Americans? Are you aware of that, Dr. Farley?
Yeah, so we do have a tobacco prevention program that does things like messages in the mass media about smoking prevention. We also work with healthcare providers across the district to screen people for smoking. And if they acknowledge smoking, most of them want to quit. And then they refer them to DC Quit Now, which provides a variety of services to help them quit. So we try to make that as seamless a connection as possible when somebody acknowledges smoking.
Has that
and if I may add, with the DC Quit Now, what's really nice about that particular program, it does provide access if for some reason you want to talk with someone. There is that hotline number that you can call and get some additional support. So that is one nice program that DC Health does support.
Okay, thank you, Dr. Lewis, and we appreciate that. And we'll look forward to following up with you and your colleagues to be able to make that opportunity available to folks. So thank you so much on that.
Thank you. Councilmember Gray, do you have other questions?
I'm done, Madam Chair.
Oh, okay. All right. Thank you for joining us. And if you have other, I'm going to stay on the clock because I think that there'll be some other folks joining. So if you have some other questions, just let us know. One other follow-up report related question. So the council amended the HORA in July of 22 to create a review process for health professionals who had prior criminal conviction related to their profession. The legislation required the mayor to submit an annual report to the council regarding the implementation of that bill, the first of which was due on January 1st. When will we have that report?
I'll have to get back to you on that report.
Okay. We will add that to the list. We'll go over the list of
I hope
follow-ups.
that list isn't too long.
We'll see where we go.
I'm
Your
trying
agency
to-
is large, right? That's the same
Yeah.
conversation I had with healthcare finance. Let's
Yeah.
see where things go as the agency is.
So Aisha
Aisha.
Nixon is going to come forward and add some comments to that, please. Thank you.
Good afternoon.
Good afternoon.
Councilwoman Henderson. In relations to the report regarding the CBC, so that was passed in November of 2022. So we are trying to accumulate the information to have that information for FY24. So we're going to take FY23 to gather that data.
Okay.
In order to provide that report out.
So we should expect this in October?
Yes, ma'am.
Okay. And for all the people who are listening out there, yes, I know what the law says, but we're also having a conversation about the reality of the situation. If we pass the bill in November, they're gonna need some time. There we go. That's for the Twitter trolls out there. Okay. Let's go back to substance abuse and opioids. So my understanding is that DC Health is the lead agency under Live Long DC to explore the feasibility of a 24/7 harm reduction center. I have asked this question, Director Turnage, and I've asked this question of Dr. Vazran, and I've gotten two very different answers. So now I'm going to ask you, what is DC's Health current position on the feasibility of such a center in the district?
I'll have to get back to you on that. And I'm going to work very closely with my sister agency.
That's fair. This is going to come up, right? So obviously, you know, and when I talked to Dr. Bazaran about this, I think we both said, we're going to go to New York to see what's going on in New York.
Yes.
Because I've never been, she's never been, she's never seen one. We need to see, but also recognizing if we're all going to be honest about the situation in terms of our political environment in the nation's capital, this is something that requires some research and some thought. And I acknowledge though, right, we have an opioid problem here in the district. It's very different than West Virginia, but it's still a situation that is killing people here. And so we need to think about strategies in terms of how we reduce the number of deaths and get more people into treatment. So I look forward to, go ahead.
Yes, and I will say that actually internally within DC Health, we were having conversation about it yesterday, actually. So it is on our front burner, if you will. And we are very concerned about our district residents. We know that our population is a little different than other states.
Right.
We have an older population.
Older,
and,
Black, male.
Yes. And we're still working through trying to further explore some of the things that we talked about, even looking at our needle exchange, which of course we have that, looking at the population that's, you know, that utilizes that needle exchange program. So I want you to know that it is on our front burner.
Okay. Which agency is in charge of updating the website for Live Long DC? There are several data sources that are out of date and broken links.
So
who's on first? Who's it?
So of course, I would like to work very closely with our sister agency, Department of Behavioral Health.
Okay.
And I'll reach out to them.
Okay. And I mean, I think I've definitely said this to Patrick. I've said this to all the agencies. I'm so glad that Octo is finally getting around to updating everybody's websites. Y'all's website, you do a lot of work. And I want us to be able to find that. I want it to be able to be not just a depository for random reports, but a website where people can actually go to get actual information to help them in terms of public health. The Live Long DC website can be a very valuable resource, but if all the data is outdated, somebody just needs to take responsibility for that work.
Okay.
On the website, similarly, but slightly different on smoking, you were talking a little bit about smoking cessation with Councilmember Gray. I specifically want to ask about flavored tobacco though, and the new flavored tobacco ban. DC Health plays a role in this by processing the applications for exempted businesses like hookah bars.
Yes.
But there was a situation with the application. And so I'm curious, how many businesses have applied for and received these exemptions thus far?
I can't give you the exact number, but it's small. It's maybe 5.
Okay. Knowing what I know, even just about 9th Street, Northwest, going towards U Street, that number is, that tells me there are a lot of businesses who are out of compliance with the law. So whose responsibility is it to provide education to these small businesses that this is, one, the law around flavored tobacco, and 2, here's the process for your specialized business that can receive an exemption to be able to have one?
I'm not sure, the tobacco control program approves exemptions, but as far as enforcement of those people that are outside the law, that's not our responsibility. So
who enforces?
So what I will say that
Your mic's
there are a number of persons involved in this. I will say that when our food program goes out in the evenings, periodically, there is a time when we go out to see if people are doing smoking in where they should or should not. We also look at whether or not they're using hookah or the flavored tobacco. With that, we do notices of infraction. So a lot of times it's been more of complaint based. I have not received any, I'm not aware that Health Regulation and Licensing Administration has received any complaints of recent.
Okay. So then let me I have some questions on facility licensing, so I'm going to jump to that specifically in terms of the food piece because, oh, hold on, let me read. I gotta find my number here.
Arian.
Okay, so
I will ask.
so this is, I guess my overall question is around enforcement now and collaboration with, what do they call themselves? No, ABRA.
Oh, ABRA?
But they have a new name because of cannabis. But you know who I'm talking about. Fred Musali and his team. So they are responsible for the inspections and enforcement piece as it pertains to, are you following the rules and regulations for your liquor license?
Yes.
You all do the food portion?
We do the food portion, and I'm going to have Erin Gibson, who is the Senior Deputy Director for Health Regulation and Licensing Administration, explain to you the process that they go through in the evening.
Okay. My central question is there collaboration that's happening from the inspector standpoint?
Yes.
Okay.
Yes. So in those type of situations, we typically do a joint investigation with ABRA as well as DLCP. So if there's an issue like that, we do joint investigations with them. If needed, we will also call MPDN.
Okay. So DC Health's Division of Food currently licenses a roughly 6,500 food businesses and facilities. This is based on the data that you all provided. Most of these businesses are supposed to be inspected at least once annually, but HRLA only conducted 2,300 routine inspections in FY22. So what happened here?
So yes, so due to follow-ups, complaints and things of that nature, sometimes we go by a risk-based inspection. Let me back up a little bit. So depending on what they do, so for a hospital, for example, they can be inspected 3 to 5 times a year, but a gas station with only prepackaged foods, that's a really low risk. So we may not inspect that. We may inspect that every other year, simply because of staffing and how many facilities we have. Now for the inspection, I believe you're asking about the actual inspection process.
Yes, sir.
Yes, so we do it by risk-based inspection in order to be licensed. And I want to point out that we don't actually issue the license. That's issued on our behalf by DLCP, but our role in it is we do the plan review. Once they are built out and inspected by DLCP and DOB, then we come back and we do the pre-operational inspection, and they take that pre-operational inspection and then can get a business license.
Okay, so when you say risk-based inspections, yes, there's a difference between a gas station and a sit-down restaurant.
Yes.
Of the sit-down restaurants, how often are they supposed to be inspected?
It depends on their risk. So if they are—
Wait, what do you mean? If you're serving me food, you risk, right?
Yes,
Whether it's sushi or a hamburger.
So it's always a risk. There is a risk. But what we take into account is the population you serve. So a hospital or assisted living facility, they are serving an immunocompromised population. So that's a higher risk. A place that's sushi with raw product, that's a higher risk.
Yep.
But if you're talking about a place that is, they're just flash frying food and they're not reheating and doing a lot of that, that's not a higher risk. So it's a risk, but compared to.
You know, I don't want to bring up the Popeyes, but I'm gonna bring up the Popeyes.
Now, that's a good point. So if you have a bad history, we raise the risk level, which means you'll get inspected more and vice versa. So if you've been compliant throughout our inspections over the last few years, we can also lower the risk level. It's a way of managing our workload because it would be impossible to get to.
How many inspectors do you have?
16. We're not, right now, we are advertising.
How many vacancies do you have?
5.
Is 21 sufficient for every hospital, school, restaurant, gas station, whoever else? This is me asking you, do you need more people?
I would say yes, we're always in need of additional sanitarians. It is a specialty. We have a couple of plans to see how we can incentivize people to become sanitarians. But yes, there would be an incentivize. When you think of the fact that in order to follow the risk base, as Erin explained, certain risk base means that you would do 3 on-sites per year versus 1 on-site per year. And we also have to, those same sanitarians do respond to alleged foodborne illnesses. So they have to go on site and do that inspection of that restaurant where someone may say that they had whatever they might have eaten and then they had symptoms. The sanitarians actually go on site and do those. And then we have also the same sanitarians go on site to do complaint investigations. So let's say you were out eating and you found hair on your food or a little critter running across the way, they would then go out and do that complaint investigation. So I will say that team is very busy all the time. And Erin, you may want to explain how they work weekends and evenings.
Yes, so recently, within the last 1.5 to 2 years, we have expanded our time. So now we work until 10 o'clock at night, and we also work on Saturdays so that we can hit some of those establishments that may open later or may open only on the weekends.
Are your sanitarians hourly wage? I hope they're salary.
Salary.
Okay.
Yes.
What's your starting salary? So I'm out here trying to get people jobs. I just like to know.
I can get you the grades. So we have grades 9 through grades 12 sanitarians. I don't know.
Okay. Okay.
Yes.
All right. Like I would just want you to know. Okay, so I'm originally from Brooklyn, and y'all know that in Brooklyn, right? They put the letter grade on the outside. It was very controversial when they did that. However, it increases the level of, number one, the facility and the business paying attention to what is going on. And number two, for consumer awareness. I'm getting a little heartburn because I'm hearing you talk about 16 inspectors across the 6,500 businesses. I don't think everybody you're supposed to hit every year is being hit.
I'm going to say that we do our best. And no, all of them are not inspected, if I am to be honest, but we do our best to go to as many of our restaurants. And we want to make sure that, especially those that are high risk, that we make sure that we do pay attention to those. We are very responsive to any of our district residents that may have a concern and report a complaint to us. As it pertains to sanitarians, that's one of our hardest to fill positions. We talk about healthcare workers, sanitarians is also.
But I think about it, I like, when we get to the budget season, there's going to be some positions that, the executive is going to say, well, I need to offer hiring incentives of X amount of dollars. Some of them are going to be 6 figures or higher, not 6 figures. That's wrong. 5 or higher. This to me is a public health. I need a sanitarian.
Yes,
We
yes.
need sanitarians as a city. And so when we get this list of, where folks say, oh, the frontline positions that need folks, this is a frontline position, in my opinion, that needs people. And so I want to make sure that this is a priority. I'm gonna let it go for today.
Well,
I want to follow up. What I want in terms of information is a breakout of the risks facilities. How many facilities are high risk?
Okay.
How many are
Yes.
whatever? And then how you all truly determine that. And then when we get to budget section, we'll have a larger conversation about how many inspectors that you need in order to do this work. And I don't want you to feel like I'm giving you a hard time. I did the exact same thing with DOE on inspectors around mold. We had none. Yes, the whole city. We had none. We had no fine structure on that as well. That also goes into the social determinants of health in all of those pieces.
Yeah.
So we'll come
But
back to that.
if I may, I do want you to know, as well as our district residents, that during all of COVID, our sanitarians were out there. When the restaurants were open, they were out there doing the inspections of the restaurants to make sure that they were following proper infection control when things began to open up. So even though we may not have enough, they were out there. So I do want everyone to know that, as well, of course, as the nurses were in our healthcare facilities.
Yeah.
But I would appreciate whatever you may want to.
Got it. Hold on, let me, Ash. Okay, all right, we're gonna keep going until somebody joins us. Okay, shared kitchen facilities have become an important part. Don't go anywhere, sorry. Sorry. Shared kitchen facilities have become an important part of enabling small food businesses to be able to grow. But out of the 28 applications for new shared kitchens in FY22, only 8 were approved. Why is the approval rate so low? And I'm sure, I'm not saying it's for bad reason. I'm just curious.
So I would have to get back to you on that.
Okay. All right. DC Health conducted 2 inspections of DC Jail's culinary facilities in FY22. I just talked to Director Foss, so this is me bringing it up. You all issued 12 citations. I guess this goes to the question that we were talking about before in terms of, you said, with follow-up pieces. How do you ensure that these citations are addressed? And also, is the DC Jail considered one of your high-risk places?
So we do not technically have licensure authority over DC Jail as far as the inspection of what happens there. How we're in that particular space of DC Jail to do the environmental inspections with a set required frequency per year is through the Jail Improvement Act. And with that part of the environmental inspection, yes, we do inspect the kitchen. I will say that if we have any major concerns of the kitchen during that inspection, a revisit of that inspection of that kitchen is done before we actually leave the premises, meaning during that 2-week period or 3-week period.
Okay.
So
Director Faust asked me to come over for, what do you say, dinner, so I have a hot meal. I want to know.
Oh, yes, you mean at the jail?
Yes, before I go.
Yeah.
Y'all checked
Yeah.
it late. No, I'm kidding. So there is currently legislation before the council that has been referred to the committee to address some of the health and safety concerns raised by current and former inmates about the food served at the jail. So this is why I'm asking some of the questions, right? We've getting complaints. Some of it is on quality. That's not y'all.
Yes.
But in terms of the safety piece, I think that is you all.
Yes.
DC Health completes annual quality reports for each of the hospitals. Are these reports publicly available?
No, the hospital inspection reports, if that's what you're referring to.
Yeah.
That are conducted by the Office of Health Facilities, Healthcare Facilities Division, they are not currently online.
Okay.
But if you were to request a report via FOIA, yes. Once we receive the the statement of deficiency to
Mhm.
the facility, then it is available to anyone that may request it. What I always advise, we may have a statement of deficiency. Why don't you wait until we have the plan of correction that is approved, and then ask for the complete document if one wants to do so through FOIA or whatever.
Okay. If an inspector sees mold in a facility, either healthcare, food facility, what actions does the inspector take? Where do you refer it?
So we will refer it to DOEE, Department of the Environment, because they do have that division there.
Okay.
Yes, of course, we would take certain actions. Depending on where it is that we're talking about, it may be a notice of infraction, of course, the deficiency stated.
Okay.
And notice of infraction. If we're talking about people in that immediate area, such as a healthcare facility, then that would mean that that particular facility would have to remedy that. They may have to bring an outside person to come in.
Okay. Do you all fine?
Yes, we have local fines, notices of infractions. And then there are situations where, depending on the type of healthcare facility and what type of inspection it is, it could be a licensure inspection, it could be a federal certification, recertification and licensure inspection. It could be in a complaint or an incident. A complaint inspection would be if a family member or the patient themselves or the resident calls into us a concern, that's a complaint or an advocate. An incident would be self-reported by the facility. Irregardless, when we go in, we're looking at compliance with the regulations that are for that particular provider type.
Okay. And I'm raising this because now you're saying, so you guys have been seeing, if you saw mold in a facility, you referred it to DOE. DOE didn't have a fine structure until like a couple of months ago, which meant that we're going several years here. And this is not on you. This is on the government as a whole. I don't feel like we've been necessarily taking this seriously when we know that it impacts environment. Can you describe a little bit in terms of your oversight of the Psychiatric Institute of Washington? Are they treated as a hospital when
They're treated as a hospital. They are licensed as a specialty hospital.
Okay.
Specialty hospital because they do not have an emergency.
Okay. And so you all are only looking from a facility standpoint, not necessarily in terms of program quality.
So with Psychiatric Institute, we conduct two different types of surveys, if you will, a licensure survey. Of course, part of that would be the different modalities that they should provide for the patients, depending on whatever their psychiatric need is. So it's more than just environment. We're looking at healthcare as well. There is also a special psychiatric survey that is done typically by our federal partners. That's really true program. But with that, when we're there, we're looking at the overall care of that patient and whether or not they're not only meeting their medical needs, but their psychiatric needs as well, that the modalities are offered.
Can you all add, are the discharge needs being met as well? And I brought this up with Dr. Bazaran. The neighbors next to PWI have been constant on this in terms of people being discharged at all hours of the night, people being discharged without proper clothing, people being discharged, like all of these different things for this particular special population. And it's surprising to me when you say like, oh, we treat them as a hospital, because I know from the hospitals, they can't discharge certain patients if they don't have anywhere safe for them to discharge, right? They have, some of these hospitals have patients there for over 300 days. So the idea that PIW, now I recognize there's a certain level of choice in terms of this type of facility, and a certain level of free will if they're not there under the involuntary FD12.
Right.
Okay. But still, I feel like discharge is part of care. Are we doing that part correctly? And so I just ask that you all look at that as well. And it's the same with DBH, but I think that this has come up. Let's see, what is March? I've been chair of this committee for approximately 2 months. Every meeting that I have in terms of behavioral health, somebody's bringing up PIW. And so somebody, and I recognize that it is not a government institution. We contract for beds, but from an oversight standpoint, we got to get a handle of what's going on from an operations standpoint. And I know they've had some leadership changes there, but if you all are licensing them as a hospital, then we need to treat them as a hospital from a quality standpoint as well.
Yes, point well taken. And I will say that Dr. Bazaran and I both went to PIW to meet with the new leadership there and to have conversation about their capacity and the different programs that they were putting into place. So yes, we will continue. We have spent quite a bit of time at PIW. We will continue it. And I know Ms. Cooper, who is the Associate Director for the Office of Health Facilities, has had her team out there. In fact, I think if they're not there now, they were there last week.
Okay. Can we talk a little bit about the certificate of need process while we're,
yes,
I promise I'll get to some lighter stuff, but we're in the heavy at the moment.
Yeah. And I'm going to bring up Terry Thompson, who's the director over the Safe Health Plan.
That was you. I can tell with the mask. It's
Yes.
nice to see you in person. Okay, so of the 12 hospitals in the district, DC Health reports that 7 did not meet their required level of uncompensated care in 2021. And 3 others have not yet reported on their level of uncompensated care. What is the impact on district residents when hospitals don't comply with this requirement?
So it depends on the reason for them not meeting full compliance. So it's 3% of their operating costs is what sets the floor for uncompensated care.
Mm-hmm.
So I don't know that I have an answer for who's not getting care or if there are individuals that aren't receiving care.
So what happens when people don't meet the requirement?
So they have to give us a compliance plan.
Okay.
So they have to make up the amount that they're short and explain how going forward they're going to meet compliance.
Okay. So for the ones from 2021, have you received all the necessary?
So we just got the reporting. So we lagged by a year.
Okay.
So we just got the reporting and we are now, there were 3 facilities that we were waiting on reports. And we are collecting those and we are working with the providers to do compliance plans.
Okay. I understand you all are in the process of transitioning the CON process to an online application.
Yes.
And you say it's supposed to be done by the end of FY23. How's it going? Are we on track?
So we are on track for it being substantially online, right? So right now we have the front end portions of the application process are actual online fill in the blank questions. And then when you get to the certificate of need, there's an application that you pull down, complete in an Excel spreadsheet and upload. Those questions are being converted to online questions.
Okay.
And so that portion should be finished by the end of the fiscal year.
Okay. So I guess at this particular stage in the game, there is no component of the process that is paper. There's just not one platform that you can use. Is that a better way of, is that when people say like, it's online, but you were telling me you download an Excel, you fill out the information and then you upload it back. To me, that's a digital process. It doesn't require you printing something and scanning or sending it via snail mail.
So I guess it all translates differently because I would say as long as you're still filling out an Excel, that while it's electronic, it's not online.
Got
fill
it.
in the blank.
Okay. Those are for the public, Terry and I met. And so we talked about some of the CON processes and telehealth and some of the issues there. So I don't have any other further questions on that front.
Great.
Let's go to maternal health. Favorite area of mine. In FY22, DC Health provided 4 grants through the preterm birth reduction initiative to identify women at risk for preterm birth and connect them with specialized care and comprehensive services. What were the results of this program, and does DC Health plan to continue it in future years?
The program initially was a pilot to see, can they screen women? Can they connect people to care? And the conclusion was, yes, this was a valuable program. So yes, we do plan to continue that. 4 grantees will continue to be funded. And the focus will be on, again, screening women early on to determine if they're at risk, addressing those risk factors, and then directing them into specialized services if they need those.
Okay. So what do you determine as success? Is that you've identified Christina for preterm birth. If I don't actually, if I enroll in the program and follow through, and then I actually go into labor at term, we're considering that success?
Yes, that's what we consider success.
Okay. So from a numbers perspective, do you have any data on how that pilot operated out?
Not that I can report now. I can get back to you if there's anything we have, but the numbers would be small. It's going to be off in the future when we have more numbers.
Oh, I see. Oh, because there's 4 grantees. So what was the size? What was the end size?
Let's see. Not sure if I have the number, but let me see.
All right. Our first hearing together, we're all going to learn about how we do.
Yeah. I'm sorry, I don't have the numbers with me here, but I can get back to you with them.
Okay, we'll add that to our follow-up list, because I just think it's important if we have this data to be able to prove success and justify the funding continuing in the future. But hearing you say that we're going to continue the funding, so I'll just look for that in the budget submission. At the healthcare finance performance oversight hearing, we heard from some public witnesses who advocated for evidence-based home visiting programs to be covered by Medicaid, as they are in other states. And obviously during the hearing today, we heard from a number of witnesses about the home visiting program and healthy steps. We use healthy a lot in the names of our programs. What's DC's health position on transitioning this program from a grant to being reimbursable through Medicaid?
Yeah, for it to be reimbursable under Medicaid, DHCF would obviously have to be involved.
I know, but are you guys advocating for that?
I would say, the home visiting programs are evidence-based. There's clearly a value to them. And I think if there's a way to tap into additional funding through a federal match, there's an advantage to that.
Okay. All right. So DC Health said you all are expected to release the perinatal health and infant mortality report 2019, 2020. But it's based on 2017, 2018 supplemental data. In your responses to the committee, you said we would have this report in February of 23. Y'all know what today's date is.
Yes, that report is posted.
Oh, great. Yes. Somebody, Carl, can you send us a link? Great. How can we, though, get more timely data? Because it's 2023 and we're looking at a report based on 2017, 2018 data. Like we've made several policy.
I believe it's up to 2020. The one that's.
Okay. Still 3 years behind. I was just sort of noting, we made several policy changes in the district related to maternal health, and I recognize that data lags behind and years lag behind, but our reporting being 3 years after the fact, how can we do better? Can we do better?
Good afternoon. I'm Fern Johnson Clark. I'm the Senior Deputy Director for the Center for Policy Planning and Evaluation, in which the Vital Records Office is under my purview.
Okay.
So there will be a data lag. We do have a contract with our federal partners at the National Center for Health Statistics, which is a part of the CDC. So we have closed the birth and death file, there is a schedule in which the federal government tells us to close, and we reconcile the files with them. So we are now in the process of analyzing the 2021 data, as we have not yet closed the 2022 data, which will be upcoming. So there is a data lag in terms of when we are told to close the files, and this is nationally. And then when we reconcile with our national partners and they say our data are now approved for analyzing. So that's the data.
So is 3 years normal?
So it's not, I think we released the 2020, but 2021 is being in the process of analyzing right now. So there is a lag, but that does not mean that you can't get more timely data, but not in a report format. So we have the capacity to analyze the data as we, I would say in a preliminary way, but not to share for public consumption until that reconciliation has been completed.
Okay. And to what extent, when you all have this data and are working on your report, are you sharing information with OCME and their maternal
Correct.
mortality review committee?
Yes, correct. So they'll give us a list.
Okay.
And then we have a team member who's assigned to work with them. And then we provide the data in the various format that they're requesting from us.
Okay.
So that's really timely. That's real time.
Okay. Can you guys hold on 1 second? Sorry. We're trying to manage the Zoom to see if any of my colleagues want to, I just want to make sure that I'm not missing anybody because we're not on the clock. Okay. All right, I have a few more questions that are maternal health related, but I don't think they're specifically rated on policy planning and data. Okay.
Thank you.
Thank you. So on the Healthy Start program.
As you can tell, we're a good team here at DC.
We were a
Health.
good team.
Yes.
Let me tell you, people were asked, why do you bring the government in person? And it's for this very reason.
Yeah.
Your agency is too large for you to do this alone. So if everybody can, and also you have an excellent team, give them time to shine. Okay. So the Healthy Start program served 533 expecting and new parents in FY22. Is there a wait list to participate in the program?
I don't know if there's a wait list in participating in the program, that there may be people who deserve to be enrolled who haven't been enrolled.
Okay. So how do we reconcile that? I'm just trying to determine. So, right, obviously we're getting people who are saying we need to expand the program. How many, by how much? If we expanded it, will we still be able to find people to fill those slots? You know what I'm saying? So I'm just trying to understand from an enrollment standpoint, clearly there are other eligible people out there who we can reach, but expanding the grant by this much will allow us to serve X, which would meet X need. Do we have that type of analysis?
I don't think we have specifically for Healthy Start. I can say that there was a needs assessment done for home visiting in general.
Okay.
That estimated that there were around 3,500 high need families out there. And the number of families that are reached through these home visiting programs is a lot smaller than that. So the need is well exceeds what we're reaching now. Okay.
I'm going to come back to asking a little bit about that in terms of WIC, not home visiting, but how are we meeting the need in terms of eligible people? But I want to ask, DC Health is developing a licensing process for certified professional midwives and doulas. When will this be complete?
Well, at this particular time, I believe that first we're trying to get the advisory group together.
Okay.
What I'm very happy about, the regulations were drafted. So the Board of Medicine is in the process of reviewing that. So we are making progress towards the end of licensing doulas, but we have to get the regulations.
Yeah. So like DC Healthcare Finance has done their part in terms of the expansion piece, and we are seeing people who are signing up. But I think the thought is that once DC Health finishes on their side, we will see a further increased number of people who decide to sign up to provide their services through Medicaid. And so do you have an estimated timeline? What are we aiming for?
So we're hoping to complete all of this, of course, this year. But right now, they can provide the services and get reimbursed through healthcare finance. So not having the license is not going to deter them from actually being in practice and supporting the moms.
Okay. And something similar that I asked on Tuesday, which probably was an unfair question to Dr. Anderson and Ms.
Meady Barginelli,
about whether or not there should be a separate board. It was loaded. I admit that. However, they were there. So I'm going to ask you that question. Should there be a separate board that deals with midwifery and doulas versus all of, part of them going through Board of Medicine and part of them going through Board of Nursing? Obviously, I think that works well for what we're doing right now. But I don't know. Have we?
So I think that the structure that we have in place now will work. Right now, under nursing, the midwives who are nurses with advanced training and education fall under the Board of Nursing. The doulas and the CPMs will then fall under the Board of Medicine. What is really good is that those two boards do communicate with each other.
Yeah.
So I think that that's the very important piece of all of this. So right now it is working.
Okay. When will DC Health publish its DC Calling All Sectors Initiative report on addressing housing insecurity during pregnancy?
So I will have Dr. Anita Arno, our Director of the Office of Health Equity.
Hello, good afternoon.
Good afternoon.
We have finished that report and it's going through its due diligence at this time. It has to be fully read through. The staff member who worked on it most closely recently departed. And so we've just got to just finish it out and then share it with, pass it up the chain, including Dr. Lewis and our communications team, et cetera.
Dr. Lewis, they have you reading a lot. Okay. I will probably ask you about that at budget just to kind of see where we are on that front.
I'll make sure I put everything on fast pace then.
Not necessarily. It's just I think some of these reports inform some of the work. Yeah. And if somebody worked on it, we want to, sort of see what it is and how we can act on it. But sort of related to maternal health, but a little bit more on food access. And, Dr. Farley, you just come sit and stay. I don't know why you acting like you can go back and forth. Just have a seat. Okay. So, one of the things, so I'm a very big proponent of food access. We have too many areas of the city that I feel like are food deserts in comparison to others. And then we have areas of the city that explode. 8th Street is a really good example of that. We went from having one grocery store and now I can go to the Giant, to the Whole Foods, to the Trader Joe's, and so on and so forth. And yet, Ward 5, Ward 7, and Ward 8 are these like impenetrable areas, but I don't understand. And I would keep pushing on it. I have these conversations with developers all the time, like, yeah, congratulations on your ribbon cutting of your new blah, blah, blah in Ward 3, but like, when are y'all going to do this in Ward 7? And we have made some progress, but one of the things that I'm concerned about is that some of these new grocery stores that we are opening in some of our lower income areas, east ends of the city, including Lidl and Aldi, don't accept WIC. And so how do we balance that out? Because if I'm a WIC recipient, I still can't do all my shopping in one spot, right? I could get my SNAP benefits, but I can't do WIC there. So how is DC Health working with DMPED as they are going through the process of recruiting stores to come to the district, to say, we need you to accept the full complement of the benefits that we're offering?
You know, first I should say that we have been in WIC working to have more access in those underserved areas, mainly through the small and medium-sized stores. And so we're up to now 52 sites that accept WIC across the district. I don't know the specifics of the negotiations with Lidl and Aldi. I'll be happy to check into that and get back to you on those.
Okay, but are you having these conversations? So DMPED has, let's just say, a large amount of money in terms of grocery store access for incentives. Are y'all at the table for these conversations, or are we doing this in silos?
We definitely have had conversations with DMPED, but even with that, my understanding, and you've talked to them probably some more than us, is that they have to coax some of these supermarkets to get into these areas. And so they can't always demand all the things that they want. We would certainly want them to offer WIC. And again, as to where they are, there were negotiations on those stores. I'd have to get back to you, but they're not always in a position to demand everything they want.
I understand that, I do. But in many cases, I feel like we can't be so desperate that we bring something to an area and then folks aren't even able to shop there because they don't accept this, or they don't accept that, or they don't accept the other. But we can continue to work on that. The WIC enrollment dropped during the transition period to eWIC benefits as people got used to the new debit cards, as well as were required to have in-person appointments. How are you all working to increase the enrollment, and what additional resources do you need to reach the population? I think I said earlier, maybe only 58% of eligible residents in the district are actually enrolled.
Yeah, so as you know, probably from the response we had in questions, enrollment went up during the pandemic. In part, that might have been sort of a false number because people were automatically re-enrolled. They didn't have to meet the requirements they did before, and so they may not have actually been participating even though they were officially enrolled. Mm-hmm. Once they had to come in to get a card, then enrollment dropped. But since that time, enrollment has been increasing. We have run a media campaign to encourage people to enroll in WIC and to talk about the benefits of the eWIC card. People really do appreciate that. I do expect that's going to continue to increase, and it's really just how do we continue to get the message out? So we've done that broad media campaign. In addition to that, we are doing data use agreements and data matching so that we can do direct outreach to people who are eligible but not enrolled. The first step is with TANF, but we're also in conversation with DHCF to similarly do a data match with Medicaid so that we can do direct outreach to people who are eligible but not enrolled.
1 second. Okay, so this came up a little bit in testimony, but what, if anything, are we doing in terms of transitioning individuals who are at the Howard site that has now closed to another site, making sure we don't lose those folks in that transition?
We did direct outreach to all those folks, and all of them were transitioned to another site by the end of September of 22.
Okay, so all of them were?
Yes.
What's the new, you added a new site after the Howard closure?
There are new sites being added. Most of the Howard clients transition to existing sites, but there are additional sites that are being opened.
Okay. Several of the Healthy Food Access Grant programs received an increase in funding in FY22 with ARPA dollars, but DC Health's responses show that most of these programs did not spend down their full amount of money. Why was there underspending?
I'm guessing that they just couldn't access as many clients as that they felt they needed. Certainly there's plenty of need for these programs. People need and want access to healthy food.
Definitely.
But it takes time when you have a big bump up in dollars to get that translated into programs on the ground.
But so what are we doing in terms of FY23? Because I said at the beginning, I don't like to give the federal money. I don't like to give them their money back. Once we have it, we need to spend it. So I want to make sure that we're spending it, especially since, lots of folks testifying, Produce Plus, all of these programs, Healthy Corners, Joyful Food Markets. Healthy Corners, especially talking about the work that they're doing. Are we recalibrating in terms of what we're doing in FY23 to make sure that the programs that can use more money are getting more money, and then the ones that aren't really working that well, that we're retooling?
It's as to the question of, are we spending the federal dollars so we don't give them back to the federal government? We do keep an eye on that, and we're going to try very hard to make sure that those are spent. But I think you had a second question is, we'll have a problem. Can we sustain it? That was one-time funding.
Right.
And so it's not necessarily going to be sustainable.
So at this time, we're not in a position where we can address fiscal year 24 funding at this time.
Oh yeah, no. I'm talking about 23.
Yes.
Right. Of the existing budget that we in, are we on track to spend our money, or do we need to think about reprogrammings now so we can meet our target?
Good afternoon. All of them spent we spent the federal funding first. So what happens is, if there's anything that's unspent, it comes back into the local coffers. We're not at a position yet in 23 where we have to do any redistribution yet. But the funding has remained equivalent to what was given to them in 22 for 23. So.
Okay. So, I mean, to your point, Dr. Farley, around like the sustainability piece, I guess this is something we have to think about for going forward, right? So DC Health used ARPA funds in 22 to add fresh produce to the commodity supplement food program boxes that were distributed to low-income seniors. I have to imagine that was probably a very popular addition to that program. Are we going to be able to continue that in the future, or are we going to have to think about something different? I think those are the things that we need to start thinking about, especially now, because, they're not going to extend this money. But one of the things I learned in grad school, like once you give people a benefit, it's really hard to roll it back. You've given them produce now. They're going to expect produce going forward.
So in 23, they're funded at the same levels.
Okay.
They're good in 23.
We will talk to you about 24 in like 4 weeks.
Yes.
Okay.
I think some of them have started to talk to you about it already.
All right. We're making some good progress here, everyone. Let me just check. Okay. I was just checking to see if any colleagues had joined. We'll keep going. Let's talk about school nurses. Oh, hold on. Let's stop. Do you need a break?
Oh, no, I'm good.
You sure?
I'm fine. Thank you.
But we've been going since
Do you need a
3. Yeah, we're going to take a 5-minute break.
All right. Thank you. Okay. Thank you.
Okay, and we are back. Thank you to everyone for your patience. All right, so let's talk about some school nurses and health centers. I'll start with one of the issues that was raised from the testimony today. In our contract with, in our grant with Children's, do we cover the stay programs in the nursing program?
Yes.
Okay, so I'm not sure if you're familiar with the background, but so Roosevelt Stay used to be at the same campus as Roosevelt. They split, but they haven't had coverage. And to be honest, I'm not entirely sure that Garnett Patterson site even has a health suite, but because it served as a swing space for several schools, including Duke Ellington for a couple of years, perhaps it does. So what's the status of what's happening there?
So this is my understanding, and then I may get back to you if there's any additional detail to fill in.
Okay.
And that is as Roosevelt and Roosevelt Stay were together in one building. Then the Stay students were moved to this other building, which is very close by. It may even be across the street, but that other building.
It's okay. Keep going.
And that other building does not currently have a health suite, not a permanent health suite.
Okay.
Those students can be served at the main Roosevelt campus now, but there is some distance to travel there. They are building a permanent health suite. And when they build a permanent health suite, then they are eligible to have a school nurse like any other school.
Okay. All right. So I guess that's more of a question for DCPS and DGS in terms of capital, because they have to build out the health suite for the Garnett Patterson site. I'm a little concerned that they didn't have one there, considering that site has been a swing space for several schools for several years, which means that they haven't had it. But okay. There's nothing that we can do in the intermediate, right? Like the health suite is the requirement.
Yes, for someone to be stationed there permanently. But again, the students can go to the main Roosevelt campus for services. And I don't know how long that distance is. I heard someone say it's across the street, but maybe that's
right. Like
not
if
true.
I get I don't know, some type of cut, we're talking about Roosevelt, which is in Ward 4, the Roosevelt campus. The new campus for Roosevelt Stay is in Ward 1. I can't just walk across the street. I actually have to get on a bus, a couple of trains, and do some walking. So I'll ask DCPS, they're here tomorrow. So I'll ask DCPS around what they're doing in the interim to help in terms of the first aid pieces there. But in the same regard, so, you guys are lucky because you are at this hearing and you didn't hear from all the charter schools who testified yesterday about their desires for the school nurse program. And one of the things that they have raised consistently in the hearing, but also in meetings with me, is that DC Health doesn't have a list of recommended products to purchase that would meet the requirements for the health suite. So if you want a specific, basically what they're telling me is, if DC Health wants a specific refrigerator, just tell us what the refrigerator is, as opposed to just saying refrigerator on your thing. We buy one and then it's not the right one. Can we update the list to just be more specific, to say like, here are a recommended list of things that would meet the requirements for the health suite?
I mean, we do have a list of what needs to be in place for health suite. I have seen it. That exists. It's a fairly long list. I'm not aware of there being problems where someone bought the wrong refrigerator. What I've heard of the delays of opening health suites is they simply didn't have the basic equipment. A nurse can't function if she doesn't have, a computer that's connected to the internet, a sink, an exam table, some pretty basic supplies. That's what I've heard about in the delays of a health suite being approved.
Okay. Well, then how about this? If we were to set up an introduction between you and Dr. Walker Davis, who's the executive director of the Public Charter School Board, can y'all have that conversation?
Absolutely.
Okay.
Sure.
So that I feel like this will help in terms of the silo pieces, because they testified before the committee of the whole to talk about all of their things. I talked to Chairman Mendelson and I'm telling him, hey, hold on, wait a minute, because the nurse program is through the health committee and DC Health. And perhaps everybody just needs to get in a room and have a conversation about what the issues are so we can kind of resolve them. Sure. Now, I know for some of the charter schools, some of their issues is they want the health suite to be able to also be used by the behavioral health clinician under the requirements of DBH. But I know that for both DBH and for you all, you say, no, you need separate spaces for privacy purposes, right? If the nurse is in the room, then somebody comes in, the clinician can't also be in there as well to serve students. So let's just follow up to get those conversations going, because I think that could perhaps alleviate a lot of the challenges that are being raised. So we can work on that. Dr. Lewis, though, you mentioned in your testimony that you were working with Children's in terms of a new proposal around what the school nurse program looks like going forward. I've had a conversation with Children's around that as well. I know you can't say anything about specifically FY24, but so I will ask this question around this new model that you all want to pursue on school nursing. Is this something that you are looking to pursue at the beginning of school year 23-24?
So what I would say, we are very sensitive to the workforce shortage as it pertains to nurses. And what we're looking at is how we can still have the proper services available, not only in addition to telehealth and other things that we have already put in place, but how we can expand and have additional persons placed in the health suite. So with that said, we are in conversation with our contractor or our grantor, if you will, and how we can maybe meet those needs with the right health professional.
Okay, but is this something are we aiming for the beginning of next school year?
We're trying our best, yes.
Okay.
Yes.
Because I think that in that, there probably has to be a change of some sort in the law. So I just want to make sure that we can make that happen. Because one of the larger complaints from schools, not just from charters, but from DCPS, is that the inconsistency, and I know it's all about the workforce challenges. I know that Children's has had to use staffing agencies to try to fill in gaps. But then schools will say, I don't know who's in the building that day, or the person who's in the building who was sent to us has actually never worked with children before. All of these different things. One of the other things that has been raised around the school nurse program is inconsistency in school leaders and the nurses having an understanding of what the nurses can and cannot do. And what I mean by that, this came up a number of times during the height of the pandemic, where schools wanted to, can you do more than paperwork? Can you administer a COVID test? Can you do more than administration of medication? Do you all publish and make available for school leaders, like what's in the guidelines? This is what your school nurse can do. Welcome to the school nurse program. This is what your school nurse can do.
So we have until now answered that in sort of on an ad hoc basis, but because of this sort of request, we are putting together a handbook that says exactly what the nurse does and what the role is. And we're very close to putting that out, probably by the end of this month.
Okay, great. Can you share a copy of that with the committee once
Sure.
you guys have that done? So that helps us in sort of alleviating some of the questions that have been raised. The school health services program performance improvement indicators were quite low for FY22, with only 1 in 5 students with asthma having an asthma plan, and 1 in 4 students who have received an oral health assessment. Do we anticipate that these numbers are going to improve in FY23?
You know, the asthma action plan is one that is we're definitely concerned about. It depends on a parent interacting with a provider, getting a copy of the plan, and then bringing that to school. And so while we've tried very hard to promote that, we still have those low numbers. And so as you've heard, we're trying to change that process by having the electronic asthma action plan. If we can get that in place, I'm hoping those numbers will increase in the next school year. It's not going to happen immediately. Still a difficult process. And the oral health program, likewise, probably increased numbers, but it's hard to bring that sort of to scale.
Is it because we don't do oral health screenings in schools?
Back up and say, what number exactly are you looking at there?
Well, so let's say if I look at even the school-based health centers utilizations of services, right? So we have school-based health centers at all of the high schools. Blue and Dunbar had 0 oral health visits. Anacostia had 66. Cardozo had the most of over 1,100. Roosevelt had 158. Coolidge didn't have any. And Woodson had 578. So I'm trying to understand how are we improving upon this, but also too, even beyond the school-based health centers, you know this, when a student is enrolling in school for the first time, you have to, along with your immunizations, you also have to do an oral health form.
Right.
And we're not seeing very high compliance numbers on the oral health form, even though people are doing the immunizations. I'm trying to get to the bottom of why that might be. Is it you can't make an appointment with a dental provider? Is it you don't have dental insurance because that's not covered? You know, have we sort of sussed this out?
Yeah, although those forms are required, there's no real enforcement of that. And if parents have difficulty getting an appointment for a dental provider or just don't do it, or do it and just don't bring in the form, there's not much we can do. And getting consent for some sort of oral health services in the school is also a problem. Getting a consent form back as a process can be a complicated process. So I suspect we're going to continue to have problems with oral health. The services are difficult to have availability anywhere, but I think we can continue to promote that. I think we're closer to making progress on the asthma side.
Okay. I think we need to continue to work on this. I mean, I wouldn't be pushing it so hard if didn't a kid die? Not in DC, but in the region from an infection. Tooth infection, right? Like I as the public health agency, we know these things are connected in the same way that I said, you know, with vision, right? We need kids to get vision screened because it connects to academic achievement. Same with oral health. It connects to that as well. DC Health did an excellent job last summer in terms of the increased promotion around childhood immunizations. Like, truly, kudos to your team in terms of the work that you all did, the rollouts of the school clinics, the information campaigns, and kudos to the schools too, right? They were making the calls, they were telling the families. I think we put the pressure on, and it wasn't to be punitive. It really was around public health. I think oral health needs the same type of attention, the same with vision, the same with hearing. All of this goes into the academic pieces, but it's also around health as well. And so maybe we could think about, as we gear up around when we do the work around immunizations in the summertime, we can also add in a component around oral vision and hearing.
Yeah, so the vision and hearing screening does take place. So that we're solid on. As far as oral health, let us work on a plan that we get to you.
Okay. Okay. I know it's hard. We don't have a lot of dentists. That came up earlier. And all of those pieces, but I think it's certainly important. Okay. Let's talk about the universal health certificate. Where are we on making this electronic?
Yeah, there's
what is this, doses?
Well, that's related, but not the same topic. So
okay.
Universal Health Certificate is the form that provides information about vaccinations, as well as other information about the health of the children that parents are required to bring into school.
Yes.
Required, but again, there's no enforcement. And so not all parents do that. So it's a paper process right now, requires them to go to the doctor, get that paper, bring it to the school. So we want to make that a digital process to make it easier on people.
Yes.
So we are very close to having one where at least it's an electronic process at the provider level.
Okay.
The provider can go into the electronic health, or can go into his electronic health record, say, print this out, and there's a piece of paper then the parent brings in, so the provider doesn't have to fill it out by hand. We are also working on a longer term process where it goes directly electronically from the provider's electronic health record into our system, so that the parent doesn't have to carry that piece of paper into the school. So that's going to be a couple of step process.
Okay, so where are we on step one or phase one? Let's call it phase one.
You know, we are, I've sort of seen the first draft of what the electronic form looks like. So we're close to deploying that. But I think that the fully electronic process, we're probably a few months away.
Okay, but let's focus in on phase one. So what will happen with phase one? So I take my kid for her annual visit. she
Right.
gets shots or not. Her pediatrician says, do you need the health form or the daycare form? I say yes.
Right. Actually, I realized that there's more options that I mentioned earlier. So the big providers in the city, Children's, have the ability right now to say, great, and they go to electronic health record, they click a button, piece of paper spit out, parents has that. Okay.
Yes.
So that's an easy process for them. We're also setting it for other healthcare providers that they can go online and just fill out an online form, and then that goes directly to us. So then the parent doesn't have to carry that piece of paper and doesn't get lost there. So those two, so the Children's spitting out a form from the electronic health record, that's in place now. The
Right.
provider entering it into our portal, we're close to that, maybe a month or two away from that. And then the fully electronic process where it could go from big providers like Children's directly into us, that's several months away.
Okay, hold on. So what you described, phase 2, we're gonna call them phases because that would make it easier.
Okay.
Provider entering the portal. Children's isn't a part of that?
Any provider can participate in that.
Okay. But what will I have to do as a parent under phase 2?
No matter what, the parent is going to have to go to the provider, make sure the child is examined and say, this information needs to go to my school.
Right. So here, let's back up. Let's use me. My kids, their pediatrician is at Children's. So right now, when we go, I get a form.
Right.
But then it is my responsibility to take the form either to the daycare provider or to the school.
Right.
At what point will I, as a parent, not have to do that?
That's probably several months away.
Okay. Okay. So on phase 2, though, you said a provider entering the portal.
Right. So right now, if you go not to Children's, but to a private provider, he's going to actually have to take a paper form, write it by hand,
Yep.
hand it to you, comes to us, and then we have to do the data entry on our end.
Mhm.
Phase 2, what's going to happen is that provider can go and key it in, and then it gets directly into ours. So you don't have to carry that form to us.
Okay.
What may be helpful, we can map out what our planned process is going to be.
That would be great.
And send that to you.
Okay. Because what we really want at the end of the day, and I know this from the school end, is that they have to sit there and do the data entry for 500 kids and for some cases, if it's Children's, great, it's nice and printed and you can read everything. For other providers, they have to translate and decipher what all of these various things mean. But even still, the lost in translation, it would be ideal if the systems just spoke to each other and families, the only responsibility you have is getting your kid to the appointment and we take care of everything on the back end. When you say several months, what's the definition of several?
I can't be more specific than that. I can get back to you with that.
Okay. So as something for a follow-up, if we could just have a plan of action, here's where we are, here's where we hope to be by this time, and here's where we hope to be by this time. It doesn't have to be exact, but I think that will help tremendously because the whole thing with no shots, no schools was literally around, we can't enforce it because the paperwork isn't right.
So let me just say, for immunization data, there are other electronic channels for that to travel. And those are in place right now. So the vast majority of providers in the district have an electronic health record. Those electronic health records are mostly connected to us automatically. So that flows into our immunization registry automatically. There are some that are not that connected to us electronically. And so those parents need to bring them in and that would need to be key punched in. There are other children who were vaccinated in other states. We may not have that record, or they were vaccinated in Maryland at a provider that didn't submit theirs to the Maryland immunization registry. But overall, 85, 90% kids were probably getting that data electronically. The process we just talked about for the universal health certificate helps bring in the rest of that information, health information beyond vaccinations.
Right. Okay. So when you receive the information on vaccinations, how are you all sharing that information with schools?
Schools have what's called an immunization compliance portal built in Salesforce. There's a designated person in the school who's their point of contact, which we give authorization to. The person logs in. When they log in, it is literally one click, and then they'll see a list of all the kids in the school with whether they're compliant or not, and if they're not compliant, what vaccines they're due.
Okay, so you all have made it very simple. Yes.
Yes, what I was going to add is that most recently, we have also posted on our website the compliance ratings for the different schools.
Fine. On the website, though, your website, you know, the house website.
Carl will send you the link.
Okay. All right. On school nurses, really quickly, we share, or we try to, we share information with the rest of the committee and the rest of the council, the pre-hearing responses. And the pre-hearing responses, there was one elementary school that you all reported that had 0 hours of nurse coverage each week. And I want to know if that's a typo. It's Garfield Elementary in Ward 8.
Let me look into that. Get back. I don't
It
think
was
that
the
there
only one
it shouldn't
across,
be.
and I was just like, that seems
That's probably a mistake or some sort of miscommunication.
okay. All right. Let's talk about HASTA. Thank you, Dr. Farley. Oh, hold on one second before you go. Okay. Is the DC Alzheimer's plan under you?
Yes.
Okay, great. Wonderful. Hold on. When can we expect an updated plan to be published?
That is very soon.
Come on, y'all. Very soon, several months. Let's be a bit more specific. Who's the person?
And it is under me, and they told me earlier today. I just don't remember, and I don't want to commit to something that I can't produce.
Okay. Okay.
By the end of the fiscal year.
September.
Yes.
Okay. You all had 170,000 to adopt regulations for dementia training for direct care workers. But that was not spent in FY22. Why?
Yes, that program is under Sister Administration, Health Regulation and Licensing Administration. I will say there was a number of activities that were started as it pertains to this, but what we realized is that we first needed to have regulations. So regulations are in the process of final draft. Once they have been finalized in draft, the attorney will then share that with the program will review, and then we will move to our next steps. I will say with that said, is that we have had some calls with our Veronica Demerson Sharp and her team, because it does affect, not only nursing homes and assisted living. I've had some brief conversation with the Home Health Association as well, to let them know that this is coming forward. In addition to that, one of the members of our Board of Nursing has also done some research on various certification programs for dementia. So we've done a lot of activity, but we must first have the regulations. So that's what we're waiting for.
Okay. In that same regard, also around Alzheimer's, DC Health had budgeted 250,000 to promote its new website for Alzheimer's resources, and that money was not spent.
That campaign is being developed, and it will be running soon.
Okay. Was that money from FY22 or FY23?
Money, I believe, was FY23.
Okay, so I think that money was from 22. So the question I have is, do you have money available in 23 for this work?
So there was funding to develop the website.
Yeah.
And then there was a separate pot of money for doing a media campaign to publicize the website.
Yep.
And
So is the website done?
The website is done.
Okay.
Absolutely, yes. And
So now we're just gonna
very
promote
proud.
it.
Just have to promote it, and the campaign to promote it is being developed. It should be running this fiscal year.
Okay. All right. Awesome. More questions about that? actually, before I go to Hosta, I'll go back to primary care. And this is also sort of a workforce question. You all reported, I think in your pre-hearing responses, that the district needs 96 additional primary care providers who accept Medicaid to meet the needs of residents. On Tuesday, I asked the board chair for psychology and the board chair for pharmacy, Dr. McCants happened to be there, but I was asking more specifically to Dr. Jimenez, how do we get more of your providers, more of your licensees to accept Medicaid? And he spoke very transparently that the reimbursement rate was an issue. And I'm wondering, and I suspect, right, for some primary care providers, that is the same. And so one of the things that was very shocking to me and a little bit like we got to work more together is the fact that the board chair said, we haven't talked to healthcare finance in a while. Right. And that's not on them. That's on healthcare finance. But to what extent does DC Health play that role of bringing these agencies together to have these conversations around the realities of, we're telling you we need more providers, and the providers are saying you're not giving us enough money. So how are we reconciling to meet the needs of the district?
What I will say is that there are a number of conversations that are had, and of course I would want to have our sister agency in-house to really address this. I know that healthcare finance does have meetings with various provider types. So I don't know if they have or have not been at the table, or have been invited or not invited, or have asked to be present at the table. What I will say is that I'm willing to reach out to our sister agency to see if we can start initiating conversation.
Yep. That would be great, because I think it goes to equity, health equity. And, you know, I think we've heard this from other providers, right? They make more money from telehealth, right? I don't have to go out. I could do it from 45 minutes, you know, from my home office and make way more than going out to a school or to some community-based organization, et cetera. But we have to sort of figure it out. And I know that there are limitations in terms of what the federal government is going to pay for, but we also know that the needs are great for our residents. And so if I have all of these individuals who are getting Medicaid in the district who have mental health concerns, because we've seen that as an increase from the pandemic, but I have no providers who are taking Medicaid, how do we meet the needs? And then we see them manifesting in other places. So I definitely want us to work on talking to one another about how do we increase access. Okay, now for real, I'm going to go to Hosta for real this time. Thank you, Dr. Farley. DC Health reported that 80% of new HIV diagnosis in women occurred in Black women, and that in FY23. DC Health is providing many grants targeted to this population. What type of projects and organizations are eligible for that funding?
Mostly community-based organizations who their target populations are Black women who are already serving Black women and have Black women in their doors already, who they can provide enhanced service to. We're looking for providers who aren't currently funded for service already, so smaller organizations, maybe some that aren't as, what's the word I want to use? Savvy in how to get grants and that kind of thing, but have a large catchment of Black women already.
Great. And how much total funding did you all make available?
$75,000.
How much has been spent already?
We are working on awarding them many grants now.
Okay, but the applications are out and you reviewed them?
The applications are out. We are reviewing them now.
Okay. DC Health is reinstituting its Youth Sexual Health Advisory Board in FY23. Why was this discontinued?
COVID.
Okay. I think this is an excellent time to bring it back. I think you saw the CDC reports on the Youth Risk Behavior Survey. I think they come out with the district data in April. So we'll see a little bit more of DC, but we have a number of young people who testified. And then also some of the data that we're seeing, right? Like, I think that this is incredibly important. As part of reinstituting, how are you recruiting members to serve?
So we are working with schools. We're actually starting in middle schools this year in this version of it, in 8th graders, to try to catch them before they go to high school.
Okay.
To be able to reach out to their networks and do some health education, peer-led health education for youth. We also have some of our peers from before COVID, before everything had to stop, who are still actively, communicating with us and engaged in different ways, but engaged. We also go to the schools and recruit from there.
Okay, great. Are you guys aware about the new health standards that are being implemented in schools in terms of sexual health?
We have gotten a heads up. We haven't seen them, but we work with OSSI to do some of this work. And so we anticipate that they will get them to us.
Okay. I think that's interesting that you guys weren't engaged as an agency for this. I'm a little skeptical now. But nonetheless, I think it's important that we're kind of aligned though, because at least my understanding of where they're going with the health standards, we're going to be talking to a younger population based on the data. And so when we think about some of our peer education and supports, I want to make sure that we're not just focusing on high school students anymore. We really got to get into these middle schools and talk to these young people as well.
We work really well with OSSI. Okay. And so when we began the talks last summer to re-engage the youth-based services programs, we talked about engaging a younger group. That's why we're going to middle schools now. We've actually started some outreach. We were at Jefferson Academy last week.
Oh, great.
We'll continue to do that outreach and start to lay the foundation for some of those partnerships going forward.
Okay. And when do you hope for the first meeting to be for this group?
We hope to have everything ready to go. We're going to do some trusted adult training this year before the school year ends, but have the youth board completely ready to go for the next school year.
Okay. For school year 23-24.
Yes.
Okay, great. DC Health provides funding for several housing programs for people living with HIV. Several of these programs are federally funded, like the HUD funded Housing Opportunities for People Living with AIDS and the CDC funding PrEP housing program. Does HOSTA use any local funding for housing programs?
No.
Okay. Are there a waiting list for any of the federally funded programs?
We do not keep a waiting list. There was a waiting list at one point several years ago, but it was disbanded because the way that HOPWA runs is that and this is probably morbid to say, but if people don't pass away, there's no way to add someone else to the list. And so there was a long list that couldn't be moved, which is why we decided to create some of these other programs that you see in the response that we sent that can provide shorter term support to people to get them up into housing, to help them with education and workforce development, to make them sustainable, to be able to sustain their own housing moving forward, because we can't sustain HOPWA as a lifetime entitlement anymore.
Okay. Did it used to have local funding?
Not that I'm aware of.
Okay. Okay. How does DC Health work with DHS to ensure that people experiencing homelessness? Well, never mind. I'm answering my own question. You're telling me there are no slots available. So doing outreach to make people aware of these housing programs is.
I will say that we do use the same unified entry point. Okay. So that when people go to the entry point, they get access to whatever is available. Okay. So we fund the same entry point so that they will have access to our programs as well as the DHS funded programs.
Okay. It appears from the responses to the committee that the district generally does not spend down all of its federal funding from the Ryan White HIV/AIDS program in each fiscal year. Why is that?
There are a myriad of reasons why we don't spend, but I will give you some. One is provider capacity, especially with COVID. We've seen a significant shortage in workforce. When our subrecipients allocate their grant funds and they put it in salaries and then they don't hire, then they have to move that to another line. And if they can't hire, then that money gets turned back to us. And so a lot of times we will try to reprogram it like halfway through the year as we meet with them and they're monitoring to say, okay, what else could we use this money for? but they're usually very confident that they're going to hire and they don't want to move that money to someplace else. And then we get towards the end of the grant year and they're not able to hire. That's one big reason. The other thing is that we fund an eligible metropolitan area, and Ryan White has to be the payer of last resort. So if there's any other program that can pay for that service, those funds have to be used before the Ryan White funds can be used. That is legislatively mandated in the Ryan White legislation in Congress. And so that leaves money on the table when, like, there's lots of money for opioid and mental health and all these other things that we know people need.
Right.
But the Ryan White funds can't be used until the other funds are expended.
That is such a Congress move. They do that on lots of different programs. So that makes sense. But I think you're bringing up a reoccurring theme across all of these hearings. This is the last performance oversight hearing for health, is around workforce pieces. And it just brings up the question around, like, there were two young people who spoke today who were like, yes, I'm going to school. One, she's like, I'm going to nursing school. The other one was like, I'm going to school to be a therapist. How are we introducing more young people to the health professions starting middle school, high school? I think lowering the age for the CNA program is going to help, right? Because you're going to have some of these high school kids who can take part-time roles and then see this sort of as a path. But this kind of came up a little bit yesterday. I don't necessarily think of health professions from a vocational ed perspective, because for many of the health professions, because we require degrees, examinations, certificates, et cetera, it's not as though you can just like go through a high school program and then go off in the same way as like some of the trades, plumbing, steel, et cetera. But are we having these conversations with our public schools around, like, here are all these jobs that are coming available in the health perspective. Help us help you.
Interesting enough that I would say we took advantage of Thursday when you had the board hearing. Some of the board members were, as you know, there at DC Health, and that was part of our conversation. How can we get more information out to people, to our youth, about opportunities, career opportunities in healthcare? I think that we will have to strongly engage even the associations in doing so. So I think it's going to have to be a collaborative effort in trying to make sure that we get more information out. I think that even when they have they need to see us as well.
Yeah.
I know that at DC Health, we have opportunities where we can bring in interns and they shadow us, and to see the different things that we do. For example, I'm a nurse, but I'm not in a typical nursing position at this particular time. But so there's other opportunities. You can start here, you can do different things. Same as laboratorians, sanitarians. There are many roles, because even at DC Health, even for example, we talked about sanitarians and food. We have sanitarians that inspect our pools. So there's a wide range of opportunities, but to get those, to make that awareness available. So,
and I mean, I think some of this is important because as we learn about some of these, there are technical skills that are necessary. Like, I remember when I first went to a hearing for the Office of Unified Communications about 911, and I asked, okay, why can't y'all find people? And they're like, well, you got to know how to type. Oh, okay. We don't teach typing in schools anymore, right? Because we assume that everybody has a cell phone, so you don't need to learn how to do it. But for this specific job, you have to be able to hear information, type it, get it right, relay it. You may have to deliver a baby over the line. Like, it is a technical skill that is required there. Sanitarians, I didn't realize in addition to the exam, they told me it's biology, it's all of these other pieces. It's technical. It's not just walking into a room and observing what you see and checking some checkpoints off the list, but there are pieces to that. There was another job where, like, they had issues with drug testing people and the cannabis, and they're like, well, it's legal. And I was like, well, no, this is a safety sensitive position, right? So there are all of these pieces that I feel like if we inform young people early enough of, like, here is the path, choose your own adventure, but start early on said adventure around these are the courses that you need. These are the skills that you need. Don't do that stupid impulsive thing that you're thinking of. That's going to put something on your record. That's going to impede you, you know, all of these different pieces. So I would love to work more with the boards and with DC Health around how do we do that from a promotion standpoint, because even in the mayor's comeback plan, health and life sciences is a big one. Life science in particular is like the one industry, well, I'm gonna say this, but you know, obviously there are caveats, like it's one of the industries that you're really not supposed to do from your house, i.e. you're not supposed to do a lab from your house. You know, you're not supposed to be dealing with chemicals at your house in your basement. We know that happens, but nonetheless. Okay.
Can I just add a couple things there?
Yeah.
We do have programs where we fund community health workers. And so they can be people of lived experience that then we provide training to and embed them in community-based organizations, giving them a government job on their resume as a training in hopes that they get hired, or to promoting them to get hired at the site that they're placed or at another site. We also have.
Do you have vacancies? Do you have openings?
We will. They run in 6-month catchments. And so they're like cycles. There are classes of them.
Okay.
And then we do fund our community partners to be able to have community health workers. We also have some interns. We provide experiences for capstone projects for university students to get experience inside the Department of Health to be able to understand how it works and hopefully love it and come work with us.
Okay, great. I'm on my final little bit here. So budget, I have a couple of budget related questions. DC Health had a lapse rate of 11% for its FY22 grants. In your responses, DC Health explains that this is due to turnover, vacancies, unobligated funds, and underspending by subrecipients. How are you all working to reduce this lapse rate for 23? I know it's a very general question because everybody has grants across the agency. So Dr. Lewis and the Fletcher.
I think Clover did a great job explaining to you what the problem is that we're experiencing throughout the entity. The problem she expressed that HASTA is experiencing, all the sub-recipients are experiencing. Difficulty in hiring, the difficulty then in getting not just staff, but qualified staff to work for them. They have the same supply chain issues that we had for their contracts. So that's what we see. Typically, we're not in that level. We're not at 11%. We're normally in the about 5 to 7% range.
Okay.
So that was an anomaly, but that we hope will not be repeated.
Okay. In your responses, DC Health reported that for the ARPA-funded youth vaccination incentives funding, you only spent $900,000 of the $3.62 million total allotted for this purpose. What are your plans for the rest of those funds?
How much? 900,000?
Yeah. So these are the youth vaccination incentives.
Yes, I remember. It's like
we were giving.
I thought it was like $4 million. And some of it was spread to schools, to RC, to have vaccination incentive programs.
Yeah, but you only spent 900,000 of it. So where's the rest of the money?
We have we're going to spend a little bit more, not a lot more in FY 2023. And as we're winding down the vaccination programs across the city, those correlate with that. So it won't be a lot more than what was spent in 2022 that we've reported.
Okay, but how are you going to reprogram it then?
ARPA funds will dissipate.
It's not dissipated. It's ARPA. We got this money till 24.
So you get an allotment, and what you don't use, you return it. You return it to the city, and then the city will.
Oh, the larger pot.
Absolutely.
Okay, so I'll talk to Jenny Reed about that one. Okay, all right. DC Health reports a $27 million balance at the Howard Centers for Excellence, and an $8.5 million balance in ARPA funds for the centers. What's the plan to spend down this funding?
So the Centers of Excellence have an allocation through 2026. They have received about 12 million to date. About 12 million to date, are projected to spend by the end of this year, somewhere in the region of about 10 million. Clover mentioned that every time we talk to a provider, they are aiming to spend everything. But that's what the projection we're hoping for. Now, we have a non-lapsing fund, so what they don't spend becomes available. That money is designated for the 5 centers of excellence, and they are both operational and startup costs that are distributed over those 5 years for the centers of excellence. So what we will do is what they don't spend this year, they will get to carry into the future years.
Okay, but that's through 26.
Mm-hmm.
So at what point, again, because I don't like to give money back, at what point do we say, okay, Howard Centers of Excellence, it doesn't seem as though you were going to spend all of this, so we're going to redirect this to another program who can use this funding?
So right now there's a district law that says that they get X amount of money.
The district law?
Yeah, that they are due to 26 million over the course of that period for these particular projects. So DC Health is at this time bound by that.
Okay. There were several grants in your responses that caught our attention. MCH Ventures, Mommy. They were awarded $650,000 grant to integrate electronic health records, but didn't enroll as many people as expected, only serving 637 out of the 10,000 people targeted. What happened with this grant?
It wasn't continued because they didn't perform well.
So you discontinued that grant?
Yes.
Okay. So this was this local money or federal?
I believe it was local money.
Okay, so it's already gone. Okay. DC Health awarded Howard the federal grant of $661,000 for the WIC program. They only spent $332,000. Obviously, we know that you have moved on in terms of no longer having Howard as a site. But what have we learned from what happened with that experience? Like, how are we making sure that future WIC sites are spending, are doing the necessary outreach, are meeting?
Yeah. And just say, I mean, we do have oversight on the other WIC grantees, and they are performing well. I'm not sure, Keith, you want to add to that?
Yeah.
Sorry,
there are only 3 chairs at the table.
Oh, no problem. The WIC grant is an anomaly in the grants that we have, in that the WIC grant earns a rebate. So I think the allocation in 22 is about 14 million, of which about 10 is for food. But we spend and then we get a rebate, and we must apply the rebate against expenses. So we actually spend about 16 million. But when you apply the rebate, and the rebate tends to come after the fiscal year is closed. So when you apply the rebate, and so if you look budget to actuals, you might see 14 to 7.
Yeah.
But the reality is the spending is a lot more than that. And that's the only program that we have. So that's the one grant that produces that anomaly. When you look at it, you think that spending is really low. And that's not to diminish whatever Dr. Farley said with respect to that particular site.
Okay, so let me ask you a question from a grant administration perspective. When you have a grantee that provides or that has a period of unsatisfactory performance, that's documented, obviously, but how does that performance play into future grant cycles?
So we do, first thing, we don't write off anybody. First of all, we do corrective action plans. We provide technical assistance. When we've reached the point where we are no longer going to engage any one of those particular partners, and I think we have something to the tune of 170 something different grants running at any point in the fiscal year. Once we do that, we have a system that when you're applying through, we categorize that subrecipient similar to how you do with a contract. And then that plays into the fact of whether they will get resources. Again, it depends on if it's for the same service, if it's a different service, how they've reacted to that particular RFA. So there are a lot of factors that come into play when we decide how we rank them for any future funding.
Okay, that's good to hear, because I feel like in some parts of our government, one of our biggest issues is documentation. We don't document when we have an issue, and then we end up using the same person again. and we continue to have the issue. Now, I'm not saying that specifically about grantees. I guess I'm speaking more in terms of contractors.
Absolutely.
And so we need to get into a practice of documentation. And on the contracting side,
Absolutely.
getting our money back when things continue to go awry. You all reported a spending pressure of about 1 million as a result of the new contract for animal control services. What's the pressure? Why the pressure?
So our projections were that the cost of the contract would be about $6 million, $5.9 million for FY 2023. $1 million was reduced from that contract by council before it became appropriated. So our appropriated budget is $1 million shorter than where we anticipated it would be. And what we're seeing now is a realization of that.
Okay. What is the process of the new location?
So there are a lot of there are a lot of partners that we're working with. We're working with DGS now to locate a site, and we're working with our contractor as well. So we're making sure that the site will meet all the needs that we need to have. But we have, and it's not something that has been overlooked. We've been working on this now for about 24 months.
Yeah.
We actually got 4 sites, selected a site. When we were moving through the process to finalize that site, the person pulled out, the owner of the site pulled out and chose a different option. And so we were back to square one. And so that's where we are right now. We're continuing to work with our district partners to identify a site. We all know the urgency of that.
Okay. Because every time I drive by that shelter on New York Avenue, I'm like, poor things. And it's one of those situations that's kind of frustrating because we have the money, right? The money's already budgeted. So we just need to find a site.
That's
who's the driving force on this? Like, isn't the DGS hearing going on right now? Do I need to go talk to Keith?
No, I don't think you should talk to anybody. I mean, I should never be the one to tell you who you should talk to. But any questions you have relative to that, we can follow up with you on those.
Okay. And let's keep talking in terms of the contract piece. I don't think many of the public realize that DC Health does animal control, or at least that you have the contract piece for that. And when we get the emails about rodents, pit bulls, X, Y, or Z, we want to be able to meet the needs of residents on that. And so this spending pressure piece, I think, is a concern. And I didn't realize that it was a council inflicted.
So one plug to the rodent team, we respond in less than 3 days to every complaint we get.
So that is separate. The road
And 2
map.
separate components,
Yes.
yes.
Two separate divisions.
So rodent is
within HRLA, Health Regulation and Licensing Administration. 2 separate.
one is internally managed by.
Perla, y'all deal with animals, y'all deal with
Yes.
rodents, you deal with food,
Yes.
you deal with licensing.
Swimming pools.
What else?
Swimming pools.
Facilities.
Yes. Everything. Practically everything. Yes, swimming pool.
Swimming pools.
Yeah. Radiology. It's the list goes on.
Okay, all right, give me just a second. Okay, well, I'm done with my questions. Let me just look to. There's nobody else in the Zoom, so let's go. I want to go over the list of the follow-ups. I'm gonna say it out loud on the record so we all have it. We'll send it via email, but so that everybody has what we're doing. And then I have a couple of things I need to say on my end, and then we can all get out of here and have a great night. Okay, so here's what I have on follow-ups. A breakdown of the budget for the Public Health Crisis Response Cooperative Agreement grants. The number of providers who have taken advantage of the expanded eligibility for the Health Professional Loan Repayment Program. I think that was out of the conversation for Councilmember Gray. The status of the medication aid training rollout. An answer on the Social Security number requirement for health professional licenses. DC Health's position on the feasibility of a 24-hour harm reduction center. A Breakout of the risk levels for the food businesses, how many are high, medium, low. I don't even know if that's the rate, but something to that effect. And understanding on terms of why the approval rate for shared kitchens is so low. The N size for the preterm birth reduction initiative pilot, so we can understand a bit more about the successes there. Lidl and Aldi and sort of the conversations we're having around WIC. Sharing a copy of the school nurse handbook once it's released. And then a plan for the electronic digital universal health form rollout. And then you have one follow-up for DMHHS about the healthcare workforce task force report. Obviously, there's some other reports. I think Carl has a list of links of reports that are already published, and that's what I have. So those are all of the questions that I have today. Okay. So for anyone who was not able to testify or speak at today's hearing, we will accept public testimony until March 16th at 5 p.m. You may submit written statements to Ashley Strange at astrange@dccouncil.gov, or you may leave a voicemail at 202-430-6046. Again, 202-430-6046. If you leave a voicemail, please remember to speak slowly and to spell your name for the record. This concludes the performance oversight hearing for the department. Thank you so much, Dr. Lewis, to you and your team for being here to answer questions. Again, I think that your team across the board deserves a tremendous amount of praise for the work that you have done over the past 3 years. And as we're thinking about our next stage in all of our public health emergencies, et cetera, I think it's crucial that we continue to communicate and that we make sure that the public has the information as we are sort of rolling back on some of these things. But I have been to a number of the COVID centers. That's where I got my booster. That's where my kids got their shots and their boosters. The utmost professionalism from the individuals who've been staffing those sites. And I know that sometimes it can get a little daunting or disheartening when you're sitting there all day and maybe 2 people come in, or 1 person comes in, or you see no person, or you have a list of, little kids running around trying to get their shots. But when we needed you, the public health workforce in the city definitely answered the call. And so I want to say kudos and thank you so much to all of you on the work that you did there. In terms of budget, for those who are listening, we are making some adjustments on our schedule, not for government witnesses. We are making some adjustments as it pertains to public witnesses because we want to give people the utmost time to participate. And we don't necessarily feel that 12-hour hearings are healthy. So we're going to be splitting some of our hearings coming up. And DC Health is going to be one of them where we have public witnesses on one day and the government witnesses on another day. So that hopefully can help us have a more fruitful conversation. So we'll be publishing all of those once it's finalized by the council soon. The mayor's budget comes out on March 22nd, and then we will go from there. So, but until then, the time is 6:17 and this hearing is adjourned. Thank you so much.
Thank you.